the mnemonics of the branches which are arising from the cord. The lateral cord gives branches to lateral pectoral nerve, musculocutaneous nerve, and the lateral root of median nerve. The posterior cord gives branches by the name of mnemonic, upper subscapularis, lower subscapularis, nerve to latissimus dorsi, axillary nerve, radial nerve. The medial cord gives branches, medial pectoral nerve, medial brachial and antebrachial cutaneous nerves, then ulnar nerve and median root of median nerve. So what is more important in this case is the branches arising from the roots and the trunks. So there are two branches arising from the roots, the dorsal scapular nerve and the long thoracic nerve. From C5, dorsal scapular nerve from C5 and long thoracic nerve from C5, C6 and C7. There's only one branch from the trunk, suprascapular nerve. There are no branches from division. Then cords, we have discussed the branches. So there's a lot of confusion in literature regarding the timing of intervention, but the principle remains the same. So first and foremost principle, two important principles are establishment of early diagnosis and identifying the level of and the severity of the palsy. So we all have been reading about the Narakas classification. When a child comes to us in a clinic, we by the characteristic Vater's shape position, we come to know that the child is having a brachial plexus palsy. Now we examine the tone of the muscles. Before examining all these things, first and foremost, we'll like to take the maternal history. So maternal history, a detailed maternal history is taken in the form of whether the mother had diabetes, whether she was suffering from preeclampsia, whether the labor lasted long, whether the delivery was normal or cesarean, whether the vertex presentation was there or breech, is any history of shoulder dystocia. So these are the important maternal history that we need to take it. So once the maternal history is taken off, then now we need to come to child to examine the child clinically. So once we have inspected the child, that the child is having a deformity, now we would like to inspect the other things in the child, like starting from the neck, whether the child has torticollis posture. It can be a true torticollis posture, which is associated with obstetric brachial palsy, or it is a pseudo torticollis, which is associated when the child keeps his neck in the opposite direction if he is having a brachial plexus palsy. We inspect for the ribs, whether there are any fractures associated with brachial plexus palsy, which can lead to pseudo palsies. Whether there is any scapular winging or absence of rhomboids, or if there is any involvement of suprascapular nerve. So I told you in the anatomy that these are the branches which are arising from the roots and the trunks. So involvement of these branches indicates upper plexus lesions or involvement of the roots, which indicates a worse prognosis. Then we need to examine the diaphragm. If there is any involvement of the diaphragm, we can identify or we can guess it that there are chances of root avulsion, because diaphragm involvement is indicative of higher root avulsion. If there is any doubt, we can get the ultrasound of the diaphragm. Then last and not the least, Horner syndrome. So there are 4 signs: ptosis, meiosis, anhidrosis, and ophthalmos. So we all know this Narakas classification. I've gone through the literature, so there are different types of Narakas classification. Some have classified into 1, 2, 3, 4, some have classified into 1, 2, 3, 4, 5. Anyways, it doesn't matter. So the idea is the involvement of the nerve root, whether the C5, C6 nerve root is involved, which is the classical Erb's palsy, whether the C7 nerve root is also involved along with C5, C6, in where we can see a classical Vater's shape position. Then the whole plexus involvement along with either without without Horner sign or with the presence of the Horner sign. So all these things will lead to an idea whether the recovery is likely possible. If the C5, C6 nerve root is only involved, then there are very high chances, almost 80% chances of spontaneous recovery. In C5, C6, C7, it is an intermediate case where we can have an intermediate outcome where we can again wait for a few months to look for the possible recovery. If the whole plexus is involved with Horner signs, then the chances of recovery are worst and the prognosis is also worst. So rule out other DDs as I told you: fracture pseudoparalysis, congenital aplasias of roots of brachial plexus, congenital varicella, cerebral palsy. Cerebral palsy can also present monoplegic like this, but in cerebral palsy the tone will be spastic, while in brachial plexus it's a flaccid thing. then intrauterine nerve compression by umbilical cords, or deformation syndrome in bicornuate uterus. The third and fourth important principle are whenever you have identified the brachial plexus injuries, start early passive gentle range of motion exercises to prevent contractures irrespective of your further managements. And when the child comes to your clinic at around 3 weeks, 4 weeks or 1 month of age, you should call him for regular clinical examination and identifying the patients in need of early intervention. So it involves a multidisciplinary approach involving physiotherapists, plastic surgeons, orthopedician. So there have been multiple scores which have been given by multiple people, British Medical Research Council grades, Gilbert, Tassin system. We'll discuss in brief all these scores. Mallet scoring, Gilbert's system for shoulder, Birch triple system. All these scores are very difficult to assess in infants. So we use these indirect provocative tests, Moro's reflex, asymmetric tonic neck reflex. Then we have 2 tests described called as the cookie test or the towel test, where you give a cookie in the child's hand and ask him to, we cannot ask him obviously, but then we'll just observe if he can take the cookie to the mouth or not. And then there is a towel test. We'll keep the towel on the face of the child. And if the child is able to remove that towel without bending the neck more than 45 degrees, then it's a good sign. So we have all been reading this MRC system since our MBBS days, where the power is graded from 0 to 5. 0 means no contraction and 5 means normal power. But the fallacies of this MRC system is we cannot ask the child to flex it against resistance. Therefore, the Gilbert and Tassin, they come up with a newer system where they test the movement of the joints against the weight of the hand of the own child. So, but again, the Gilbert-Tassin system has a drawback that it did not quantify the range of motion. Then the Toronto muscle grading system came up.
Dr. Nitish,
yes.
1 minute remaining, please.
Okay, sir. I'll move it fast. So we all know this mallet score, which quantifies this active abduction, external rotation, hand to nape of neck, hand to mouth. Then microsurgery and at appropriate time. So when we diagnose the obstetric brachial plexus palsy, we'll wait for 3 months for abduction to return. If the biceps return, we'll continue with physical therapy until age of 2. If the biceps did not return, and there are Horner syndrome is present, we'll go ahead with the microsurgery. If there is no Horner syndrome, we can continue with physiotherapy and then look for the another 3 months. So then last 2 principles are regular physiotherapy to prevent secondary deformities and secondary procedures and residual deformities. So I'll not go with the shoulder. So, shoulder will be discussed in the next session, next speaker. So then we'll go to elbow deformity. So there are, just give me 2 minutes, sir, extra. There are 3 types of elbow deformities. First is weakness of elbow flexion. Second is flexion contracture of the elbow. The third is paralysis of elbow flexion. So there is a Steenler's procedure where we relocate the flexor pronator origin to the anterior mid-surface of the humerus. For this to be effective, the patient should exhibit the Steenler's effect, where he flexes his wrist and flexes his finger and swings the elbow. So here he uses the wrist flexors in flexing the elbow. If the child has got poor wrist extension, he is a poor candidate for Steenler's procedure because it will further reinforces the flexors of the wrist. If you have a flexion contractures, most of the times it is usually associated with the internal rotation of the shoulder. If you correct the internal rotation of the shoulder, the flexion contracture gets corrected. Even if it doesn't get corrected, then you can do a soft tissue release or a osteotomy. Paralysis of elbow extension is very rare. The last is forearm and wrist. Most common deformity is minimal pronation deformity, which does not usually require any treatment. Second common is the supination deformity. If there is a supination deformity and you can do a passive pronation, then you can do a biceps rerouting. If you cannot do a passive pronation, then you need to do a interosseous membrane release or a osteotomy or a biceps rerouting depending upon your preference. Most of the people prefer osteotomy because it gives a predictive results. Then wrist, you can use usual tendon transfers. As we all know, for wrist drop, we can do all these tendon transfers, FCU, pronator teres, FCR, FDC, FDS to ECRB. If there is a flail wrist, wrist arthrodesis can be tried. Okay. Thank you.
I think we have the questions at the end so that we save on time. So thank you.
I'm the moderator of this session only. So we'll take question and answer at the end of the session. Next, I invite Dr. Gaurav Gupta, who is a consultant at Child Ortho Clinic, Faridabad, to give his talk on optimizing shoulder in brachial plexus palsy.
I would be speaking. So I would be speaking on how to optimize shoulder issues in brachial plexus burst palsy. So whenever we, in our scenario, mostly when a child of brachial plexus burst palsy reaches a clinician, most of the time they say that just do physiotherapy and things will be fine. And every child can be better with physiotherapy, but we know that in contrast this is not the case, and around 30% of kids need further intervention. So I would directly start with a few cases to discuss the principles of how to manage shoulder issues. So this is a 1-year-old girl who was recovering from right-sided brachial plexus burst palsy. She presented with persistent arm internal rotation and limited abduction. So we can see that the child is not able to reach out to the toy due to limited abduction and limited external rotation. Her abduction is less than 45 degrees. Rather, she is tilting her body to reach to the toy. So she has restricted abduction and external rotation. We all know that shoulder imbalance develops quite early in infancy, and the hallmark sign of progressive imbalance is loss of passive external range. So how do we assess it? We adduct the arm and try to passively external rotate the forearm, and on progressive examinations, if it is being decreasing, that tells us that the shoulder imbalance is increasing. And so we should also assess the glenohumeral joint to assess glenohumeral dysplasia, which we can assess by an ultrasound in a kid. And on axial ultrasound, we can assess the relation of glenoid and humerus head. We can objectify it also by calculating alpha angle, which is the angle between the line drawn from the posterior border of spine of scapula and the tangent from the posterior surface of the head of humerus and labrum. If this angle is more than 30 degrees, it suggests that the child has infantile shoulder dislocation and severe glenohumeral dysplasia. Along with that, we can see the position of ossific nucleus of humerus. If it is posterior to the dorsal border of the spine of scapula, then it is also a sign of severe glenohumeral dysplasia. So, considering those things, we did Botox in the pectoralis major and subscapularis, and this is the same child after 6 months. We can see that there is a significant increase in the improvement in the external rotation of the child, and the child is able to now reach towards the head and the ear also. Also, if we can see that the abduction of the child has grossly improved. So in a kid less than 1 year with progressive internal rotation contractures and restricted abduction, Botox and Spica can help. Now another scenario, a 5-year boy with residual brachial plexus palsy presented with marked trumpeting and inability to reach behind the neck. We can see that the trumpeting, when he tries to do hand to mouth, is more than 90 degrees and he is not able to reach behind his neck. Now, in this scenario, we should assess the glenohumeral dysplasia by getting an MRI, and we have a MRI-based classification called Waters classification, where we can assess the relation of glenoid and humeral head by calculating glenoid retroversion and humeral head translation. And on the basis of that, it is divided into 6 types. Type 1 is a normal glenohumeral joint. Type 2, where the retroversion has increased by more than 5 degrees from the normal side. Type 3, where along with retroversion there is posterior humeral head subluxation. Type 4, where there is a pseudoglenoid formation. Type 5, where there is now flattening of the head and the glenoid. And type 6, where there is an infantile dislocation or a complete glenohumeral dislocation. Now, in the first 3 types, where there is only retroversion and subluxation, still there is some congruence between the glenohumeral joint, and we call it congruous glenohumeral joint. And in those cases, we can expect remodeling, and so soft tissue procedures like Botox and open or minimally invasive subscap release and conjoint tendon transfer like latissimus dorsi and teres major transfer can help in remodeling and improving the function of the child. But in cases where the glenohumeral dysplasia is more than 3, like 4 or 5, where there is a false glenoid or there is a glenohumeral dislocation, there we call it non-congruous or incongruous glenohumeral joint, and there not much scope of remodeling is there. So we have to shift to bony procedures like humeral derotation osteotomy or scapular neck osteotomy. So congruous joints, soft tissue procedures like Botox or tendon transfers and soft tissue release. Incongruous joints, bony procedures like glenoid osteotomy or humerus derotation osteotomy. Conventionally, we know that due to imbalance between the internal and external rotators, the child has internal rotation contracture, and usually anterior subscap release, anterior capsule release was done with latissimus dorsi and teres major transfer. But now there is a new technique by the name of minimally invasive subscap release, where you can release subscapularis from the posterior border of the scapula. This technique will be demonstrated by Dr. Maulin Shah later in the course. And tendon transfer can be done through the axillary approach. So now the same child, we did minimally invasive subscap release and tendon transfers, and we can see that the trumpeting has grossly improved, and the hand to neck posture has also improved significantly. Another scenario, an 8-year boy with residual brachial plexus birth palsy and severe internal rotation contracture, trumpeting of around 90 degrees. MRI shows glenohumeral dysplasia with flattening of the glenoid and subluxation of the humerus head. This is a type 4 glenohumeral dysplasia, and so we did glenoid antiversion osteotomy with soft tissue rebalancing. Here we approach the scapula from the posterior aspect, and we do an open wedge osteotomy of the glenoid to relocate the glenohumeral joint. Along with that, we do tendon transfer of latissimus dorsi and teres major. Now here you can see that there is a so this is the opening of the glenoid, and this is the graft in between. And the child was quite comfortable and tolerated the procedure well. And this is the same child after around 6 months. Abduction was previously also normal. Trumpeting has decreased. Internal rotator power is also good. External rotation has reached to around 10 degrees beyond neutral. And hand to neck movements are also have improved significantly. Now, finally, this is a 13-year boy with residual brachial plexus birth palsy, severe internal rotation contracture, and glenohumeral dislocation. The trumpeting was around 130-140 degrees. Child was 13-year-old. He was not able to reach behind the neck, and there was glenohumeral dislocation. So here we had to do humeral derotation osteotomy. And this is the same child after 6 months of surgery with good hand to mouth improvement in trumpeting, and he is able to reach hand to neck. He also has elbow flexion deformity which has been operated recently. So to summarize, our protocol is if the child is less than 18 months and the passive external rotation is less than 30 degrees, we have to rule out infantile posterior dislocation by assessing the glenohumeral dysplasia by calculating the alpha angle and the position of the nuclei of head of humerus through ultrasound. We can do Botox in subscap and pec major. If there is a dislocation, we can reduce it and put a spica. If there is only dysplasia, we can also put the child in aeroplane splint for 3 weeks and then start physiotherapy. If the child is more than 18 months, we have to assess whether he has only restricted external rotation or he has restricted external rotation and restricted abduction, or he has only restricted abduction. In cases of restricted external rotation and restriction of both external rotation and abduction, we have to get an MRI. On the basis of axial MRI, we assess whether the child has congruous glenohumeral joint or incongruous. If the child has congruous joint, we can do soft tissue release and tendon transfers or Botox. If it is non-congruous, we assess the age of the child. If the child is less than 4 years, we can again do tendon transfers. If the child is 4 to 10 years, we can do glenoid antiversion osteotomy and tendon transfer. And more than 10, we have to do derotation osteotomy. Finally, if the child has restricted abduction, we can see if the abduction is less than 30 degrees or above 30 degrees. If it is less than 30 degrees, it is deltoid atrophy and we have to do trapezius transfer to greater tuberosity. If it is more than 30 degrees, we have to see whether it improves with elbow extension splint. This concept I am not able to introduce because of paucity of time. If abduction improves with pedirap, it suggests there is anterior shoulder instability and the child will improve with pectoralis major transpositioning. But if it doesn't improve, then again it is deltoid atrophy and we have to do trapezius transfer to greater tuberosity. Thank you.
Thank you, Dr. Gaurav. It was a nice talk.
Thank you, Dr. Thank you, Dr. Gaurav. Next, I invite Dr. Ankul Agarwal, Additional Professor and Head of Pediatric Orthopaedics at Postgraduate Institute of Child Health, Noida, for his talk on congenital muscular torticollis.
If possible, I request speakers to give their talks. There's a lot of time being wasted in changing laptops. So if...
Meanwhile, we can have 1 or 2 questions.
1 or 2 questions from the first 2 speakers.
Yeah, till he sets up.
Yes,
Yeah,
Dr. Ramni.
Both the talks on the brachial plexus palsy were very good. Just a question to Dr. Gaurav. See, when you do that, when you have decided that the glenoid is dysplastic, I mean the 4th and 5th, then when do you decide, why do you do the scapular osteotomy first and do the derotation osteotomy of the humerus later? I mean, can't I do a derotation osteotomy when I have decided to do a bony surgery?
So sir, there are papers and we have also seen that less than 5 years with gross glenohumeral dysplasia like 4, remodel with glenoid antiversion osteotomy, and we also get an opportunity to do tendon transfers which increase the range, the available range. And later on, there is a possibility that the child may not need a derotation of the humerus. So we have seen this, that many kids didn't require. And also, if we do a humerus derotation early, then it can go back into internal rotation due to progressive. So yeah, so now the spectrum is changing, that glenoid is mainly being restricted to 5 or 6 years, and after that people are shifting to derotation. Yeah, yeah.
I think Dr. Ankur can start now. Yeah.
I am thankful to Dr. Prateek for inviting me to this wonderful opportunity. After I have come here after 9 years. I used to work here as assistant professor. So my talk for today is congenital muscular torticollis. It's a fairly common condition seen in outpatient department. However, we have to recognize those cases which need surgical intervention and delineate them from those which do not need it. So congenital muscular torticollis is the congenital unilateral contraction of the sternocleidomastoid muscle with the head tilting towards the shortened side and rotation towards the opposite side. It's also called as wry neck. Incidence is 0.5% of the live births, and various possible etiologies have been postulated as being familial. Fibrosis of the muscle following intrauterine ischemia, a sort of compartment syndrome, and it has been found associated with DDH, CTEV, and fairly common in breech presentation. The sternocleidomastoid anatomy, the muscle originates from the sternum and the clavicular heads and gets inserted at the mastoid process. The functions, it helps in the rotation of the head, the tilting of the head, and when bilateral contractions are there, it causes extension of the head. It is important for the cosmesis as it forms an important landmark for the neck outline. The relations are important surgically because the spinal part of the accessory nerve and the facial nerve are related to it in the deeper part, while the jugular vessels are related in the lower part. The diagnosis is largely clinical. It's a painless form of torticollis. The muscle is felt as a tough cord near the sternum. It typically gives a cock robin appearance, which was the famous Disney character used to sing in that typical posture. If it is present in severe form since birth, then there is folding of the ears and deformation of the occiput. The movements opposite to the deformity are restricted, and sometimes in milder cases, it may not be appreciable at birth. Long-standing cases develop a facial asymmetry, which is also called as facial scoliosis or plagiocephaly. Imaging is only required to rule out osseous causes and to ascertain the ones in which surgery is required. So I already told you congenital torticollis is usually painless, while acquired can be delineated as it is painful. The osseous causes include failure of segmentation, failure of formation, or a combination of both. Pseudomuscular sternomastoid tumor may be confused sometimes as torticollis. However, it might also be present in cases of congenital muscular torticollis. Other causes which may be part of differential includes a paroxysmal torticollis, which is also called as Grissel syndrome, in which there is inflammation at the atlantoaxial joint leading to subluxation. Habitual torticollis, in which there is a person has a partial or total hearing loss at one ear and develops a habit of tilting the head to listen clearly to the sounds. Ocular torticollis because of squint, and secondary muscular torticollis, which is a form of myoglossus of trapezius muscle. The mainstay of management is ruling out the osseous causes, and conservative management and surgical management are the two options. Conservative management has little stay in the management and is restricted only in the infancy and neonatal period. In this, stretching exercises are given. However, it has limited role. Surgery is the mainstay of treatment. The timing of surgery, this is important. Ideally, it should be done between 3 to 6 years of age. A too early surgery might result in recurrence because of fibrous contracture. a too late surgery may result in irreversible facial asymmetry. And beyond 12 years of age, it should be done with proper counseling of the patient because of complications. The various surgical options include a single pole release, a both pole release, a Z-plasty, or various other procedures which are less done, like endoscopic release and percutaneous release. A unipolar release is one in which the tenotomy is done at either the origin or the insertion. Only the affected head is released, while in bipolar release, both the origin and the insertions are released. It is simple procedure. The proximal scar gets hidden by the hair and the distal scar in the skin creases of the neck. It is not very popular right now because of cosmetic reasons and scar tissue retraction. In proximal surgical release, an incision is given near the mastoid process. Care is taken to protect the deep branches of the facial nerve which lie just near to the mastoid and the branches of the spinal accessory nerve which are a bit lower down. In distal release, the care is taken to protect the external jugular vein. So the incision is given not just over the skin of the clavicle, but a bit proximally, protecting the external jugular vein. Nowadays, what is popular and is in vogue is Z-plasty. In this, there is erasing of the clavicular head at the origin, division of the sternal head 2 to 3 centimeters proximal to the origin, and suturing the two, that is the clavicular head to the sternal stump. So post-operative regime is very important. Release should be followed by rigorous physical therapy to prevent relapses and also to correct the habitual torticollis which the child develops over a period of time. Self-mirroring posture, that is the child standing in front of the mirror to self-correct his posture, is important. And when the child is not doing any physical therapy, then intermittent bracing is important. The physiotherapy should be continued till the time of healing, that is at least 1 to 2 years. Complications which are obvious: injury to the neurovascular structures, a possible relapse, remnant habitual torticollis, and in late cases diplopia. Thank you.
Thank you, Dr. Ankur. So we move on to talks on Sprengel shoulder now. So I invite Dr. Ramni, Sir, Senior Pediatric Orthopedic Surgeon at Indraprasth Apollo Hospital, New Delhi.
So this is a point.
Good morning, everybody, and thank you very much, Prateek, Dr. Anil Agarwal, Dr. Gautam, for allowing me to be here. And I hope I have enough time, Prateek, because I'm combining 2 lectures. Yeah, this one. Just open it. So I'll be talking about the etiopathogenesis. Yeah, I'll open it. But where is it? So I'll be talking about the etiopathogenesis, classification, assessment, and then talk about various managements. I've been asked to talk on greens. I'll be elaborating a little bit of greens procedure and then talk about what I do.
Where is it?
Why don't you disconnect? Let me see. Let me see. Yeah. Let me first open it.
I think we need
नहीं वो इसको नो लेट मी जस्ट ओपन इट ना पहले इसमें
So till the time the presentation gets going, I think we can have a question or two on torticollis. So any questions on?
Yeah.
Any questions for the first speaker,
Okay, you can open
Dr.
it.
Nitish? Yeah.
So, what's the age at which you would recommend the surgery? How
This
how
is to
soon
Dr.
would you,
Ankur.
yeah? What age would you do the surgery
put the
in
same one.
torticollis?
4 years. Ideally 4 years, just before the child starts to go to school.
Okay.
That's the ideal I prefer.
And in the proximal release that you do at the mastoid level.
I have abandoned that. I am doing Z-plasty.
Okay.
Only in severe cases we do require proximal release as well. Otherwise, Z-plasty is sufficient.
Anybody else doing a proximal release?
See, I have burnt my fingers a lot of times. It all depends on your setup. Like mine is a busy setup, so sometimes, you know, you have difficulty in following them up the way you desire. So I'm doing a proximal release, a distal Z-plasty, and I have had very good results with this.
I also do proximal release routinely. The only thing that about the age, I would like to say that if you find that the facial symmetry is developing, then do it early.
Yeah, most of the time it's a bipolar release, and you have to decide intraoperatively. You have to continuously move the neck to see there are some fibrous bands. So make sure that your anesthetist is always there, because you're moving the neck and tube might come out. So this is one of the, I think, tips must remember for the beginners. Yes, Dr. Ramni.
Yeah, so I have a limited experience in this. So first of all, let us find out what it is. It's a congenital scapular elevation. It's an anomaly of the shoulder girdle leading to abnormal descent, altered position and anatomy of the scapula. The earliest description was in 1863, and then Sprengel highlighted this condition in 1891, associated with muscular hypoplasia, atrophy, and a combo disfigurement and functional limitation of shoulder movements. So what's the pathogenesis? It probably represents the continuation of fetal form of scapula. Horizontal diameter exceeds the vertical diameter. As you see here, you can see here, and then you have an anterior curving of the supraspinatus portion, and you have prolongation of supromedial scapular angle, and you have an omovertebral bar which is visible here, and then you have a costovertebral defects which can be there. And demographics, it's mostly noticed at birth, equal sex distribution, left side more common, may be associated with other congenital anomalies. And the differential diagnosis is rickets, osteomalacia, malunitis, scapular fractures, paralysis, cervical tuberculosis. Associated anomalies, there is a huge list you can see, right, ranging from the talipoequinovarus to anal ectopy with incomplete atresia. Then Klippel-Field syndrome in Sprengels, there is an association, congenital fusion of at least two cervical vertebra with or without additional spinal or extraspinal manifestation. Associated Sprengel is in 7 to 42%. Most common congenital fused segment in Sprengels is C6, C7, with extensive fusion patterns and thorough neurological examinations to be done pre-op to avoid complications. Clinical features, cosmetic, high position of scapula, scoliosis, torticollis, caput obsteosum, which is asymmetric distortion, and facial asymmetry, functional restriction of movements of scapula and scapulohumeral joint. And Cavendish classification is cosmetic classification. Grade 1 is very mild, shoulders level, deformity invisible when the patient is dressed. Grade 2 is mild, shoulder almost level, deformity visible as a lump in the web of the neck when the patient dresses. And grade 3, moderate, shoulder joint elevated 2 to 5 centimeters, deformity visible. And grade 4 severe shoulder joint is elevated, superior angle of scapula near occiput. There is a Rigaud classification to assess the deformity. Grade 1 supromedial angle below T2 but above T4 transverse process. Grade 2 is supromedial angle between C5 and T2 transverse process. And grade 3 is supromedial angle above C5 transverse process as this X-ray shows. Then further imaging, you can do, again, we saw this a few slides back, where you can do a CT scan and a 3D reconstruction. Here you are actually displacing, this is the vertebral axis, which is X. Then from the middle of this, middle of the glenoid, you draw a line perpendicular to this. Again, in the normal scapula, do the same. The distance between the two, the ratio between the two angles of the normal scapula and this distance, the ratio gives you the amount of displacement. And in cases of a rotation, you, again from here along the spine, you draw a line to the axis, again from the normal, and then you actually are seeing the distance which is there. So you can assess the rotation in this way. And treatment, a goal of the surgical intervention is cosmetic, functional. Associated anomalies like torticollis or scoli may limit amount of correction. Bilateral deformities or grade 1 Cavendish may be observed for progression. Cavendish grade 4 guarded prognosis. Avoid surgery in short necks with grade 4, less than 2 years of age. And best age is between 3 and 8 and for moderate to severe cosmetic or functional deformity. Presence and associated congenital anomalies may be a contraindication for surgery. Now, surgical procedures, there could be a scapular lowering by either a shift of insertion like in greens.
Dr. Ramani, please be close to the mic.
I'm too close to the mic?
No, you're not audible.
I need to be closer to the mic?
Yeah.
Okay. Okay. Okay, so like I said, it's in green, you either shift the insertion of the scapula or shift the origin in woodwards. And omovertebral bar resection is a consensus. You always excise whenever it is there. And clavicular morselization in selected cases, especially in older children. Specifics, Mears procedure has also been described, in which supralateral border and the supraspinous fossa osteotomy is done. Then resection of supromedial border of scapula, and there could be a partial scapulectomy only in certain selected cases. We'll talk about that. Lateral scapular lowering by vertical scapular osteotomy, and there could be a woodward modification. A lot of modifications have been done. Now let's start. I mean, it's going to be talked about, but I will briefly touch this. Now, this is a schematic representation where the morselization of clavicle is done first, omovertebral bone resection if it is there. Then there's a distal shift of origins of trapezius and rhomboids, maintaining correction of scapula within the trapezius pocket. And there is a Ahmed modification where a absorbable suture is anchored to the lower dorsal vertebra through a supromedial scapula. Hence, you are basically controlling the rotation and correcting the glenoid vera, which causes a better abduction. For severe sprengles till 15 years of age, you can probably do this procedure. Now, Mears surgical technique, the shaded area gives you an idea about what all needs to be resected. And subperiosteal elevation of scapular musculature, extraperiosteal resection of the omovertebral bone, supraspinous fossa osteotomy, release of long head of triceps and a portion of origin of teres minor from scapula, resection of supralateral border of scapula to gain abduction. And literature on partial scapulectomy, like Zieming, Zhang et al. In Clinical Orthopaedics and Research, he has published a paper in 2006. It's a modified Cavendish similar procedure of 1972, inverted L-shaped incision to release the contracted tissues around the medial edge of scapula, investigated how release of muscles combined with scapular resection is helpful to improve the cosmesis and function. 26 consecutive cases, divided into 2 groups according to the amount of abduction, minimum follow-up of 12 months, 59.11% improvement to the rate of abduction, holder abduction. Improving abduction and function was the main aim here. And safe and a simple procedure with no complications. Now, greens, we'll elaborate a little bit. Here, the shaded thing shows you the omovertebral bar. Resection of the prominent superior scapular border, extraperiosteal division of the muscle attachments of scapula. Scapula displaced inferiorly and muscular reattachments at this corrected level. So there is this paper by Androlt et al. Where he talks about the green surgical procedure, the cosmetic and functional results he assesses in orthopedics and traumatology. Now, reported functional and cosmetic status of green operative technique, retrospective study on 8 patients with mean follow-up of 4.5 years. He saw improvement in all. Green's technique allowed both lowering and rotation of scapula. Muscle attachments distally rather than proximally modified to provide better biochemical effect. Muscles reattached higher than acrothoraco junction. Rotation center. Results in literature same as Woodward's. Impressive operative approach and improved muscle livers distance adjustment to fulcrum. Resection of supromedial portion of scapula, which is then fixed to the rib cage into the pocket of latissimus dorsi muscle, more efficient correction. So, the green surgical procedure, there is a midline incision. You can see the patient's positioning prone, extra periosteal detachment of trapezius, then supraspinatus detached from the scapula along with the periosteum. Omovertebral bone is removed. The insertions of levator scapulae is dissected. Rhomboids from the medial border is dissected. Supraspinous fossa of the scapula resected, taking care of the neurovascular structures. Scapular attachments of LD and the serratus anterior muscles detached from the anterior scapula. Now, this is a schematic diagram where you can see the scapula displaced down as on other normal side using a supromedial angle as landmark, muscles reattached to scapula in its corrected position, supraspinatus to base of the spine, then rhomboids reattached without compromise to frontal plane, even by lengthening if necessary. One gets a good glenoid orientation, which in turn increases abduction. So, this is an elaborate, there are modifications of Green's too, which starts with clavicular osteotomy, insertion of serratus anterior is separated from the spinal border, scapular adherence to the thoracic wall is separated, insertion of supraspinatus is dissected, inferior pole of scapula sutured to the thoracic cage into the pocket of LD muscle. So these are modifications. Now vertical scapular osteotomy is something which nowadays has come in. And this just gives a schematic diagram in what you're doing. You are getting the scapula down. You are basically correcting the cosmetic thing. And you can also correct the rotation. This particular study, which was done by Aslani et al., it was a retrospective study on 22 patients, average follow-up of 30 months, vertical scapular osteotomy with or without scapular osteotomy, plus they did wake-up tests so that they made sure that there was no neurological problem. Mean improvement of superior scapular and inferior scapular angles and that of shoulder flexion and abduction was also seen. Significant, more cosmetic scapular lowering with little chance of NV complications can be achieved. Rotations can be tackled. Complex cases can be done with more predictable, favorable outcomes. So there is this, I'm just going ahead with my case, which I did way back in 2009. This is an 8-year-old girl. Deformities since birth. Father concerned only about the left shoulder being higher because he was concerned about the cosmesis. Girl had a good shoulder abduction. Plan was to only get the left shoulder at the same level on the right, along with improving asymmetry to the best extent possible and maintaining the same range of motion. Prognosis was given and girl assessed. There was no scoliosis otherwise. It was a Cavendish 3 assessment. Rigol's 2 probably in this X-ray. There was a suspicion of this and assessment. We could see some cervical anomalies. No scoliosis. Cord was okay. X-ray gave an impression of OV bar. Cervical vertebral anomalies. Cord was within normal limits. The CT scan did not show any bar, but peroperatively there were some fibrous bands which had to be removed. And no bar, but rotation was appreciated on these scans. Good abduction, as you can see, and she could do good abduction, and peroperatively, after morselization of this clavicle, this was an older child, we did this vertical split, pulled the lateral part and sutured it with ethibond, and then tucking the inferior part under the latissimus dorsi. No wake-up test was done, and the child was okay after that. And post-operatively, that's this clavicle incision, and that's the shoulder, which was pretty good. The abduction was good. So this is morselization of the clavicle. I need 1 more minute because I'm combining two. So is it okay? Yeah, I'm just finished, just last slide. So, so there was no NV deficit, shoulder same level, abductions maintained, father was happy. Take home points, Sprengel's deformity in dysplasia of the pectoral girdle, results in cosmetic and functional disability, and associated with other congenital anomalies which often dictate the management and outcome of treatment. Pre-op counseling is important after understanding the need of the family. Prognosis needs to be discussed in detail. Consider morselization of clavicle in older patients. All surgical techniques described in literature provide a satisfactory cosmetic and functional outcomes with low complication rate. Choose the one which you feel comfortable with. Thank you for listening.
Thank you, Ramani sir. Now invite Dr. P.N. Gupta sir for his talk on Woodward procedure. पता नहीं अभी तक कनेक्ट हो रहा था अभी खुल जाता है इसको निकाल के खुल जाता है पीएन गुप्ता इसको लगा दो वुडवर्ड निकाल के खुल जाता है
So good morning friends. I'll be talking about the Woodward surgery, its basis and its rationale. Okay. So pathogenesis is that the scapula normally forms at the level of C5 and migrates downwards. But in this particular case, it fails to migrate and stays up. So failure of migration of the scapula inferiorly leads to a Sprengel's deformity. And of course, this is associated with multiple other deformities. So there are two basically presenting complaints. One is the cosmesis, as Dr. Ramani has told, and second is the loss of shoulder abduction. So what are the causes of loss of shoulder abduction? If you have a omovertebral bar, you have the scapulothoracic movement missing. So that means the shoulder is possible, it is possible to abduct the shoulder only what the glenohumeral joint will allow you. The second is the inferior orientation of the glenoid. So if the glenoid is in this orientation, let's say 20 degrees inferiorly oriented, you have 20 degrees loss of shoulder abduction, but corresponding increase of adduction. But adduction, you really don't matter, it doesn't really matter. So two reasons, the bar and the inferior orientation of the glenoid. And this is an intraoperative photograph. This is not working. Showing the bar, omovertebral bar. So basis is you correct the pathology surgically, and how you do that is you take out the origin of the muscles and suture it distally and correct the orientation. So you remove the bar, you basically erase everything from the spine, including the trapezius, the rhomboids, and then you attach it distally. So prone position, neck flexed, drape both the shoulders and the arm is draped free. And we use this little tape on the contralateral side. Is it working? Yeah. Use this little tape on the contralateral side to give you a better intraoperative orientation. So that means the contralateral shoulder is pulled down. And this is the way you drape. The arm is free, you mark both the spines. You mark both the spines and you mark the vertebral levels. You give an incision. And we have done a little modification in the sense that we don't go much higher on the occiput. We go a little lower, undermine it from there and then take the muscles from there. So you have to separate the trapezius from the latissimus dorsi along with its fascial sheath so that you can attach it in a better way. And then you divide the trapezius at around C4 level transversely so that you are able to bring everything down. And then you have to release these rhomboids, which are often quite superior in some of the cases. The more the deformity, the more superior you will find these rhomboids. So you will have to release these rhomboids. You tag them. And then this omovertebral bar, which you see, you have to release it. Sometimes instead of the bony bar, you have the fibrous or cartilaginous bar. And if it is absent, as you can see here, this is a fibrous bar there and contracted levator scapulae, which is again at the superolateral border of the scapula. And if the supraspinous part or the superolateral part, superomedial part of the scapula is deformed, you resect that for a better cosmesis. You have to take care of the spinal accessory nerve. Come somewhere here. If you stay close to the midline, not many chances of injuring it. Nerve to the rhomboids. And if you go too anteriorly, then there is a risk to the deep branch of the transverse cervical artery. So you have to displace everything inferiorly, correct the rotation, and each successive sutures you bring down the scapula and tie it to the spine, posterior spinous processes. So you have to add clavicular morselization in very severe cases, especially in cases more than 8, to prevent brachial plexus compression by pulling down of the scapula. And how do you see that in the postoperative period? Pain in the arm, excessive pain in the arm, or weakness? If you find that, you have to undo the procedure. You have to check it immediate post-op. So we did a study, we published a study in 2014, and we had a mean lowering of scapular, total of 12 patients of 2.1 vertebral levels. About a third of them had omovertebral bar, but bar or no bar, eventual outcomes for cosmesis as well as shoulder abduction, they were the same. Mean preoperative Cavendish grade was 3.17, which decreased to 1.25 at follow-up. The only problem remains is, this part of the incision, which we are now sort of going it a little lower and then undermining from there. The shoulder abduction improved to about 40 degrees. Just concluding. And there was a positive correlation between increase of abduction and Cavendish grade. So we had comparison with other studies. So to basically summarize, Woodward's is a reliable method for obtaining uniformly predictable results and takes care of the basic pathology. Thank you so much.
Thank you, sir. Next, I invite Dr. Anil Agarwal, sir. He's a specialist and head of Pediatric Orthopedics at Chacha Nehru Bal Chikitsalaya, New Delhi. Disconnect करके होगा तो last time
So when we begin our orthopedic practice, okay, we learn the dissections gradually, but we know how to cut a bone, okay. So vertical scapular osteotomy is a osteotomy which we are more comfortable with, whereas the Woodwards and Greens requires extensive muscle dissection which comes with experience. So when I begin my practice in pediatric orthopedics, I did all the procedures. I found that the two requires somewhat familiarization with the procedure and experience which comes with time, but this type of osteotomy, vertical scapular osteotomy, because we are so accustomed to the cutting bones, is much easier procedures, and the results were similar. Okay, so a brief about the history, Dr. Ramni has already told about it, was described in 1980, also known as Wilkinson's and Campbell procedures. There are two main components of the procedure. One is that the bone is cut, second, the medial side of the scapula is freed. Okay, this is the procedure. So, it's a vis-a-vis comparison with other procedures. Okay, the putty procedures, there was high recurrence of deformity. Green, again soft tissue dissection. Woodward, lengthy incisions. And there are more conservative approaches which Dr. Ramani has already talked about. So, VSO is one of the viable alternatives. The indications are very specific, grade 2 or 3 deformity, restriction of shoulder movements, especially abduction, with or without omovertebral, and age 4 to 11 years. Be aware about the contraindications. Don't do it in type 4. Milder deformity, you did not do any surgical procedures. It will not help when there are severe skeletal abnormalities and the child is under 4 years. The technique Dr. Ramani has already talked about. I will just talk about two things. Cut the bone medially 1 centimeter away from the medial border. Put your finger beneath the subscapularis. Free the interval between the scapula and the rib cage. There the fibrous bands are present, and you have to release these bands to free the medial part of the scapula so that it rotates. Okay? And when you try to correct, the aim is to align the spines at the same level, not the inferior angle, because the scapula is small inside. When you keep these things in mind, you will always get reasonable results. There is no good results or bad results in this. You get reasonable results. Okay? So this is the comparison between the various series doing the VSO. You can see how much abduction we can. This procedure is mainly to achieve the shoulder abduction. The cosmetic correction may be slightly less than the Woodwards or Green, but you have not cut any muscle and you have not given the child a very big scar extending from midline to almost mid portion of the back. Okay? So this is the study we published in 2018. It's mainly related to the rib cage abnormalities, but we also shared our experience with the VSO in this series. So we studied all the parameters like shoulder abduction, Cavendish grade, Rigaud score, and omovertebral bar. Retrospective study, there were two types of rib anomalies. Try to understand that strangled shoulder is not a very simple anomaly, is just limited to scapula. There are associated rib cage anomalies. So when there are rib cage anomalies, how will the results alter? Something has to glide over an other surface. Okay? So when the rib cage is abnormal, how the osteotomy will behave, and when the abnormalities are less, how will the osteotomy behave? So there were 3 complex anomalies and 5 simple anomalies. I'll give you examples, and this is our results. So in simple, our results were better. When the rib anomalies were complex, the results deteriorated. Overall, we could achieve an improvement of Cavendish grade of almost 1.5 to 2.8, and our radiological improvement was very less. Omovertebral bar was present in 2 cases, okay, but its resection was very successful. So I give you some case examples to understand the procedure. So this is complex rib anomalies. Okay, you can see the amount of deformation of the ribs. The Cavendish grade improved by 2 and Rigaud score by only 1. Okay, you can see the follow-up. When the anomalies were simple, look at the amount of abduction we achieved, and the Rigaud scale again improved by just 1, but the Cavendish improved by 2. Omovertebral bar, particularly as Dr. Ramani and Dr. PN has also pointed out, they are the main hindrance to shoulder abduction, and when they are present, you have to excise them, and they sometimes produce dramatic improvement in the shoulder abduction. Okay, so in this particular case, we could restore the shoulder abduction to practically normal when the omovertebral bar was excised. So what we inferred from this study was that this, besides the strangled shoulder, you have to also analyze the ribcage associated anomalies, because a shoulder has to glide over a abnormal surface or a normal surface, and your abduction and results will depend upon more upon that rather than simple procedure, whether you are doing Woodward, Greens or vertical scapular osteotomy. Your results will not be that good if there are complex rib anomalies, and omovertebral bar, whenever is present, is one of the major causes of restriction of shoulder abduction, and you should excise it. Thank you.
Thank
And so what about greens?
That is for soft tissue, that is for suture line to heal perfectly, that's it. Otherwise, just immobilization of 1 week is required.
So basically, for a Woodward's procedure, we immobilize with a sling and swathe or arm chest for about 3 weeks. And after that, we mobilize the patient.
So 3 to 4 weeks you are mobilizing the patients. Yeah. 3 to 3 weeks.
Yeah, I just wanted to add in torticollis meanwhile the stage is set. So I usually use a halo brace after I do a torticollis, and I always do a torticollis bipolar release. Reason is twofold. One is that I always get older patient beyond 5 years of age. Second thing is that besides the muscle abnormalities, because the abnormality has been present for almost 5 to or beyond years, there are associated changes in the soft tissue and the muscles as well as the bony situations. So unless you put up a rigid immobilizer for some time, okay, the child has a strong tendency to pull it back. And we do not have such aggressive physiotherapy which is present in the Western worlds to help us out. We usually have to discharge the patient 2 or 3 days after. We cannot keep the patient for 3 weeks in-house, in bed for the physiotherapy. So this is one of the methods I have utilized for torticollis post-operative protocol.
Can I add? Can I add something? There are 2 things which I do in torticollis. One is to reduce the error of assessment intraoperatively. I pull down the contralateral shoulder with a tape in patient supine, and I laterally flex the neck and sort of tape it there so that you have a maximum standing out of the sternocleidomastoid. Second thing what I do is always do a Z-plasty or suture the clavicular to this, because I have burnt my finger once in the sense that patient was happy. But if you see your neck, the sternocleidomastoid forms a V. And on one side that muscle was not standing out. So it was asymmetrical V. So after that, I have always started doing a Z-plasty. So 2 important.
Z-plasty is now accepted procedure.
Yeah.
And all elderly patients need bipolar release.
I agree with that, sir.
Of course, as a routine, get an eye examination done before surgery. Because
yeah, so this is, I'll add to that, this is an older sort of thing in the literature. But if you see the study from Patwardhan, they have done even surgeries at adulthood, and they have not found a single case of diplopia.
No, the point is, when you are assessing, then in a smaller child, you need to be sure, in spite, you may not have, first of all, you may not have a congenital, the muscle being tight. Or if you have a muscle tight, it could be a secondary to some other cause. So you basically rule out a latent squint, that's all.
Yes.
Good morning, respected faculty. I'll be presenting the case of patient Rishu Kumari, 16-year-old female, who presented to us with the complaints of deformity in bilateral knees, bilateral feet, neck, with loss of bowel and bladder function since past 12 years. Some history. She was a normal vaginal delivery, cried immediately after birth. There was no history of any NICU stay. She was born with a myelomeningocele and was operated at 7 months at Safdarjung Hospital, Delhi. She started walking at around 4 years of age, following which deformities were noticed by her parents. On further probing, we also found out that she was operated at the age of 8 in some private hospital in Noida for urethral stenosis. She came to us for further management of the deformities. On inspection, she had a heel scar mark over the lower back region. So this was the preoperative pictures. As you can see, there is bilateral genovalgum with right more than left. She also had foot deformities. So eventually, we managed the genovalgum with a medial closing wedge osteotomy on the right side on 21st May. This was the status of neck when she came to us. We can see torticollis present on the right side, head tilt on ipsilateral side, and chin tilt on the contralateral side. Right sternocleidomastoid was prominent. There was decreased distance of ear to right shoulder. We could feel a band-like structure in the distal 1/3. So this was the preoperative neck range of motion. As you can see, both the lateral flexion as well as the rotation, especially on the contralateral side, are very restricted. We calculated the deformity, the severity of deformity. This was also described by Dr. Atul Bhaskar in IJO. We found out that the gaze angle was 71 degrees and the translational deformity was about 12 mm. We also got a preoperative CT scan of the cervical spine done, just to rule out any, if at all, any bony causes contributing to the torticollis. We planned the patient for modified Furkel's bipolar release. So this is the operative steps. We made a small retroauricular incision over the mastoid and another one made just over the medial end of clavicle. Divided the platysma, sternal and clavicular heads were exposed. Fibrous bands in the fascia were divided. Clavicular head completely separated from the bone and Z lengthening of the tendinous band of sternal head done. We approximated the tendon using 3-0 monofilament absorbable suture and subacute closure was done. Post-operatively, we placed her into head halter traction for the few days for just pain management, after which we initiated some gentle physiotherapy. Thereafter, a custom brace was given and physiotherapy was continued. This was the picture of her just before we were about to discharge her. So this is 16 weeks post-operatively. We can see the range of motion has significantly improved, or both the rotations as well as the flexions. This is just a subtle comparison between the severity of deformity. Earlier, the gaze angle was 71, it increased to 76, and the translational deformity from 12 mm went to 2 mm. We scored her using a modified Lee and modified Chang and Tang score, and we got basically a fair result by this procedure. So the take-home message should be, age should not be a contraindication for correction of congenital muscular torticollis, as it has been considered traditionally. Cosmetic deformity may not completely disappear due to adaptive changes of the face and head, but a significant functional improvement can be expected. Post-operative physiotherapy is crucial for achieving good results. Thank you.
So, in such an older patient, you have to be really persistent with the semi-rigid collars, because this otherwise is not going to get corrected, because the older patients, they will have a tendency of always going back.
Yes, sir.
And you need to really be forceful with the family that they need to keep that collar on for some good amount of time, maybe in more than a year. Physiotherapy, of course, because that is the only way to get this corrected.
Yes, sir. Thank you, sir.
Thank you. Thank you. Next, I invite Dr. Kishmita Sachdeva for her case presentation. Which one?
Good morning, everyone. I'm Dr. Kishmita, Fellow Pediatric Orthopaedics at Chacha Nehru Hospital. And today I'll be discussing spectrum of management of internal rotation contracture in patients with OVBP through a series of cases. So internal rotation contracture, as discussed, is a result of imbalance between the weak external rotators and the unaffected internal rotators. And some authors also believe that it is due to the denervation of the external rotators, leading to shortening of the muscle. And the management protocol includes internal rotation contracture release, muscle transfer, and the augmentation of the external rotators. Now, there are a lot of literature that describes various techniques, but there is no consensus in the literature. However, all authors agree that treating these patients as early with muscle rebalancing procedures before the deformity develops, but there is no consensus between what is the precise timing and which procedure has a superior result. So after reviewing all the literature, we've devised a management protocol, and we decide, depending on the age and the congruency of the glenohumeral joint, and we'll be discussing this through a series of cases. So first case is a 2-year-old male who is a known case of right-sided birth-related brachial plexus palsy, presented to us with complaints of restricted right shoulder range of motion with an external rotation and an overhead abduction restriction. This was the clinicals of the patient with external rotation and overhead abduction restricted. We did the modified mallet scoring, which came out to be 20 out of 30, and the patient had trumpeting. So when we were planning this patient surgically, we first took into consideration that the age of the child was 2 years, and patient had a persistent internal rotation contracture with an external rotation deformity less than, with the external rotation less than 30 degrees, which makes it a candidate for surgical intervention and to stop physiotherapy at this time, and abduction was restricted. However, there was no glenohumeral dysplasia and no subluxation of the joint was seen. So we decided to do a minimally invasive subscapularis release followed by a shoulder spica. Intraoperatively, we saw that the external rotation had improved more than 45, so we did not augment it with any other soft tissue procedure. This was the outcome of the patient with an improved external rotation and no trumpeting on follow-up. My second case is also a 2-year-old male with a similar complaint of restricted range of motion of external rotation and deformity. And the external rotation was less than 30 degrees, as you can see in the video. And there was trumpeting was also present in the patient. Now, when we did X-rays of the patient, we saw that the right-sided shoulder had a hypoplastic humeral head with Waters type 1, which is less than 5 degree retroversion was present when we did a CT. And when we did the mallet scoring, it was similar to the previous case. But when we were deciding on the surgical management, we took into consideration the age that was 2 years, similar deformity, which was the internal rotation contracture persistent, and the external rotation less than 30 degree, and the abduction was restricted. However, at this point, there was a congruent glenohumeral joint dysplasia that was present. So we decided to add a conjoint tendon transfer along with a minimally invasive subscapularis release. This is the early follow-up images of the patient, and there is still some amount of deformity that is present. There's a compensatory movement that the patient is doing on external rotation. However, it is an early follow-up, so we've kept the patient on physiotherapy, and we might plan a future surgery. Another case is a 9-year-old female, known case of right-sided brachial plexus palsy, came to us with restricted overhead abduction and external rotation restricted. These are the clinicals of the patient, and patient had restricted overhead abduction and the external rotation, as you can see in the video. And On imaging, we saw that the right shoulder was subluxated and hypoplastic with flattened humeral head. So this becomes a non-congruent type of glenohumeral dysplasia, which is Waters type 5. We did the mallet scoring. And because the age of the patient was 9 years and glenohumeral dysplasia, Waters type 5 was present, which is significant. So we decided on doing a glenoid osteotomy with conjoint tendon transfer and a subscapularis release. This is the follow-up of the patient with improved external rotation and abduction and no trumpeting. So my take-home message is that the decision for such patients depends on, number one, the age of the patient. Then we see the severity of the internal rotation contracture, how much external rotation is still present, and the congruency of the glenohumeral joint. Thank you.
Thank you.
So we can take a question or two, and then we wind up this session. Any questions for the last two speakers?
So coming back to the obstructive brachial plexus palsy, my question to Dr. Gaurav, sir. So I'd like to ask you that you talked about injection Botox giving in the cases where there is no congenital dysplasias. So what are the criteria in which we can practice? Since I'm not a exclusive pediatric orthopedic surgeon, the first question will be, we do get cases from the pediatrics that the patient is having Erb's palsy or kind of brachial plexy. So when we need to refer it to you guys, since I'm a basically joint replacement trauma surgeon, so we usually ask for physiotherapy and do get them checked up for the thing. And when we can even treat them like giving Botox and all those things.
So most of the times as the child is delivered, the child is not moving the limb and they refer to an orthopedic surgeon. For initial 1 to 1.5 months, we do home-based exercises where we basically are moving all the joints. After 1.5 months, if it is only neuropraxia, it will almost have complete function. So there's not much need of a pediatric ortho, but most of the times, more than 30% of cases, the movements are restricted. They don't have full function. So that is the time when the child should be referred to a pediatric ortho. There, what we do is we try to score them by doing AMS scoring, HSC AMS scoring, the entire 105 score, and then we do it every month and we start physiotherapy. We also do stimulation of the weak muscles. So passive exercises for the tight muscles and stimulation of the weak muscles. Along with that, range of motion exercises. And we follow them monthly and we score them to objectify whether the child is improving or not. So if the scores are progressively improving and child has good elbow function by 6 months, which can be checked by TAL test or cookie test, then they don't need a nerve surgery. But if they don't improve, then they may need a nerve surgery, which can be first, the confirmation is done by doing an MRI. So regarding Botox, if on progressive monthly examinations we are seeing that the passive external rotation is decreasing, the function is not improving, muscles are tight, abduction is limited, then we can do Botox starting from the age of 6 months, and we can do it till 1.5 years or 2 years also.
Thank you, sir.
Yes, one more question.
Yeah, my question is to Dr. Agarwal. So when you are doing a VSO, have you encountered any neurovascular injuries, as in a Woodward procedures? Whenever you are pulling it down, you encounter brachial plexus injuries, and we do morselization of the clavicle. So have you encountered any of these in your procedures when you were doing it?
Sir, the beauty of this osteotomy is that the medial portion is the place where it was. So you are not pulling anything, you are just cutting the superior portion of that and releasing the muscles out there. The portion which you are bringing down is the medial portion of the scapula. Although I always add the morselization of the clavicle at any age, but I have not encountered any neurological deficits in my cases, so because the medial border of the scapula is relatively free from muscles.
So you regularly do morselization of the clavicle?
I regularly do.
Thank you.
Medial part of the, is the rotation is the medial portion. The medial portion you don't pull down so severely, just cut the superior lateral portion. Yes, so that is rotated and brought down to be attached to the lateral part is pulled down. No, lateral part is pulled down, middle part is static.
So we'll take one last question from.
My question is to Dr. Gaurav, or anyone who is doing the conjoint tendon transfers in OBPI. I have encountered few patients in the follow-ups who have a fixed abduction contracture due to an isolated action of the deltoid once the adductors have been removed. So how do you manage those patients?
So we have to differentiate whether it is herbs or it is extended herbs. Because in extended herbs, the internal rotators are more weak because of the involvement of C7, subscapularis is entirely paralyzed. In those cases, if your spica is in severe external rotation, 60 degrees or more, then they will end up in external rotation contracture. And in those cases, you have to do isolated tendon transfer. You don't do latissimus dorsi and teres major both. You do latissimus dorsi only. So you have to first differentiate at the outset whether you are dealing with herbs or extended herbs.
So thank you all the speakers. Before we move on to next session, I would request Dr. A.P. Singh sir, Senior Consultant Orthopedics at Kailash Hospital, Greater Noida, and President of Greater Noida Orthopedic Association, to please come on the stage and felicitate the speakers and chairpersons of the session. Dr. A.P. Singh sir. So first I would like to invite Dr. Gaurav Gupta. Next is Dr. Ankur Agarwal. Next is Dr. Ramni sir. Dr. P.N. Gupta sir. Dr. Anil Agarwal sir. Dr. Vikas Gupta sir. Dr. Anil Joshi. and Dr. Bharat Durgia. Thank you, everyone. Now I invite Dr. Gaurav Gupta to moderate the next session.
So now we'll be starting our second session, which is deformities around the elbow. And I would like to invite our chairpersons for the session, Dr. Arun Goyal sir, who is a senior pediatric orthopedic surgeon and president, Paediatric Orthopedic Foundation. Dr. Shobha Arora ma'am, senior pediatric orthopedic surgeon. Dr. Sudhir Kumar sir, senior professor orthopedics and ex-HOD Sharda. Dr. Rajni Ranjan, Professor, Department of Orthopaedics, Sharda Hospital. And Dr. A.P. Singh, Senior Consultant Orthopedics at Kailash Hospital, Greater Noida, and President of Greater Noida Orthopedics Association. So the first talk will be given by Dr. Anil sir. Dr. Anil sir.
We are running late, so please stick to time.
Okay, ठीक. Full screen. यहाँ तो देख वो उधर करना पड़ेगा ना ये अब इसमें अच्छा ठीक है गुड मॉर्निंग अगेन ये कचरा okay so we'll cover the following topics while we are covering the overall congenital radial head dislocation, and these are the credits for this talk. We often don't see this entity or fail to recognize this because it's rare. Okay. Usually the entity is present at birth because it's congenital, but the detection is often made when the child is already 5 or 6 years old or even more than that. The usual presentation is a bilateral affection, and the dislocation is most commonly posterior, but sometimes it's also anterior or lateral. To give you a few examples so that you can recall from your practice, this is a case of bilateral congenital dislocation of radial head, and this is unilateral. I have marked a query because the diagnosis is always suspicious whether it's a traumatic or a congenital variety. But if you carefully look at the opposite elbow, you can see that the opposite side is also rounded, and there is a curve present. So that's why we conclude that it's a unilateral variety of congenital declination of radial head. So the disease seldom occurs in isolation, and there are sometimes other syndromes associated, most common of which is radioulnar synostosis or nail patella. The example shown is of a ulnar club hand on the right. How will the patient present to you when you want to investigate, or when you want to investigate the child? So the presentation is often variable. Often the elbow flexion is restricted, but the full flexion will be present, and there will be some restriction of the rotations. Okay, this is our own case in which you can see the difference between that previous case and this case. You can see the right side is affected more than the left side, and both pronation and supination is restricted in this particular case. The X-rays are shown on the right side. Okay, so to summarize the clinical presentation, asymptomatic in childhood, do not have any complaints whatsoever, some restriction of elbow motion which parents may neglect as insignificant, some restriction of forearm rotation, but as the child grows older, some prominence may be felt because now the things are bigger, and rotation sometimes produces snapping sound, and if degenerative changes set up, then there will be more pain and crepitation in the joint. What are the differentiate? How do I differentiate it from other clinical conditions? So most often both elbows are involved. If you put up a die, you can find the corresponding other side of the joint is hypoplastic. The radial head, because it's not in position and there is no articulation, will develop into a round figure rather than a concave figure. Look for other congenital anomalies. Typically, the history of trauma is not present or forgotten, what you want to name it, and it's very difficult to reduce surgically. So this is the crux of the congenital dislocation radial head. This appearance will not be present. This typical position will not be present. So imaging, if you do, there are two associated features. One is the round shape of the head, and other is the bow of the ulna. The capitulum may be hypoplastic. If the dislocation is anterior, the ulna may be bowed on the other side. It will be concave rather than convex, and the head will be anterior. How do we manage this? Okay, so the management is typically non-surgical. Although you may try the open reductions like we do for Montegia fracture dislocations, but the reduction is often very unstable, and often the head relocates back. So the indication of the surgery is mainly to decrease pain only at advanced age. It will not increase the range of the motion the child has, and the main thing is that whether it helps in the cosmetic deformity, it seldom does. So the only indication is the pain if it has become degenerative. Okay, if you excise the head early, there are reports that the distal wrist joint will be affected, and that will also become painful. With progressive migration of the radial head, a cubitus valgus deformity will develop, and there are also reports of proximal radius regrowth if the periosteum has been left intact. Okay, so this is one study which I like to quote. The complication rate of wrist symptoms is more than 25% cases those who were operated. So be very cautious in your surgical decisions. One case example, you can see the degenerative and the deformation, and this is what the excised head look like. So the correct indication only when degenerative changes have set in. Don't intervene before. So the take-home message is, it's a rare entity, does not require a surgical treatment, and when you have doubt from a traumatic condition, do investigate the opposite elbow. Thank you.
So we'll take questions at the end. Now I would like to invite Dr. Ravi Chauhan, who is a senior consultant pediatric orthopedics and limb reconstruction at Sir Gangaram Hospital.
बताइए आप। ठीक है। Good morning, everyone. So after the congenital dislocation, I'm moving to the mainly the post-traumatic radial head dislocation, or it's the missed Montegia or the acquired radial head dislocation. So I have nothing to disclose in my presentations. So mainly the potential pitfalls that we encounter in this post-traumatic radial head dislocation is the diagnosis. Definitely the usual presentation is missing the diagnosis. Somewhere the history of misdiagnosis is there. And thereafter, even if the diagnosis is done, then the inadequate reduction of the radial head, even if it is reduced correctly, then if the stabilization of ulna is not properly done, then definitely it will relocate. So we are dealing with a radial head dislocation which is missed for at least more than 4 weeks. So we can have situations that whether we should wait for further time or like that, or whether we should go for the isolated radial head reductions, or should augment it with the ulnar osteotomies. These are the various options. And sometimes what are the issues about the annular ligament reconstructions and transcapular wires. So these are the various questions that we need to address in this. So definitely these are those cases which are mainly present after 4 weeks of presentations, what we call the chronic Montegia. So there are certain radiological parameters which are quite helpful in the diagnosis. There's such as the radiocapitular line precisely from the neck, and thereafter the Mubarak's line, which is this passed through along the dorsal border of the ulna, and which shows the ulnar bow sign. So these are the various radiological parameters which are quite helpful. Along with it, the lateral humeral line is also quite useful in the anterolateral or lateral dislocations. And if the diagnosis is uncertain as compared to our clinical findings, then we should not hesitate to go for further imagings like USG, MRI, and arthrography. And regarding the classification, definitely I depend on LETS classification, which is quite useful because Beidou classification don't include the basically plastic deformation and the grainistic pattern of this injury. So coming to my case, it was a 4-year-old girl who presented to me at after 3 months of injury. So initially she presented somewhere where the initial cast was given, and thereafter, after 3 weeks, that cast was removed. Basically, she was treated for the basically olecranon fracture, which was actually not there. So when she presented me, there was the elbow the stiffness was there, range of motions were limited, and the swelling was there. So these were the various radiological parameters, and there's definitely the clear-cut post-traumatic radial head dislocation is there. So we can have a question that whether we should watchful or is skillfully neglected, but definitely in the literature we have seen that there can be cases of elbow instability, valgus deformities, pain, arthritis, and these are various complications that can be there if we just leave these cases. So definitely this is almost abundance. Next comes the question that whether we should try after 4 weeks or 5 weeks of closed radial head dislocation. Definitely it is very less successful. It's not that much successful, and the reasons for this unsuccessful closed reduction is the scar tissue formation at the various joints, mainly the radio-ulnar joint or the radiocapitular joint, and sometimes in the late cases dysplastic changes. So this, and some of the cases and some of the people have tried the close reduction by using the external fixators as well. So they do have some options. Coming to the isolated open radial head reduction, whether we should go for it without any ulnar osteotomy and all like that, definitely it can have an option only in the early presentations. In the presentations between the injury and the presentation is less, or the ulnar bowing is quite distal, then only it can be successful. Otherwise, it will not be that much successful. So the crux of the situation is that the open radial head reduction with a proximal ulnar distraction flexion osteotomy is the mainstay of the treatment, what we mainly follow. So whenever we are doing the case, we should go for the adequate exposure, and the Boyd's approach is quite helpful in that. We should adequately expose the radiohumeral and the radioulnar joint, and after the proper exposure, we should clear out the joint spaces, because then only we can have the stable reduction. And after getting the radial heads reduced, if it is coming like that, then and if it is not coming, then she should directly go for the ulnar osteotomy in order to stabilize the radial head. So this approach is quite helpful in having those exposures and clearances of the joint spaces. Once we reduce the radial head and we have planned the osteotomy, then I am presenting in this case, and normally what I do, I use the temporary transcapular wire in some of the cases only, not in always. So just it temporarily fix my radiocapitular joint, and once it is temporarily reduced and fixed for a temporary situation, then I will go for the fixation of ulnar osteotomy. So once the two screws are fixed, then definitely I remove the transcapular wire and will check for the further stability. So the ulnar osteotomy should be proximal, and if after the flexion, distraction is quite more, if it is more than 1 centimeter, we can go for the grafting or like that. So once we reduced it, once we fixed the flexion distraction osteotomy, then we should always check it for the stability. And stability should be checked in flexion extension, full range of motion, as well as the pronation and supination. So we should be very much secured enough that it should be properly checked. Once we check the full range of motion, and then only we can complete the scenario. If the radial head is not reduced, it is not stable, then definitely we need to go for further clarification of the joint spaces or something like that. So a stable radial head reduction is the crux of all management strategies, whether it is direct or indirect. So this was the post-op radiograph. And regarding the annular ligament reconstruction, definitely it is individualization approach. Literature is not in that much support for it. Regarding the transcapular wire, some of the surgeons prefer it, but if we are using it, it should be thick enough so that it will not break, and our cast should be reinforced with some sort of fiber cast or like that, so that we can prevent the breakage of this wire. This was the 8-month follow-up X-ray of that child. So coming to the next case, it was a 6-year-old boy with a elbow trauma, and this child, when presented, this was the X-ray, then definitely there is a radial head dislocation in this child. But when this child presented to me, it was almost around 6 to 7 months late when he presented to me. So when he presented to me, this was the X-ray of the child and the CT scan. So here we can find out that along with the radial head dislocation, this child is having the heterotopic ossification of annular ligament. Though it is not that much common, it is quite rare, but we do find these situations in some of the radial head dislocations. And so after this, what should be our management? Definitely the crux of the management is open radial head reduction with the flexion distraction ulnar osteotomy. But regarding the heterotopic ossification, there is not a specific sequence of management, like whether we should exercise it or whether we should go for the non-operative, we'll leave it as it is. So what I follow, basically, if it is not that much matured enough, if it is non-symptomatic, then I usually leave it if it is not that much significant. Otherwise, I go for excision, because after excision, for excision even, you need to excise the lot of soft tissue, you need to go inside it, and then only you can remove this heterotopic ossification part. So this was what I have done in this case, and as you can see that I have left the heterotopic ossification part, I have not removed it. This was the 5-month follow-up X-ray. Here you can see that the ossification part is not that much. It has resolved. But in literature, I have tried to find out that I have not found any literature supporting that there is an actual history of resolution of this heterotopic ossification. I may be missing some of the literature also for that. So the best method of treatment, definitely there is no that much of a consensus. These were the 2 systematic reviews which have an opinion that open reduction and the flexion distraction ulnar osteotomy is the crux management. Regarding the ulnar osteotomy, it should be proximal, it should be stable enough to fix with a plate and screws, and if the gap is more, use the bone grafting. And regarding the annular ligament reconstruction and transcapular wire, it should be on the individual or the tailored approach or the individualization approach. So to conclude, early diagnosis with the radial head reduction is essential definitely, and don't hesitate to go for MRI or arthrography if it is required. And regarding the surgical management, it is typically involving the angular proximal ulnar osteotomy with the open reduction, which is the main treatment. Regarding annular ligament reconstruction and transcapular wire, it should be case dependent, not routinely required. Literature is not also saying that it is mandatory. And timely intervention and tailored approach is the need to manage the heterotopic ossification if it is there for the optimal joint function. Thank you.
Thank you, Dr. Ravi, for the comprehensive talk. Now I would invite Dr. Vikas sir to give his talk on cubitus varus. We can have one question.
Angulation osteotomy for late Montagias, I often feel that when you pronate and supinate, in some position there is slight subluxation of the radial head. How do you interpret that and how do you tackle that? So it's not a very stable reduction. The head doesn't remain in that particular against that capitulum in all positions.
Sir, in mainly these situations can be in the late presentation cases, and these are the only cases where I prefer the transcapular wire. Otherwise, I don't use transcapular wire. Sir, please.
Dr. Anil, can I add on to that? Yeah. Some of the cases I have faced a similar situation. And these are those cases which are actually presenting a little late, where the subtle radial head changes are there. So you sort of pronate or supinate, it tries to go out. I don't use a radiocapitellar wire, I use a radius to ulna wire usually. The reason is that even if that breaks, you don't have much, in mid-prone you fix it, so that you have, in case that breaks, you have minimal loss of function.
So thank you, Dr. Gautam and Dr. Prateek, for inviting to this lovely campus. So I'll be speaking on cubitus varus deformity. I think the commonest elbow deformity seen by all of us. The question is this just a crooked arm? This is the picture in one day. All these kids came with these kinds of various severity of deformity. The boys could not play well because they had difficulty in holding the cricket bat. And the girls were ashamed of wearing half-sleeve t-shirts, as well as difficulty in carrying school bags. So it's just a crooked arm. I'll answer this by the end of this talk. So nothing to disclose. I'll be covering this in various headings, starting with the pathoanatomy. So let us hear what Sir Dr. Watson-Jones said in 1960, that prognosis of pediatric supracondylar fracture is excellent in spite of any residual deformity. Probably he was thinking of just short-term function, but in long term, the deformity causes morphologic as well as alignment changes in the elbow joint, which have their own functional consequences. And this paper by Japanese surgeons, in which they studied the varus elbow and did 3D CT scanning by overlapping technique, and what they observed is an eye-opener, that stress stimulation of the growth plate in a deformed elbow, especially long-standing, leads to altered morphology of the distal end of the humerus as well as the proximal end of the forearm, with trochlear, capitulum and radial head overgrowth with external rotation torque of the ulna. And similar to the lower limb, we have altered biomechanical axis, which leads to a non-physiological torque of the triceps. So what does it lead to? It leads to internal rotation malalignment. We can say internal rotation malalignment syndrome with altered elbow kinematics, which can have functional consequences like the predisposing to lateral condylar fracture with simple falls due to increased distraction and shear forces across the capitulum. As you can see in this child, they have chronic pain and instability, especially when you see these deformities in adulthood, which is known as tardy posterolateral rotatory instability, as well as tardy ulnar palsy, which is also a rare complication, like in this young girl, which I saw recently, due to snapping triceps as well as dynamic compression. Now, coming to the assessment, before that, you must understand, we simply say it's a cubitus varus deformity. That is the main deformity, but there is a variable amount of internal rotation in the horizontal plane and extension in the sagittal plane. So it's a multiplanar deformity. The clinical assessment starts with a carrying angle with a goniometer, and especially for the postgraduates, they must remember how to keep the arms of the goniometer. The one arm along the lateral edge of the acromion, the other along the midpoint of the radial and the ulnar styloid. So you measure both the angles on the normal as well as the affected side. Range of motion to be checked especially for the sagittal plane deformity, especially the hyperextension, and internal rotation in the transverse plane by the classical Yamamoto test. Okay. Now, radiological assessment begins with the humerus elbow wrist angle, or we say HEW angle, the angle between the mid-axis of the humerus and the forearm. Now, another index, which is most of you may not be knowing, is called lateral condylar prominence index. It is the amount of bone which is lateral to the midline of the humerus. Now, why this is important? In a normal elbow, this index is 0 or probably slightly negative because medial condyle is prominent. But with most of the lateral closing wedge osteotomies, this index increases and gives a unsightly appearance because of the prominence of the lateral condyle. Now, planning and surgical technique. There are various distal humeral osteotomies, and I hope you all of them are doing some like closing wedge, which have their own pros and cons. Medial opening wedge, even they have done with the hexapod, and the computer aided using a jig with their own problems and the failures. What I'm going to describe is this step cut translation osteotomy, which is a relatively simple technique, and there's an inbuilt medial translation. Because this is done above the cora, a medial translation helps to reorient the mechanical axis and avoids the lateral condylar prominence. There is a firm fixation with a Y plate, which allows early mobilization, and it is as useful for the valgus also, cubitus valgus deformity. And we subsequently published it. Now, preoperative planning can be done on a tracing paper or in an X-ray. What we do is in the Bone Ninja app. So taking this example, 34 degree was the deformity. And we then simulate like this on the Bone Ninja app. You give it first cut, then you take out the wedge, and then you overlap it. So now you know that you have achieved the right angle. So coming to the technique, it is done in a semi-supine with shoulder and elbow flexed to 90 degree. Posterior tricep splitting approach. The initial cut is above the oblique fossa, about 1 centimeter, a transverse cut. Then you place the triangular template, and you see the wedge, and you take out this portion of the bone according to the template. Then you actually translate it. Lateral edge of the distal fragment is moved into the apex of the osteotomy. So where you have removed the angle. So fix it with a temporary KVR like this, antegrade KVR, and then you make it retrograde. Another KVR from the lateral side. So once you have done this, you check the angle, the carrying angle in the table only. If you are satisfied, you fix it with a Y plate, contoured Y plate. It's readily available Y plate used for fracture fixation. And then you finally check it and give a post-operative cast for about 2 to 3 weeks. So what you do, radiological outcome is by the angle as well as the lateral condylar prominence index. So the clinical outcome is done by Opperheim et al., which includes the angle, the range of motion, as well as any complication. It could be excellent, good, and poor. So I'll show you some of the cases. So this girl, which we did in the earlier part, in 2006, she had an angle of 23 degree. So we took a wedge of about 30 degree, and we were using paper planning at that time. So that's the intra-op picture. And that's the post-op after 3 months. She has good range of movement and has good correction of the deformity with normal angle on the affected side and the no lateral condylar prominence. So we could follow her. That's at the age 13, and the last follow-up when she was 20 years old. So after 14 years follow-up, the deformity is well corrected and there's a good remodeling. Now another case, again this case with severe deformity, 34 degree. So we took out a wedge of 40 degree, and that's the post-op picture. Now this is an interesting case. She came to us in 2015, 17-year-old girl with a mainly hyperextension deformity, as you can see. Severe hyperextension deformity. Her story goes like this. In 2003, at the age 5, she had a supracondylar fracture. And as most of you actually try to treat them conservatively, she was treated like this, which went into varus deformity. But unfortunately, in a good private hospital, she was treated like this with some kind of, I can't say it's a dome osteotomy or some kind of osteotomy, which the surgeon added another insult, added hyperextension to the already existing deformity. So now she presented us with 40 degree of about hyperextension and 20 degree of varus. So the good thing about this osteotomy is you can do the flexion, you can add the flexion part. So we did the paper planning in 2015, and We corrected the deformity using this Y plate, added the Y plate, and that's the post-op result. So in the last case, this boy came during the COVID time, 11.5-year-old. Again, he has a severe deformity. Presented like this, you can see. Age 7, again, supracondylar fracture, treated conservatively. And age 11, he went for corrective osteotomy. Again, this kind of osteotomy, still surprised why the surgeons do an adequate job, fixing with 2 K-wires, which just acting like a single wire. And he presented again with severe deformity with hyperextension. So he came to us during the COVID time, and we were buying time. So let this COVID be over. But meanwhile, he had a simple fall. And what he actually suffered from was lateral condyle fracture. So it's not an uncommon injury following varus deformity. And we've seen a lot of cases with simple falls due to the increased shear forces. So what we did is we planned open reduction of the lateral condyle as well as planned to correct the deformity in the same sitting. So that's the post-op result after 4 months. He still has some varus that is probably due to the lateral condylar prominence, a kind of pseudo-varus. So do we need to correct both internal rotation and hyperextension? Now this paper published in JBJS has categorically stated that internal rotation need not to be corrected. It is well compensated and it will lead to poor fixation. Hyperextension is only to be corrected in a child older than 10 years of age. Okay? So the lessons to learn is that close reduction and pinning should be the standard of care in all type 3 supracondylar fractures, because the most common reason for cubitus varus is malunited supracondylar, especially type 3. It's no longer a benign or cosmetic deformity as we used to think. Early corrective osteotomy will prevent the eventual complication, will be good remodeling. Whatever you do, osteotomy should be firm, stable, and should have early mobilization to achieve good cosmetic and the functional outcome. So what about these kids? They underwent the osteotomy, and we can now say with confidence, it is more than just a crooked arm. So you can go to this article also by Christina Ho, where he categorically says that these are to be treated as early as possible. Okay? Thank you.
Thank you. So thank you, sir, for this very clear, making the topic very clear to us. Now I would invite Dr. Kapil Gangwal, sir, Head of Department, Santokba Durlabji Memorial Hospital, Jaipur, to present his talk on cubitus valgus. We can take one question till the time the talk is being set. One question.
Before you start, I just want to make a small comment, particularly to benefit the postgraduate students. Many of them from our institute are sitting there. Whenever I've been going there as an examiner for last more than 30 years, and cubitus varus is a very commonly kept case. When I ask them why it is a cubitus varus, they say since the 3 bony points are normal, that is why it is cubitus varus. But let me tell you that the cases which are presented to them, they are generally 1 to 2 years or even 3 years late. And by that time, there are some other problems which do develop in the 3 bony points also. The apex of the triangle rotates medially because cubitus varus is not purely a coronal plane deformity, the distal fragment rotates. And the second thing is that the distance between the olecranon and the medial epicondyle does get reduced significantly. Dr. Hardas Singh Sandhu, more than 30 years back, I think 20 years back, had written an article in Indian Journal of Orthopaedics. Because of the medialization of the triceps, the medial pull of the triceps moves the olecranon towards the medial epicondyle. So those cases, this does happen, and postgraduate must understand this, that there are changes which do develop in such cases after a long-standing deformity. In a very fresh case, this may not happen, but some of the cases which are given to them are all old, and these secondary changes do develop in them.
Right. So just moving on to another deformity. Not as common as the cubitus varus, of course, but we do see that once in a while. And let's see how is it going to move. Okay. So the most common reason for the cubitus valgus is the non-union of the lateral condyle humeral fractures in children. And we'll talk a little bit about that as well. Other reason for cubitus valgus that we see in clinical practice is a missed Montagia, as Ravi alluded to in his talk. And that can cause some lateral instability and deviation of the elbow into valgus. And sometimes you can have it from malunited fractures around the elbow, and rarely you see it in Turner's or Noonan's, and I haven't seen that in my clinical practice as yet. So the non-union lateral condyle is actually quite uncommon. It's about 0.6% incidence, but we do see it in clinical practice, and the reason for that is that we often miss them. We fail to take the x-rays in proper orientation, or we fail to recognize the secondary displacement of these fractures, which often happen in about a week's time, or they're not properly fixed, or we remove the fixation too early before the fracture is united. So we really need to pay attention to treatment of these fractures, and then probably the incidence of non-union will be less. So looking at what's the natural history of these non-unions and what causes these fractures to go in cubitus valgus. Well, two types of non-union patterns have been described. The first one is the one in which the radiocapitular articulation has actually moved proximally to the ulnohumeral articulation. And these are the ones which have a tendency to progress more into the valgus and cause more problems with clinical functioning of the elbow. And the group 2 has the fracture pattern in which the radiocapitular articulation is at the level or below that of the ulnohumeral articulation. And these are not so symptomatic as compared to the group 1s. And if you see that the group 1s actually have the more valgus and also are more symptomatic. The same group which published the article in which looked at the long-standing non-unions also looked at the timeline, and they found that these children became symptomatic on an average about 9 to 10 years from onset of the non-union, and the ulnar nerve symptoms appeared around 12 years from onset of the non-union. And the ones which got the ulnar nerve symptoms were the ones which had the more valgus. So more than 20 degrees was a predisposing factor for the ulnar nerve symptoms to appear. So the late non-unions, the problems are of pain, instability, neurologic symptoms, which is the ulnar nerve symptoms, and deformity. And we are mainly looking at the cubitus valgus management of the deformity and what we do with that. The treatment options for the non-union, basically based on symptoms, that's the current thinking. So for instability and pain, you fix the fracture. For ulnar nerve symptoms, the standard management is of a transposition, and this has now become more controversial. We'll talk about that. And the osteotomy is required for correction of the valgus deformity, and that's usually for over 20 degrees of deformity. So the classic article was by Milch in 1955, and he described two types of the osteotomies. The one was for the metaphyseal deformities, which is the Milch ones, and the other one was more for the deformity at the level of the joint, which required angulation and translation, which is called the Milch 2 osteotomy. And K. Wilkins in this article in Orthopedic Clinics showed that the Milch 1 really worked for the ones for the non-unions of the lateral condyle, which did not have too much deformity, so which were not proximally migrated. You could get away just by doing an angulation osteotomy. And for the ones which had migrated proximally, you needed the Milch 2, which was the angulation and translation osteotomy. So now this is an article from Rohtak, and they've talked about the Milch osteotomy for correction of the cubitus valgus, and they got away without fixing the non-union fragment or doing an anterior transposition of the ulnar nerve. And they found that this was just correction of the deformity was enough to take care of the symptoms as well as resolve the ulnar nerve symptoms. And these are pictures from their article. So I don't do the Milch osteotomy myself, but this is just for covering it. So the other treatment which is described for this is the dome osteotomy, and this article is from Japan, and they've described the technique. It's published in Bone and Joint Surgery Journal. So the first step is in situ fixation of the non-union fragment, and it's all done through the posterior approach. And then you do the dome osteotomy for correction of the deformity and do a simultaneous anterior transposition of the ulnar nerve, all through the posterior approach. So you're right there and it's easy to do. So this is a 13-year-old girl, more than 6 months from injury. There was pain stiffness of the elbow, and there was increasing deformity. And there were no clinically visible ulnar nerve symptoms, but on nerve conduction test, there were some changes. So that was the clinical picture. And this is what was planned, a dome osteotomy, in situ fixation of the fragment and anterior transposition of the ulnar nerve. And no real attempt is made to do much dissection in the fracture fragment, and that's what it looks like after the fixation. So that's 4 months follow-up. The osteotomy is united. The fracture fragment also seems to be uniting. She has reasonably good cosmetic correction, and that's about a year, and some restriction of flexion, but the fracture has gone on to heal and the deformity is corrected. Another case, 14-year-old boy, 1 year from injury, slight cubitus valgus, occasional discomfort and good range of motion. That's the fixation and the dome osteotomy. And that's a long-term follow-up with good cosmetic correction, and the fracture fragment also goes on to heal. So you can do the same thing with fixators, and this is a publication from Egypt, and they've used supracondylar osteotomy, again angulation translational correction, and that's how it's done. The pictures are from their publication, and I don't have experience with using fixators for correction of this deformity, but you can do it, as you can see here. Another interesting article from Turkey, and this is a recent publication in which they didn't do osteotomy. What they've done is that they just used the non-union fragment, and they've stuck a tricortical graft taken from the iliac crest to correct the deformity and also for union of this fragment. And they had about 20 patients. They had good correction of the cubitus valgus from average of 30 degrees to 9 degrees. And none of these patients had restriction of range of motion or avascular necrosis. So interesting concept of correction of the deformity without doing a osteotomy. I, of course, have no experience with this either. So just take-home points. Non-union lateral condyle is commonest cause is the commonest probably cause for the cubitus valgus. Ulnar nerve symptoms mostly will occur in deformities over 20 degrees, and the supracondylar osteotomy is the mainstay of treatment. You always don't need to go after the non-union and the ulnar nerve transposition, and those may correct just by correcting the deformity. Thank you.
Thank you, sir. Now we have a case presentation by Dr. Aditya. We can have a question in between. Any questions?
A very good morning to one and all present here. Myself, Dr. Aditya, and I'm a senior resident at in Pediatric Orthopedic Department at AIMS Rishikesh. And today I'm going to present our result on spike translation osteotomy in a case of cubitus varus deformity. So, Case 1, we have a 8-year-old male who presented with deformity over his right elbow since 6 years, and for which he had underwent injury during his toddler phase, which was managed conservatively with a above elbow slab. Currently, he has no restrictions of any daily activities. On examination, we could appreciate the cubitus varus deformity on the right side, and there was a slight hyperextension deformity which was present. Clinically, there was around 12 degrees of varus which was present. So again, in palpation, the inspectory findings were confirmed, and there was thickening of the supracondylar ridge which could be appreciated, and also the 3-point bony relation was maintained. At the right side, the affected side, there was hyperextension of 20 degrees, which was more than the opposite side. So he enjoyed a good range of motion at the elbow, both the side, except for the extension, which was a bit more on the affected side. And Yamamoto test was positive on the right-hand side. We can appreciate that there is more internal rotation on the right affected side, suggesting a positive Yamamoto test. So here in the pre-op X-ray, on the AP view, we can appreciate that there is a malunited supracondylar fracture, which has remodeled pretty good. And but still, we could appreciate that the anterior humeral line, it was passing anterior to the capitulum, suggesting of the extension which was seen clinically. So when the pre-op planning for this patient was done, we could appreciate that there was a correction needed of around 17 degrees was required in this patient. So he was diagnosed as a cubitus varus deformity, and he underwent spike translation osteotomy. So I will be showing about the paper. That is, it was first published in 2016, wherein this technique was described through surgeons from Iran. So when we have an elbow and the bone has been exposed, and we first mark the osteotomy site, that is a triangle like the classic step cut osteotomy is marked. Point A, point B, wherein the correction angle is noted, and further on, osteotomy is performed in the decided plane. Further on, adding to this, a spike is created on the radial wedge, that is to accommodate this spike at this end. And again, osteotomy is performed, and this is the final gap that we will obtain in the humerus, distal humerus. Then the wedge, the distal end of the fragment is translated, and the spike is adjusted, accommodated into the wedge that has been created. So this osteotomy not only provides rotationally stability, but also it gives a good cosmetic review. So these are our intra-op images. Using the posterior approach, the bone was exposed, and the osteotomy was performed as described before. And wedge was resected out, and a spike was created. This was the final outcome. Here we can appreciate how the spike which was created, which could have become a lateral bump, has been accommodated into the humeral shaft. The beauty of this osteotomy is that it can be just stabilized with a simple K-wire fixation, irrespective of age, because the spike itself acts as a stabilizing agent. So finally, 10 degree of valgus could be obtained, and the patient was mobilized after 3 weeks of immobilization. So at 5-month follow-up, we could appreciate a near normal morphology at the right elbow, and he's enjoying a good range of motion. Our case 2, again, a patient with a similar deformity at the left elbow with varus deformity, and it was calculated that the elbow was in extension and varus deformity was there. So 25 degree of correction was required in this patient. Again, the patient underwent spike translation cut osteotomy, and at the 3-month follow-up, this was the remodeled bone, wherein we can appreciate that the patient now enjoys a good cosmetic elbow and enjoys a good range of motion. So my take-home message here would be, although cubitus varus is a commonly encountered entity in our OPD practice, surgical correction mainly for cosmetic, but also to avoid the different complications ranging up to the tardy posterolateral instability. And spike translation not only reduces the lateral prominence, but increases the union rate and provides stability at the osteotomy site. Thank you for providing me this opportunity.
So next case is by Dr. Ashish Upadhyay.
Good morning. I am Dr. Ashish. I am working as a senior resident in Chacha Nehru Hospital in New Delhi. I am presenting a case on missed Monteggia fracture. So the brief history of the case, it's a 3-year-old boy. History of fall 6 months back at home. He was treated conservatively in a plaster slab for 3 weeks outside. When he presented to us, there was a complaint of pain, deformity, and restricted range of motion. The clinical findings were restricted pronation and flexion. These are the pre-op clinical examination and the radiographs. What was the next step? Obviously, it's a operative intervention with an open reduction of the radial head and ulnar osteotomy. In osteotomy, what are the options available? Transverse osteotomy, lengthening open wedge osteotomy, step cut osteotomy. But we have, what are the challenges for the osteotomy? We require angulation, we require the ulnar length to be increased, proper rotation, and the proper bone contact for the healing. We have opted for the oblique angulation osteotomy described in this paper. And this osteotomy is tick marking all the requirement of the osteotomy required for the missed Monteggia fracture. Why does the angulation work? Because in the Monteggia fracture, why the radial head is dislocating? Because the ulnar length is decreased and there is an angulation in the direction of the radial head dislocation, which reduces the interosseous membrane and the radial head dislocates. So we are doing a ulnar osteotomy in the opposite direction of the radial head dislocation, which tightens the interosseous membrane, and this puts back the radial head in the position. What was the level of the osteotomy? We have done an oblique osteotomy in the direction of the radial head dislocation, where we cannot see the proper bend in the ulna. We have done an osteotomy at the junction of the proximal and the middle third of the shaft of ulna. In cases where we can see the angulation, we have done the correction at the angulation. This is the schematic representation taken from the paper. What are the advantages of this? It's a simple procedure. There is an adequate bone contact. Bone graft usually not required. It's a large contact area, so healing is good. And it's a easily angulatable, we can easily angulate the ulna, and it's a stable osteotomy that can be fixed with a plate. What is the disadvantage? There is one more surgery required for the implant removal, and we have to do the intraoperative bending of the plate as per the angulation seen intraoperatively in the ulna. This is the immediate post-op. We have kept the child in plaster slab for 6 weeks. After that, we have removed. This is the recent at 6 months, 6 week post-op, 3 month post-op, and this is the yesterday's clinical result. take-home message is a oblique angulation osteotomy is a viable option for the Miss Monteggia fracture, easily done, and it fulfills all the requirement for the Monteggia reduction.
We can have questions for this session. Any questions? So I have a question with Vikas sir. So in lateral closing osteotomy, we can also translate the fragment medially to avoid the lateral bump.
Yes.
So how advantageous is the osteotomy which is described by you in comparison to that translation with lateral closing?
Now the osteotomy, step cut osteotomy, first and foremost, you can plan your correction amount by keeping a wedge which you have planned preoperatively. You can fine tune. You can also increase or decrease the correction which you have seen during the surgery. The second foremost thing is the inbuilt translation which avoids the lateral bump. Most of the lateral closing wedge osteotomies, if you are just closing it and then you're translating it, the contact area decreases. The fixation is also not very good as seen. Most of them are being fixed with a K-wires, which does not allow early mobilization. So good thing about this step cut is, though the surgical time definitely increases, but you allow early mobilization as early as 2 weeks and you achieve full range of motion. Having said this, I was doing French osteotomies in my residency days, but then I realized that the failure rate was very high because of the failure of the implant. So we have shifted to this step cut translation even in the failed cases, given thesis also, published also. So I think it's one of the osteotomies which can be taken up by the beginners for the cubitus varus as well as for the valgus. I do.
Thank you, sir. Any other questions?
And one more point which Dr. Gautam also said, that for the postgraduates, that there is always a dearrangement of the 3 bony points. Because of the long-standing deformity, the 3 bony relationship is disturbed. And the common tendency for the postgraduate is to say that 3 bony points are maintained. So they should be avoided. Yeah.
Bony points preserved, but I think
it's only in supracondylar fracture that 3 bony points are maintained. The deformity, because of the changes, elbow kinematics have changed. The triceps pulls the olecranon medially, so the relationship is definitely disturbed.
From Dr. Kapil, you were doing dome osteotomy and fixing with K-wire. Is that sufficient K-wire? Yes.
So please use mic, sir. It's not audible.
Please. Yeah, I never use a plate or more solid fixation for the osteotomy. Unless it's adolescent or adult. So for children, in my hands, K-wires are enough. Like we pin a supracondylar fracture, we don't fix supracondylar humerus fractures with plates. Yeah, so it's like you are creating a fracture.
Because by the time most of these cases come, there are 12 years around. And
yeah, so just like you'd fix a supracondylar humeral fracture in a 12-year-old. Similar, just wires. So 3 wires which are divergent and maybe 1 wire on the medial side which crosses over the osteotomy or proximal to the osteotomy.
So if there are no further questions, we move on to felicitation of our speakers and chairperson. So I would invite Dr. Anil Joshi sir to felicitate the speakers. So first, I would invite Dr. Ravi Chauhan. Dr. Kapil Gangwal, sir. Dr. Arun Goyal, sir. Dr. Rajni Ranjan. Dr. A.P. Singh. So now I would hand over the mic to Dr. Prateek for the inauguration.
Morning everyone. So we are already running very short on time. So I would invite, but we have a tradition of lighting the lamp here. So we'll light the lamp and seek blessings from Ma Sharda. I invite Professor Dr. Gautam sir, Anil sir, Dr. Arun Goyal sir, President POF, Dr. Manoj Padman sir, Secretary POF, to please lighten the lamp. I request AP Singh sir, President GNOA, to please lighten the lamp. I request Gautam sir to welcome the attendees.
I am honored and privileged to welcome the Paediatric Orthopedic Federation to hold its first meeting in Sharda University. I'll particularly I'm very happy that my senior colleagues like Dr. Arun Goyal, President of the Federation, and my contemporaries and many junior colleagues are present to be on this occasion. You see, I am by training, I'm a joint replacement surgeon. But as a postgraduate, I had a great fascination for pediatric orthopedic surgery. It was not a separate branch that time, but I would say pediatric orthopedic surgery is a branch of the thinking orthopedic surgeon. Most of the other branches are mechanical, like replacing a joint, tibial cut. In pediatric orthopedic surgery, the surgery may be simple, but the thinking behind that is a great thing. Just like cerebral palsy, very complex process. So you have to decide what is to be done. The surgery is simple, but if you take a wrong step, so it does disaster to the patient. And I also been an OSCE setter for national board examination for the last 4 to 5 years continuously. And I found that most of my question, about 30%, are from pediatric orthopedic surgeons, but they provide the insight for a discerning student to find out the right from the wrong compared to the other specialties. All other specialties also important, but here you have to apply a mind and brain to come at the right conclusion. So I think this day-long proceeding will do a great for the pediatric orthopedic surgeons and some of the PG students who are present here. And with that, I'll not like to take much of your time because we are already running late of time, and welcome you once again for this session at Sharda University.
Thank you, sir. We take a quick tea break, and I request all the speakers of coming sessions to please load their talks so that we
no time is wasted.
No time wasted in transitions.
So on behalf of Posicon Team 2025, I would like to invite everybody for the upcoming Posicon. So we'll have a flyer here shortly for the details of timing and this thing. Loading it.
राहुल केस प्रेजेंटेशन वो जो है ना बच्चों का वो मैं अभी प्ले करवा दे रहा हूँ जो ई पोस्टर है ना ऐसे ब्रीफ होगा वो तो अपना वो देने आया सर्टिफिकेट के लिए
ये डॉक्टर राहुल का है मेरे पास
डॉक्टर राहुल का है ना ठीक है डॉक्टर आशीष का भी अपने में डाल दे
एक मिनट
दोनों का साथ साथ ही है दोनों का डाल दे
कौन से सेशन में
ये सेशन नंबर 4th में नेक्स्ट सेशन का मतलब सारा हो गया ना काम सबका विकास सर बस अपना लैपटॉप लेंगे
कौन सा इसमें सेशन 4 में है ना अपना नाम क्या है
इसमें ये आशीष केस प्रेजेंटेशन
सेशन नहीं चल जाएगी चल जाएगी
मतलब कुछ चेंज तो नहीं होता ना
नहीं कुछ चेंज नहीं सेम जी सर
इसमें है अपना
सरकारी खाना
मेरा
हाँ सौरभ इसको शो ऑन कर दो just run through it's coming in the same order as expected बनाया है इतने सारे एक्सरेज डाल रखे हैं अच्छा done thank you केस हो या ना हो लिटरेचर के पास केस जरूर होता है सही बात है अलग क्लब हैंड में तो लिटरेचर में भी नहीं है केसेस अरे यार आई एम एएमसी इन अपर मैं तो एएमसी इन अपर में ऐसी चीज है इसको लोग रोज देखते हैं लेकिन करते कुछ नहीं है दैट इज एग्जैक्टली द मैसेज दैट इज एग्जैक्टली द सेम इन अल्लर क्लब हैंड आल्सो इतना काम करने के बाद आई एम नॉट एबल टू सी अ सिंगल केस ऑफ अल्लर क्लब हैंड ठीक है ठीक है चलो वो चाय पीते हैं
ये किनका है तो ये सेशन कौन सा था 3 या 4
हाँ सेशन लास्ट सेशन 5 में है सेशन 5 में हाँ सेशन 5 में
ये नीतीश की दूसरी टॉक रहेगी उनके लैपटॉप पे अरे यार मांगो ना यही तो तुमसे तब से बोल रहा हूँ
तो मैं चेक करूँ
जी सर राहुल ना
हाँ सेशन 3 वाला ठीक ठीक
ठीक
खाली डाल 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 कोई दिक्कत ना करा तो पानी डाल
अब सेशन कौन सा होने वाला है? 3 हो रहा है ना, 3 कोली 3 का शारदा में
देख ले।
विकास गुप्ता नहीं है, विकास गुप्ता को बात करनी है मैंने। ठीक है, नेक्स्ट फॉर सर। जो खा पेल हम भूखे इधर। इसमें तेरे दिलीप और आशीष हो गया ना?
दिलीप और आशीष हो गया।
हाँ, ये दोनों बाकी आ रहे हैं खिलाड़ी, बाकी उतना तो डालिए। दिलीप हो गया, आशीष हो गया।
फोटो खींच दे मेरी।
ठीक है, सेशन नंबर 5 में कुछ डाला अभी तक?
जल्दी खींच दे।
ये AMC नपड़लिम किसके डाला भाई? सेशन 5 नाम क्या?
सेशन 5 में देखियो यार कौन था वो, नाम बता के नहीं गया।
अभिषेक साहा। अरे भाई रुक जा, अभी काम हो रहा है तो फोटो। चाय पकड़े खड़ा है पोडियम पे, तेरे लग रहा है। अभिषेक साहा हो गया। मैथ्यू वर्गीस।
खींच दी।
ऑन है
डॉक्टर,
ये है डॉक्टर अभिषेक साहा। सुमित गुप्ता चल रहे हैं और डॉक्टर मैथ्यू वर्गीस। ठीक है, मैं सारे बंदों को यहीं पर ही लेंगे। यहीं बैठा हूँ।
यहाँ पे नितिन सर बैठे तो है।
गुड मॉर्निंग।
यार बाद में खा लेंगे।
किसका लगता है? ये मेरा सब।
चला ही नहीं तो आएगा
तो फिर अभी चालू नहीं होगा
प्रोजेक्टर
ऑन है अच्छा वो ऑन करें
विकास सर भी आ रहे हैं उनको भी डलवा देना सेशन 3 में आएंगे
एक मिनट बस यार सेशन 3 में ना श्री
सेशन 3 है
नहीं सर अभी डाल दीजिए
ये पेंटर से तो सर अभी डाल दो क्योंकि ये भी होने लगता है
इनका सर का डाल दे लास्ट सेशन डॉक्टर सुनील
वीडियो पता नहीं चलेंगी नहीं चलेंगी यार चल जाएंगे सर कौन सा सर पीपीटी तो ये है सर ये और ये 3 वीडियो भी डाल दो जी सर 1 मिनट सर वीडियो डालो तभी चलेगी ना वीडियो की 1 मिनट सर सुमित ना सर पूरी चला के देखना दीदी चलो सर ये वीडियो चल रही है तो हर बार ये करना पड़ेगा इसकी वॉल्यूम कम कर देना यार बंद कर दूँ सर हाँ वॉल्यूम बंद ही कर दूँ इसको हर बार एसेस करना पड़ेगा क्या नहीं सर हो गया ना बैक कर लेते हैं बाद दोबारा चला के देख लेते हैं ये तो इसमें पीपीटी में कर देना 3 वीडियो ना तीनों में करना पड़ेगा मेरे ख्याल से लास्ट में 2 वीडियो होंगे लास्ट में आवाज कम कर दो आवाज कम कर दो सेव करना रहेगा चल जाएंगे ना मोस्टली जी सर चला के देख लेंगे एक बार ये भी चला के देख लेते हैं आवाज़ नहीं कर देंगे ठीक है लास्ट वाली होती थी लास्ट में होती ना आप पेन ड्राइव दे दो सर मैं डाल दूंगा इसमें
मेरा नेक्स्ट सेशन में केस है
जी
इससे कर लो इससे कर लो
यही सेशन 3 में है ना सर आपका?
हाँ मतलब हाँ नेक्स्ट सेशन में।
एक मिनट। एक सेकंड। कोई नहीं।
कनेक्टर ले लो। पर है तो तुम कैसे करोगे? और कनेक्टर ले लो।
सर आपके पास पेन ड्राइव है तो पेन ड्राइव दे दो, हम डाल देंगे, इसी में डाल देंगे।
सर किसी और से लेते हो, किसी और से लेते हो। मैं पेन ड्राइव पे डालने के लिए कनेक्टर चाहिए।
अच्छा, ये ऐसा कनेक्टर चाहिए सर? ये सर का दे दे जिनका है।
सूस वाला किसका है?
ये वो 3 लोगों की थी तो दिया था।
पॉइंटर यहीं रख देते हैं ना।
ये चल नहीं रहा।
ये सेल खत्म हो गया, ब्लैंकेट का था।
सेशन 2 खोल के देखिए एक बार यार, 3 इसमें ये है
क्या? वो खोलना है पर्चा?
पर्चा खोल। सेशन 3 में विकास भी है क्या? डॉक्टर विकास कोई?
हाँ ये रहा।
ठीक है, हो गया, सारे हो गए ये तो। और में नहीं हुआ सब। हाँ सी शुड डिलीट हुआ बस।
सुमेश्वर मानी पे था, मनोज को
कहाँ है? बोला उनसे
वो भी गया कनेक्ट करना। सुमेश्वर में आना बेटा, सुमेश्वर में आना तो
तो लिया
सर उत्तर ये जो ब्लू शर्ट में बैठे सेकंड में कोड वाले इनसे लेकर आना, सुमेश्वर मानी सर और लास्ट में नोट सर।
जी सर, इसमें भी 2 ही आए हैं।
ठीक है शुरू करते हैं सर। जी सर।
So good morning everyone. So we are moving to the next session in the club hands and the similar deformities. So I would like to invite the chairpersons. First the Dr. Kapil Kangwal sir. Now the Dr. Manoj sir, Dr. Manoj Padman sir, the senior consultant in Rainbow Children Hospital. Manoj sir, बाहर है? अच्छा हाँ sir. Okay. So Manoj sir is in the consultant pediatric orthopedics in Rainbow Children Hospital, and he is also a secretary Paediatric Orthopedic Foundation. I would like to invite Dr. Rahul Kaul sir, professor in Department of Orthopedics, Sharda Hospital, and Dr. Abhisar Katiyar sir, senior orthopedic consultant from Yatharth Hospital. So I would like to invite the next speaker, Dr. Nitish Arora, consultant pediatric orthopedics and complex trauma at Medicover Hospital, Mumbai.
So we'll start with the radial club hand session. The surgical technique will be discussed in the next session. So we'll start with the etiopathogenesis and assessment. So radial deficiencies can be can present with any degrees of congenital hypoplasias or aplasias, including the thumb, the thinner muscles, the carpal bones, or the radius. So it comes under the formation defects. So what is, so we'll see the classification. So this is the classification given by Swanson. They have classified into 7 categories: failure of formation, differentiation, duplication, overgrowth, undergrowth, then constriction band syndrome, and generalized skeletal abnormalities. So it was a morphological classification. It doesn't explain the severity, how severe is the involvement, whether the only the radius is involved or radius or thumb is involved. And there is no reference to etiology or embryology understanding of the pathology. So ranking these anomalies based on the severity of the expression is important, because the treatment principles is always dependent upon the whether the humerus is involved, how is the elbow joint, how is the radius, how are the wrists functioning. So this is important. So we'll see briefly how the radial club hand develops. So when the limb buds are developed at around 4th week of gestational age, any limb is developing along the 3 axes: proximal to distal, anterior to posterior, and dorsal to ventral. So proximal to distal, what we called as a apical ectodermal ridge, it releases fibroblast growth factor, which is responsible for development of the upper arm in proximal to distal direction. Then anterior to posterior, what we called as a zone of polarizing activity. This is along the ulnar side. It promotes the development of the ulna. And it releases one hormone called as a SHH, sonic hedgehog hormone. This interaction of sonic hedgehog hormone along with fibroblast growth factor is responsible for radial sided structures. So disruption of AER leads to transverse deficiencies. Disruption of ZPA or SHH is responsible for ulnar sided longitudinal deficiencies, and disruption of SSH along with FGF interaction leads to radial longitudinal deficiencies. So a new classification came up based on these things. They have divided into malformation, deformations, and dysplasias. Then further differentiation took place, that the failure of axis or formation or differentiation along the entire upper limb, or they involve the hand. So this is a comprehensive classification. We don't have enough time to discuss in detail. So the basic thing is, malformation is an abnormal formation of a tissue. Deformation is an unusual force which is acting on a developing tissue, and dysplasia is abnormal organization on a cells of a tissues. So we all know this radial dysplasias classification described by Haeckel and further modified by Bain into 1, 2, 3, 4. 1 is almost a normal with minimal shortening of radius, and 4th is complete absence of radius with significant radial deviation and absence of carpus including the thumb. So what are the clinical manifestations? We can see this. It is clearly obvious that the radial sided structures are absent, and with the significant deviation of the wrist, which is always present at the birth. The ulnar sided will be knobby. The thumb may be hypoplastic. It may be rudimentary. It may be absent. Detailed neuromuscular examination, we have to do it as discussed in the future slides, and detailed examination of the whole body, because we need to rule out certain syndromes. So we need to do 2D echo, we need to do renal profile, we need to rule out the spine x-rays, whether there are any spine abnormalities or not. So why we need to do these things? Because there are certain syndromes associated with this radial club hand. It can be either an isolated sporadic syndromes, or it can be associated with genetic defects. It can be thumb hypoplasia, it can be associated with vectoral association. Therefore, vertebral anomalies need to be ruled out. So two important things: if it is bilateral, rule out Fanconi's anemia. And in TAR syndrome, the thumb is almost always normal. So associated deficiencies: humerus may be short, it may present with distal epiphyseal abnormalities. Elbow joint ligaments are either lax, but it is incorporated with muscle. Therefore, the size of the capsule and ligaments permitted only limited flexion and extension with lack of pronation supination. Ulna is always curved, but the distal end of the ulna has a delayed appearance of epiphysis, but with early fusion. So this has a surgical implication. Wrist, the radius, scaphoid, and trapezium, the two ulnar radial sided carpal bones, they are always absent, either partially or completely, depending upon the severity of the involvement. The other carpal bones may be disturbed to some extent, or it may be normal in majority of the cases. The wrist joint capsule, there is no cartilage, it is only fibrous tissue. The fingers presents a characteristic stiffness. Haeckel finding indicates that the index finger tends to turn inwards, so it presents a spherical grip instead of a normal cylindrical grip. So surgical implication: elbow range of motion should be normal before planning for any surgical stabilization of the wrist, else wrist stabilization is a fused elbow will cripple the patient. There should not be any waiting period considering the ulna physis fusion. You can do early surgery within first 2 years of life. So muscles, they are almost always involved in all the patients. Forearm muscles are completely abnormal. The post-axial muscles are normal. The pre-axial muscles are almost always disturbed. So what is the surgical implication of these muscles? Because standard approaches in these patients is not possible. Muscle planes are not well defined. Therefore, usual soft tissue spreading and separation is not possible. Just a minute, sir. Last two slides. Musculocutaneous nerve is usually absent. Median nerve is always present, but it is very thick. And considering the thickness of the nerve, it can be whenever we do a surgery, it can be visually confused with a radial enlarge. So we need to make sure whenever we are excising the radial enlarge, either it is not a median nerve, it should be radius only. So there are vascular anomalies. Only ulnar artery is the most prominent arterial supply. So whenever we are doing a dissection, we need to dissect and preserve the ulnar artery, else it can be a disaster if the ulnar artery is damaged. And as I told you, as the nerve is unusually thick, it has to be differentiated from fibrous enlarge of the radius. Thank you.
Thank you, Dr. Indish, for his wonderful talk. Now I would like to invite Dr. P.N. Gupta, sir, for his talk on management principles of radial club end.
Good morning, friends, once again. So radial club hand, I'll be discussing about the basic management principles and the basic surgical technique. Why you should treat radial club hand? Because that's an ugly looking deformity, often compromising the function. So what are the components of the radial club hand? One is a deformity in the wrist region. And second is rudimentary or absent thumb. So we need to tackle both. But question is, are all radial deficiencies same? They are not. Because depending on this classification which was discussed earlier, the management could change a little. So type 1 is a radius which is slightly short. But the good point is that the distal growth plate is present. So the management is a little different from type 2 where the radius is short, a little thin, but the distal growth plate of the radius is absent. And in type 3 it is very short, and again the distal growth plate is absent. The issue with the type 2 and type 3 is that they usually have a remnant of the distal radius as a fibrous enlarge. So this has to be factored in while you are treating this. And type 4 is complete absence of radius, and usually there is no fibrous enlarge here. So how do you treat them? Type 1, well, this is a type 1 deformity. You can see a little bit of thumb issue and short radius, but you can just gently stretch it. You can cast them, you can put in a splint, and you can see after a period of time, the results are reasonable in this patient. This is the and that's after a follow-up of about 2 years. At the time of presentation and follow-up after 2 years. Another patient with the type 1 deformity where lengthening of the radius has worked, but you have some anomalies in the proximal area here as well. So this could lead to a potential loss of supination and pronation, but nevertheless, in type 1, you can consider lengthening of the radius. And you have to be beware of excessive lengthening. In this patient of 22 years, he was concerned with the cosmesis. So he was after my life to lengthen it. I lengthened it, I did a bit of deformity correction. But then what happened was a contracture because the muscles are very, very tight in these patients. Not only the bones are short, but the muscles are also tight. So they are resistant to lengthening and they have a potential for contractures and finger stiffness. Type 2 leads to progressive shortening of the radius in relation to ulna and the distal growth plate is absent. The question is it worthwhile to lengthen the radius? Absolutely no, because the distal radius growth plate is absent. So even if you lengthen, you will require multiple lengthenings. So what are the reconstruction options? You have to reconstruct the wrist, you have to reconstruct the thumb. And you have two reconstruction options in the thumb, in the wrist. One is centralization, other is a radialization of the ulnar, ulnarization of the carpus. We'll discuss that. So, where they are done in both, in all the three situations, type 2, type 3, type 4. So what do you want is a wrist stability, a good wrist alignment, optimum forearm length, and a normally looking wrist. So one has to consider that the radius fuses, distal radius growth plate fuses prematurely. So you have a radius which will remain minimum of 40% short as compared to the contralateral side. And remember, distal radius is the growing end of the radius. So it is important to factor in this. If you damage the distal ulnar growth plate, it is going to lead to a grossly short ulnar, forearm. So, definitive surgical management. Now you have two options. One is you preliminary stretch the radial side soft tissues using a distractor of your choice, whatever is your choice. You can use monolateral, you can use a ring. Ring will give you more stability, right? Or you can shorten the ulna, which is already short. It is your choice, whatever you are comfortable with. So we usually do a stretching of the tight radial structures using a Elizarov fixator. And this is what you can achieve. An alternative is shortening of the ulna. So what do you do in wrist reconstruction? You do a centralization. Again, you have to stretch. And the technique is you centralize the ulna in relation to the second metacarpal. You either create a slot in the carpal bones, shove in the ulna there, or you just try to place the ulna in relation to the second metacarpal and let the tissues fibrose. And if you shave the part of the carpal bones, it is going to lead to a total wrist stiffness. And there is one modification described by creating a little slot between the scaphoid and the lunate bone and shoving it into the ulna, described in 2021. You can see the figure. I have no experience with this. So centralization will give you a stable wrist, but a stiff wrist. And if you injure the distal ulna growth plate, then it is going to lead to a gross shortening. The wrist, so-called wrist preserving procedure is basically you shift the ulna towards the radial end of carpus, or you shift the carpus, or it's called radialization of the ulna or ulnarization of the carpus. The plus point is that the motion at the wrist is retained. And this was described by Buck and Gramco way back. So you excise the fibrous analog and you approach it dorsally, dissect everything, preserve the extensor tendons. Distal ulna is freed and taking care to preserve the epiphysis and its vasculature. Hand is positioned with radial carpal bones. Have to take about 2 minutes more over the head of the ulna, and K-wire is inserted. And the tendons are transferred. Usually the ECRL and ECRB are as a single mass. So radial tendons are transferred towards the ulnar side for a muscle balance. And Pele modified this by a volar incision, and where the FCU or flexor carpi ulnaris is detached. Again, you dissect along the proximal carpal bones. You have to take care of the median nerve, which is exceptionally large here. You release the ulna, totally preserving its vasculature and the growth plate. And then you make a little pocket on the radial side of scaphoid, place the ulna in that pocket like this, and sort of ulna deviate the wrist about 15 degrees or so, right? And you fix it with K-wires. And you transfer that cut FCU along with the pisiformis to the ring finger metacarpal base. right? So you transfer it to the ring finger metacarpal base. And you may require additional shortening, or you can do a preliminary stretching. And you can appreciate the results here. You can see the motion at the wrist. You can appreciate the preserved motion. Remember, a lot of them, they will have finger stiffness as a part of the syndrome. So, some adjunctive procedures are ulnar osteotomy. If you have excessive bowing of the ulna, you can consider that. Ulnar lengthening, yes, you can consider in some of the cases after centralization, but never in bilateral cases. And one has to be beware that do not overly lengthen, otherwise this is going to lead to a problem with feeding, especially if you have done a centralization. Policization of the index finger is best left to the hand surgeon colleagues or plastic surgeon, and best timing for that is around 2 years of age. So I'm not going to discuss that. So to conclude, type 1, conservative or surgical lengthening of the radius. Type 2, type 3, type 4. You reconstruct the wrist either by centralization or by ulnarization of the carpus, whatever you call it. I'll do the second procedure, the ulnarization of the carpus. And in type 2 and type 3, you have to excise the fibrous analog to prevent relapses and balance the muscles. So you have to do the ulnar transfer of the carpus on the ulna, retaining the wrist motion and tendon balancing. Thank you so much.
Thank you, sir. Now, I would like to invite Dr. Syed, Assistant Professor in the Department of Orthopaedics in KGMC, Lucknow.
Good afternoon, everyone. I thank the organizing team for providing me this opportunity. I'll be presenting on ulnar club hand. So to begin with, it is a rare post-axial partial or a complete longitudinal deficiency of the ulna, which is 5 to 10 times rarer than the radial club hand. Estimated incidence of ulnar club hand is around 1 per 10,000 live births, and it is normally associated with the congenital skeletal malformations. The involvement of internal organs or any systemic syndromes are rare with ulnar club hand. So it's also known by many names. One of the most commonest names we hear is the ulnar club hand, and it may be unilateral or bilateral, and in some cases it's often asymmetric in many cases. So it is normally the ulnar club hand is sporadic in occurrence, and it is always and many a times associated with skeletal abnormalities. Split hand and split foot with ulnar dysplasia have an autosomal dominant inheritance. So moving on to the clinical findings, the hand is hypoplastic. 90% cases there is absence of fingers. 30% cases show syndactyly. 70% cases have abnormalities in the thumb. The metacarpals are rotated, and the thenar muscles, the tendons and the muscles are hypoplastic. And since the radius is always present, there is a support for the carpus. However, the forearm is always short, and there is a diminished range of motion in the elbow. So the child presents with usually limited function. It is normally painless. On physical examination, there is a shortened and bowed forearm. There is a decrease in elbow function, and there is loss of ulnar digits. So moving on to the classifications, the most common classification which we use is given by Bain, which ranges from type 0 to type 5. In type 0, it is a new addition to the classification in which there is only deficiencies in the carpus or either in the hand. Type 1 is undersized ulna with both the growth centers being present. Type 2 is the most commonest type in which the ulna is partially missing. There is an abnormal bar of fibrous tissue which is called as anlage, which extends from the distal side aspect of the ulna up to the wrist. Normally the elbow is functional and stable. In type 3, the elbow is unstable and the ulna is missing completely.
and hand and wrist malformations are also common. Type 4 involves an abnormal connection between the humerus and the radius. It is humeral radial synostosis, and the elbow is fixed in a position. And type 5 is meant for proximal ulnar longitudinal deficiency, in which the distal forearm remains bifurcated. So there are various classifications. Paley and Herzenberg have combined these classifications, and they have classified from type 1 to type 5. Type 1 being hypoplastic ulna with distal epiphysis intact, and type 2 is absence of distal 1/3 of ulna. Type 3 is absence of distal 2/3 of ulna, and in type 4 there is complete absence of ulna. And type 5 there is radiohumeral synostosis. So moving on to the patient workup, serial radiograph X-rays are taken, in which elbow, forearm, wrist and hand all are taken in a single sequence. And MRI sometimes is used to delineate non-calcified tissues such as the fibrocartilaginous anlage and to see the extent of it. And in addition, appropriate genetic evaluation is required, as ulnar club hand is many a times associated with genetic malformations. So in radiological findings, there is ulna is absent, there is bowing of radius. Ulna most metacarpal is normally smaller as compared to the other metacarpals. So moving on to the management. Management is quite a challenging task. The goal is to improve the function of the affected limb. In cases of unilateral involvement, minimum functional deficiency occurs. And if there is bilateral involvement with elbow flexion contractures, the patient will have difficulty in performing activities of daily living. If the thumb is absent, there will be difficulty in pinch and grasp. With internal rotation and forearm pronation, hand to mouth and hand to head motion is also difficult. And most of the difficulty occurs in the cases of radiohumeral synostosis and those with absent or deformed digits. So moving on to the treatment portion, if there is only a ulnar deviation, it can be corrected by serial casting from birth and gradual stretching of the tight ulnar structures. Normally the mild cases correct by 6 months of age. In cases of anlage, if the patient has presented early, the anlage should be excised before the occurrence of radial bowing or a radial head dislocation around 6 months of age. Excision of entire anlage is not necessary in an early presentation. However, at least 50% needs to be excised. And the wrist needs to be placed in a normal radial deviation with a long arm cast for about a month, followed by night splints which are worn for 6 months to maintain the correction. However, if a child has presented late, almost entire enlarged anlage needs to be excised because the anlage has a tendency to tether, which can cause progressive bowing. So in later ages, it is recommended that the anlage should be excised completely. In cases of bowing of radius, simple radial corrective osteotomy is advocated. If the forearm is less than usual rotation, the treatment consists of radial corrective osteotomy. And however, it is better to wait until the child is mature to make a decision about the appropriate position. In cases of radial head dislocation, treatment involves observation or either a resection or a creation of a single bone forearm. In cases if the ulna is preserved more than 1/3, then resection can be done, and if the ulna is absent, more than 2/3 is absent, then a single bone forearm creation is advocated. Ulna osteotomy has also been performed with or without ulna shortening as required. Radiohumeral synostosis release is done in young patients, and large excision is done, and in old patients it is done by distal humeral osteotomy. In cases of unstable elbow, it is preferred to do a ulnar humeral arthrodesis or a elbow ligament reconstruction. So to conclude, this rare post-axial partial, it is a rare post-axial partial or complete longitudinal deficiency of the ulna. Early intervention is essential to improve the function of the affected limb by preventing contractures. And the take-home message is that ulnar deficiency is relatively less frequent than radial club hand, It is always, it is associated with musculoskeletal abnormalities, but not with systemic abnormalities. Functional improvement is achieved mainly by rotational osteotomies. Hand reconstruction surgeries are common. Splinting has a less role. Thank you.
Thank you, Dr. Sayed. Thank you, Dr. Sayed. Now I'd like to invite Dr. Swaroop. Dr. Swaroop Sinha. He is Assistant Professor in the Department of Orthopaedics at AIIMS Bhopal.
Thank you very much. So I'll be talking on post-infective club hand-like deformities. So acquired club hand-like deformities have two components. That is, one is the shortening of the radius, because I'll be dealing more with the radial club hand type of acquired deformities. And second is the associated soft tissue contractures. So the reasons of shortening could be multitude. It could be because of a post-infective bone defect, like in osteomyelitis, or a traumatic bone loss, or growth arrest in the distal radial physis, or due to tumors like HME, or in the exostosis. In the post-infective club hand, the reasons would be as a sequelae of acute hematogenous osteomyelitis, as in this case, or the traumatic bone loss in open fractures, or secondary osteomyelitis after surgeries, that is iatrogenic. So a good-looking X-ray like these can turn into conference X-rays like these. So coming to the evaluation, we need to evaluate the patient in terms of history, clinical examination, and blood workup to look for signs of active infection, which could be a discharging sinus, signs of inflammation, or tenderness. Blood workup would show raised total counts, or raised CRP, or raised ESR. Once this is done, the deformity needs to be evaluated. It should be evaluated in terms of whether there is any passive correction of the deformity, whether it is possible on stretching. This will assess the soft tissue contracture. What is the condition of the wrist and the fingers? How much is the stiffness associated? What is the amount of shortening? How is the elbow? Because if the child is having this onset in the infancy or in early neonate period, we know that upper limb osteomyelitis can be multifocal and the elbow may be unstable, so that needs to be assessed before planning treatment. Then the neurovascular examination. Once this is done, we have to evaluate the radiographs. In the radiographs, first we need to look at the radiocarpal joint. Early onset osteomyelitis in infancy, we could have the whole radiocarpal articulation lost. So these patients behave like a congenital radial club hand. Then we have to have a look at the distal radial physis, whether the physis has any growth potential left or whether the growth potential is lost. Then how much is the shortening, what is the defect size, and what is the growth remaining in the patient when the patient has come for treatment. So we need to always individualize the patient, the treatment, and for that we need to identify the problem. We have to make a problem checklist that needs to be addressed. So we need to first define whether the patient has any active infection or not. What is the condition of the soft tissue? What is the contracture? What is the passive correction possible? What is the status of the radiocarpal articulation? What is the status of the physis? How much of shortening is present? And what is the defect size? So the management principles will depend on what problems have been identified. So for infection, the standard treatment would be debridement. Also, in children, the masculate technique using antibiotic cement spacers works really well in treating the infection and providing a bed for bone grafting. The second would be to address the soft tissue contracture. This could be addressed simultaneously with the debridement surgery by using external fixator, or in a preoperative period if the shortening is not too much with the help of stretching casts. Then we move forward if there is a absent radiocarpal articulation, then we cannot reconstruct the radius. In these cases, we need to treat it like the congenital club hand, as Gupta sir has already shown us, and this would be by doing a centralization. Coming to reconstruction of the bone defect, there are multiple options available. The first one would be bone grafting, in which the stud grafting from the fibula or from the ipsilateral ulna, that's the ulnar stud graft, can be taken, or iliac crest can also be utilized. In some cases, if the proximal bone stock is healthy and long enough, we may think of distraction osteogenesis by Elizarov principle or by a monolateral fixators. Then lastly, the management of the growth arrest itself.
if the patient has a growth arrest in the early life, if we treat it, then because there is no potential of further growth, these patients can always relapse with the deformity, and this needs to be taken care of while planning the treatment. Lastly, when surgeries fail or the defect is too massive, or if there is a proximal radial deficiency also, where the radius cannot be reconstructed, then we turn towards the one bone forearm or the ulnaeus. So this is a case example. A 12-year-old male, he had come to our institute with a 6-month-old history of distal radius fracture, treated with K-wire pinning. However, when he presented to us, because of K-wire associated infection, he had an infected non-union and a club hand-like deformity, as we see here. So we decided with the plan of an ulnar shortening osteotomy, because the patient was at the terminal phases of growth. He was an adolescent, and we planned to do a ulnar shortening osteotomy and a stud grafting with plate fixation for the radius. So the idea was to restore the ulnar variance. So this much amount of correction or shortening of the ulna is required to correct the ulnar variance. And however, the amount of bone graft required was higher than the amount that would be received from the ulna. So if the amount of correction or amount of shortening that is desired in the ulna is lesser than the bone defect, then we will have to look at additional sources of bone graft, that is from the either from the fibula or from the iliac crest. So we went ahead and fixed it. And this is the 9-month follow, where we can see that the deformity is corrected, the fracture has healed, and also that the distal radial physis has now started to grow further because the physis was spared. So there are a few more examples from literature, which I have taken from literature. So this is a one-year-old child who has come with a post-osteomyelitis defect. And we can see here, in this case, we see that the distal radiocarpal articulation is lost. So in these cases, we have to manage it like a congenital radial club hand, where centralization has been done. Another case, a 12-year-old female, again with the chronic osteomyelitis of the distal radius. Because of active infection and presence of sequestrum, as a first stage, they have treated it with the muscular technique, used a distractor to correct the soft tissue contractures, maintain the length. Then, in the final stage, they have gone ahead with the ulnar shortening osteotomy, bone grafting, and fixation with plates. Similarly, another case, 11-year-old male with the chronic osteomyelitis distal radius. This patient was also treated in 2 stages. First stage, soft tissue distraction with muscular technique, followed by a ulnar shortening and bone grafting and fixation. Lastly, this was an 11-year-old female, again with the massive bone loss. So in this case, the authors have decided to go ahead with the single bone forearm procedure, and these are the results as we can see. So these are my references. Thank you.
Thank you, Dr. Swaroop. Now moving to the case presentation, I would like to invite Vikas sir for his case.
Okay. So I'll be showing this case. I think Swaroop has already covered some aspects of this. And I would like inputs from my chairpersons. I think they're well experienced. So 12-year-old girl presented to us in June 22. As you can see, almost like pan-diphyseal osteomyelitis of the radius, stiff wrist, shortened forearm, draining sinuses. So what would you like to do, Manoj, before I tell you what I did?
So you said draining sinuses.
Yeah, you can see from the photographs.
Yeah, so obviously the first priority would be to kind of debride it get on top of whatever you do will not work if there is active infection. So you'll have to debride it, get rid of the infective focus, and probably some form of some mechanism to maintain the length while the bed settles down, while the infection settles down.
Okay.
With probably just a monolateral fixator or something like that, just to keep it out to length.
And
before
what about,
you plan definitive management.
Okay. And what about the reconstruction part?
So if you are able to kind of then get a sterile bed with no infection, then you have your various options in terms of how you're going to manage the gap. I think Swaroop alluded to it, a combination of things, shortening or masculae, all of those things come in. There are various options depending on whatever you're comfortable, once you get on top of the infection.
So as rightly Manoj has said that you need to debride this forearm first. So just take you to the story, actually what happened. In December 2020, she had this osteomyelitis in the proximal end, as you can see, which was missed, intraosseous abscess. By next 2 months, it was quite evident, but I think surgeon still ignored it. And by the next 6 months, it has involved almost like whole of the radius. And she presented to us almost a year and a half after, with this picture. So as the principles of infection go, you need to debride this. So what we planned was debridement with sequestectomy through the posterior approach by identifying the posterior interosseous nerve, okay, Thompson's approach. And this almost like more than 10 centimeter of the radius was excised. Now the next step is you have various options, single bone forearm, or and what we did in the same stage, we used this JES, a simple fixator, to stretch the soft tissues because it was like a radial club hand, post-infective radial club hand with severe stiffness, contracture. So we did gradual stretching, not acute stretching, to correct this variance. Okay? So now this was after 3 weeks. We could see that the forearm was well aligned and we could correct the ulnar variance. So this is after 3 weeks. So what is the next? Kapil, what would you do now? You have regained the length.
Yeah. So I think it's 3 weeks from the point when the infection is quiet is, I think, early for me to put in any reconstruction. So I'd probably keep it stretched out to length. Maybe the fixator across the wrist will need to be removed. And then I'd probably see maybe if I could stick a long fibular strut graft in that as a choice for bridging the gap. Yeah.
Okay, so that's what we did probably after 6 weeks. So waited for another 2 to 3 weeks. We did free fibular grafting, punched it, and this was the intra-op picture, and fixed it with 2 plates with a K-wire across the distal radial ulnar joint. So bed was sterile. We added some bone graft also. So that's the latest photograph. She is doing well, and functionally she is almost normal. As you can see, she is able to use her hand for all the day-to-day activities like cooking, another. So I think this is one of the options, instead of going for single bone forearm. So what you have to plan is a stage procedure. So don't try to combine all the modalities in one go. Debridement, stretching, and in the last, bone grafting. So thank you very much. Yeah. Any questions or opinion about this?
Thank you, sir, for interesting case. Now I would like to invite Dr. Rahul. Yeah.
Good afternoon, sir. Myself, Dr. Rahul, I'm a pediatric orthopedic resident, AIMS Rishikesh. Today I'm going to present a case on the surgical management of radial club hand. A 4-year-old male child presented to us with bilateral upper limb shortening since birth and radial deviation of bilateral wrist, absent thumb on the right side with rudimentary thumb on the left side. Dominant hand was left. Functional impact was marked disability on the right hand. Only cylindrical grip was preserved on the left hand. No significant birth history. Developmental milestones were normal. Upon inspection, bilateral forearm shortening. Right forearm was shorter than left. Wrist and hand were directed 90 degree radially. Absent right thumb and left rudimentary thumb were present. Upon palpation, both bones palpable at the left forearm. Movement, shoulder range of motion were normal and bilateral forearm supination, pronation absent. Bilateral hand radially deviated, active range of motion, finger present. Elbow range of motion, the patient enjoy elbow range of motion of 90 degree and the palmar flexion was 10 to 30 degree on the right side and same on the left side. These were the pre-op x-rays when patient presented to us in 2022 December. Diagnosis of bilateral radial club hand, modified Bain type 2 left side and type 4 right side with rudimentary thumb on left side and absent thumb right side. Procedure was done Pallia's ulnarization along with deviation of carpal bone ulnarly and excision of rudimentary thumb. This was the original article given by Drawer Palle 2017. This was intraoperative image. We have taken a volar incision, Z shape, and we have transferred the carpal bones ulnarly, followed by creating a radial pocket on the radial side of scaphoid and placing the head of the ulna on the radial pocket, following which we have excised the PC form along with FCU and transferred it over the dorsal aspect of the fourth metacarpal base. These were the post-op x-rays and after ulnar shortening osteotomy, it was fixed with the K-wire. Follow-up patient presented to again after 1 year in January 2024. We can appreciate there is a correction of the radial deviation on the left hand side. Previously patient enjoyed only a cylindrical grip on the left side. On the following follow-up, the patient can able to eat from the left hand side and patient's elbow range of motion were normal. These are the current follow-up videos of left hand side. Patient can able to write with left hand and can also eat his food, and he can also able to dorsiflex his wrist up to 20 degrees actively. These were the follow-up x-rays of left hand and this was the current x-ray. The hand to forearm angle preoperatively was 70 degree, which was corrected to 18 degrees upon follow-up, and the range of motion of dorsiflexion improved to 20 degrees on the left hand side. Grip strength also improved. In February 2024, he again underwent Pallia's ulnarization for the right hand. These were the pre-op x-rays in the February 2024. Intra findings, medial nerve was shifted radially and FCR palmaris longus were absent. We have isolated the PC form along with FCU and transferred it dorsally and sutured it to the base of the fourth metacarpal base so that it will act as a dorsiflexor of right wrist. These are the post-op x-rays. The ulnar shortening was done along with plate fixation and 2 K-wires were used. One K-wire passed from the ulnar head to the scaphoid and another K-wire passed from the base of fifth metacarpal. These are the current follow-up x-rays of the right hand. The hand to forearm angle were improved from 24 degrees to 10 degrees on the right hand side. These are the pre-operative clinical pictures, and this is the current post-op clinical picture. The patient's radial deviation also improved on the left hand side. These were pre-operative videos during February 2024. This is the current video. The patient can able to hold object from his left hand fingers. We have not done the polycization because patient presented to us at the age of 4 years. So he had already developed the left hand dominance. Take home message was to parallel ulnarization, shift the hand and wrist over the ulna, avoiding traditional radialization, improve function, enhances the hand alignment, grip strength and overall functionality, growth and stability, promotes the balanced growth by using ulna as a primary weight bearing bone. It also lowers the risk of deformity recurrence as compared to other treatment options, better outcome. It provides superior cosmetic and functional results, significantly improving patients' quality of life. Thank you, sir.
Thank you, Dr. Rahul. The house is open for a couple of questions. Any questions? So, if there are no questions, and as we are running late, I will request the house that we'll do all the felicitations after the sessions, just before the lunch. So we are moving on to the next session. I invite Dr. Swaroop Sinha to kindly moderate the next session.
Thank you, Dr. Pratik. So the next session is on miscellaneous forearm and wrist deformities. I would like to invite our chairpersons, Dr. V.K. Gautam sir, Head of Department Orthopaedics at Sharda Hospital, Dr. Matthew Varghese sir, Senior Consultant and Head of Department, St. Stephen's Hospital, New Delhi, Dr. Rakesh Kumar, Professor, Department of Orthopaedics, Sharda Hospital, and Dr. Amit Srivastav, Associate Professor in the Department of Orthopaedics, UCMS and GTB Hospital. So I would like to invite the first speaker, Dr. Sudhanshu Bansal from Cord's Clinic, Ludhiana.
Yes, yes, this one. This one. Pointer. Just run it now. I'm Dr. Sudhanshu Bansal. My topic is Madelung deformity. This was described by Otto Madelung in 1878. The Madelung deformity is a deformity of the distal radius in which there is a deficiency on the ulnar and the volar surface of the distal radius leading to this deformity. The classical congenital form of the deformity is proposed to be due to the abnormal Viker ligament leading to the restricted distal radius growth on the volar ulnar corner of the radius. This is the presentation of a picture to depict how it causes the deformity. This triangular black is Viker ligament. With the growth due to the pressure over the physis, medial physis of the radius, this causes ulnar deviation of the radius. Presence of the Viker ligament on the volar aspect with growth causes pressure over the radial physis on the volar aspect, leads to the ulnar deviation. Volar deviation. There are some conditions which look like Madelung deformity. They can occur because of the post-traumatic injuries of the physis, such as gymnastic wrist due to the repeated microtrauma to the distal radius physis. This picture may look like Madelung deformity. Some tumors like multiple hereditary exostosis, it may be associated with Turner syndrome also. The congenital classic type is most commonly associated with Larry-Wheel disc chondroosteosis. This is a triad of bilateral symmetrical Madelung deformity, short stature and mesomelic disproportion. It is, in this, the entire radius is usually involved. It is more functionally and aesthetically affected, and it requires more complex surgical interventions, and the risk of complication is more in this type. Presence of the Viker ligament easily differentiates between the true Madelung deformity and the Madelung-like conditions. Girls are more affected than the boys. Typically, they present around 8 to 14 years of age. It is a progressive deformity. It comprises less than 1.7% of the total pediatric hand deformities. Typically, kids present around peak skeletal growth. The main concern is cosmetic concern, then wrist pain, limited range of motion, decreased grip strength. X-ray is sufficient to diagnose this condition. There is bowing of the radius is seen. There is exaggerated volar and ulnar tilt of the distal radius. Carpal subluxation is seen. Due to this herniation, the proximal row look like a V-shaped pattern. Dorsal subluxation of the DRUJ. Flame-shaped distal radius notch is seen on the ulnar aspect of the radius, which is pathognomic of Madelung deformity, and positive ulnar variance. Radiological type can be distal radius type, it can be entire radius type or reverse Madelung type. In entire radius type, there is a gap between the radial head and the capitulum, which has to be more than 4 mm to mention it to be entire radius type. The entire radius type is usually due to Larry-Wheel dyschondrosteosis. And the third type, which is reverse Madelung type, the ulnar is dislocated on the volar aspect rather than prominent on the volar aspect rather than on the dorsal side. MRI is usually not recommended. It is the best modality to identify Vickers ligament and a bar. Treatment is based on symptoms, severity, cause, and timing of diagnosis. So, if any kid presents with the mild symptoms, it is better to try conservative measures like NSAIDs, splintings, and drag on until it becomes too symptomatic or bothering. If skeletally immature patient, the conservative management fails, then Langenskiol procedure is done, in which the physeal bar is ablated and fat is filled, Vickers ligament is resected. If required, ulnar epiphysodesis or shortening is done. It is suggested that better to wait and drag on until we can do a radial dome osteotomy rather than doing this. But if it is symptomatic or severe, we have to do it. In skeletally mature, as mentioned, distal radial dome osteotomy is done, and ulnar shortening osteotomy or ulnar head resection according to the skeletal maturity and deformity. Most common complication is revision procedure, in which the secondary ulnar shortening osteotomy is required. Risk of extensor tendon rupture is there, mostly the ulnar extensors. Wrist pain, wrist arthritis. Wrist arthritis is mostly seen in severe types such as conditions which are seen in Larry-Wheel dyschondrosteosis. Some example of a skeletally immature child in which the dome osteotomy was done, fixed with K-wires, and ulnar shortening was done. Another example of 15-year female who presented with one side deformity. Her main concern was cosmetic and with mild pain and limited rotation. For her, the dome osteotomy was done, fixed with the plate. For 2 weeks, the radioulnar wire was placed to develop some fibrosis and some stability. This is her left side is the pre-op clinical picture, right side is post-op clinical picture. There is significant improvement in the lateral aspect, lateral profile. Patient is happy, doctor is happy with full roam, pain-free roam. Another patient, 12-year girl who presented with severe pain, bilateral deformity, right more than the left, limited roam, and she gives a history of 1 month ago she had a twist injury at school. Following that, she had very severe pain and limited range of motion. She also gives a history of 3 years ago. She had a fracture which was managed by a quack with the bones, with a cast. There was no radiological or X-ray was not there. So she was given a cast for 4 weeks after this presentation, and there was no improvement seen. This is her X-ray picture which shows volar ulnar displacement of the ulnar head, prominent ulna on the volar side, radial bow. There is subsidence of the lunate, increased radial inclination, ulnar bow of the radius in the midshaft. There is a gap between the radial and capitulum. So it can be, I don't know, it is complicated because of the fracture or it is mix of type 2 and type 3, because there is a gap between the radial head and capitulum, and there is a volar prominence of the distal ulna. This is our other side X-ray, which also shows some midshaft radius bowing. So type 2 or maybe associated with Larry-Wheel dyschondrosteosis. This is her 2-month follow-up X-ray. For her radial bowing was corrected. She had ulnar bow, dorsal bow, and rotational deformity. That was corrected. Distal radial slope was attempted, some correction, but because of weak bone, couldn't correct fully. Ulnar shortening and distal ulnar epiphysodesis was done. This is just 2-month follow-up. She's under physio with K-wire in situ, but she is now pain-free. Just a broad, if conservative fails, then less than 10 years of kid ligament release and physolysis can be tried, but they may need another procedure later on. 10 to 14, if severely affected, then we can do ligament release, radial osteotomy, and ulnar shortening. If not severely affected, ligament release, radial osteotomy, or this ulnar epiphysodesis. Thank you.
I just want to ask the pediatric orthopedic surgeons who are present in the house, how many of you could ever resect only the Wecker ligament and check the progression of the disease? Does the patient ever come at that stage? And real practical experience when only the Wecker ligament to excised and the progression was delayed amongst the people who are present here. Generally, they present during the second growth spurt when the deformity is high. So anybody having experience simply with the excision of ligament and checking the progression? I don't think, nobody? Anybody in the group? Because this appears to be a prophylactic procedure. Whether everybody has been able to do practically, that is my question. He comes with a deformity. Now suppose he comes a little early with some deformity. Will you like to interfere in this manner, or will you like to wait till second growth spurt? They all come late. In India, they may be coming late when the cosmetic deformities. So you want to say something? Yeah.
So I don't have any experience of releasing only the Vickers ligament, but there are papers which suggest significant improvement or complete remodeling only with this thing.
Yeah, literature probably describes isolated cases, but I am asking the people who are sitting in this crowd in India whether we have been able to do this or not. Okay.
Thank you, Dr. Sudhanshu. Now I would like to invite Dr. Somesh Virmani. He is consultant pediatric orthopedic surgeon at Sarvodaya Hospital, Faridabad.
Good morning to all dear friends and respected seniors. Okay, so today I'm going to talk to you about forearm involvement in multiple exostosis. Probably this is the most controversial topic which we are discussing today. There are other controversial topics also, like Perthes and all, but still we reached to some consensus in the consensus statement in Perthes, but I don't see, while reviewing the literature, we are anywhere near the consensus in this. So HME, we all know, involves the long bones, has genetic connection. Forearm is involved in more than 60% of cases of multiple hereditary exostosis. And basically, we all know forearm is like a single long joint, and any shortening or deformity of one bone will create problem in the whole of the forearm as well as the other joints. So that's what is happening probably here. Depending upon the location of osteochondroma exostosis, the bone becomes short, bowed, and then affects the distal radioulnar joint or the proximal radioulnar joint or even the elbow joint. So what exactly is happening? Because if there's a deformity, if there's an osteochondroma, most commonly in the distal ulna, the ulna will become short. Radius is also affected, but less commonly. Radius is not that short. It doesn't mean that the length is not that much affected, but ulna is significantly affected, and that has long-term sequelae also. Once the ulna is short, it leads to again like teethering effect on the other bone, maybe because of ulnar collateral ligament, and just like we were discussing just some time back, ulnar club hand. And once it happens, radius also starts to bow, and either it will dislocate proximally or there will be a carpal slip. Most of the times, one of them will occur, but there are cases, I'll also show a case where both the things are happening in a single patient. Clinical presentation, mostly these patients will have, most common presentation will be deformity. Restricted range of motion is there, but usually after the joint has affected, and that also mainly the rotations. Pain is quite a late presentation, not initial in the pediatric age group. Visible deformities, of course, there. Along with that, sometimes the osteochondromas are palpable, and sometimes what happens that you can even palpate the dislocated radial head also. Radiology, I think our diagnosis is very well managed with the X-ray itself. It's self-explanatory. Bones will be short. There will be bowing of the radius. Along with that, osteochondromas are visible, and if radial head subluxated, that is also there. Although there is a role of CT and MRI, I'll not say it's not there, but that's mainly for treatment planning, particularly in the complex cases when radial head is subluxated, there is deformity of the proximal radius along with the distal radius, then you definitely need a CT or MRI. There are a few important parameters, the importance of which I will be discussing in next few slides. Ulnar variance, we all know. Do we have a marker, please? No, okay. So ulnar variance, we all know, difference between the length. Total ulnar length, I'll talk to it, how is it important. Percent ulnar length is basically the ratio of the radius and the ulna. And total ulnar bow, how much is the ulnar bow, because this has an implication on the stability of radial head, which we'll be discussing. Radial articular angle, that happens because there's a tilt, as I said, because of the shortening of the radius, articular surface also starts to bow, which ultimately can lead to carpal slip. Carpal slip is measured here. You can see in this way, we see how much lunate is covered with a longitudinal line, depending on whether carpal slip can also be quantified. So coming to few classifications, not few, rather there is only one classification which has been universally accepted, or I don't know what, which is Masada, way back in 1989. Till date, we use that classification only, although most of our studies have found it to be insufficient. So what is there in that? Masada classified into 3 types. Type 1, when the exostosis in the distal ulna, and ulna is short. And as I said earlier, distal ulna osteochondroma is the most notorious to cause problem. Ulna will be short, radius will start to bow, and bowing of radius will ultimately lead to radial head dislocation or carpal slip. Second type is when the radial head gets dislocated. In that, Masada classified them at 2A and 2E further. When there is exostosis in the proximal radius, it is 2A. And when the ulna one, which is just causing the radial head dislocation because of length or bow, it's type 2B. And type 3, which is less common, is in the distal radius causing the radial head shortening. But many osteochondromas, particularly the distal ones, are not classifiable by this. And it was recognized by many people. And then 2017, Joe modified for that and introduced 2 more types, type 4A and 4B, in which type 4 is with the distal osteochondroma in both the bones with stable radial head. And 4B, when the radial head is dislocated with it. As I said, there have been various studies to look for their reliability. Most of the studies have found they are not very reliable in classifying. Latest one being in 2023, and so much so that search is still continuing. In last month only, there has been a new classification in Journal of Hand Surgery classifying for the MHE only. Coming to treatment. So treatment, as we all know, we want to preserve the range of motion and prevent pain. That's what we want to do. First of all, non-surgical treatment. Mild cases, we'll try to manage non-surgically. There are surgical indications. Surgical indications, severe deformity, pain, or functional limitation, or progressive dislocation. If we are able to catch the child at that stage, when the radial head has started to slip, that's a very good time to intervene. And carpal slip. Masada has also given his own protocol for all the types, and it was almost completely surgical. The various options, the surgical options which we have at this stage is, of course, first of all, it will be osteotomy because it's a deformity. Depending upon which bone is involved, how much short it is, we plan that corrective radial or ulnar osteotomy. Excision of osteochondroma, that is almost a part of any surgical intervention we'll do here. And then lengthening procedure, which is the most glorified procedure, although results of which still need to be testified, that ulnar lengthening with the fixator, or we can do radial shortening also. And then finally, if radial head is also dislocated, then radial head management. So while reviewing this literature, and otherwise also this topic is very close, I was happy that I was given this, because in my fellowship we used to do a lot of ulnar lengthening, and I was given the task of researching this. Then at that time, I'm going to talk, another paper from Masada group came which showed that long-term results of all the lengthening procedures are not great. So that time we probably put a hold on ulnar lengthening procedures. So the questions which at that time only and now also were that, whether to intervene or not. If to intervene, when to intervene, because child come at the age of 2 years also and at the age of 12 years also, when to intervene, and which intervention is best, lengthening, shortening, or just excision of osteochondroma. And what are the long-term results? I think that is the most important thing. What are the long-term results, which is important? Because many short-term studies are there which are telling that ulnar lengthening or the other procedures work very well, but there's a very severe paucity of long-term results. I could just find 2 studies, this which I was talking to you about, which came when I was in the final part of my fellowship. This was by the Masada himself, the Masada group only. I think they reviewed the same patient which they did in 1989, and there they concluded that long-term results of whether it was corrective osteotomy or lengthening, they are not beneficial. So they recommended just one procedure which is most beneficial, was excision of exostosis. Another long-term study in 2012, they say that symptomatic radial head instability is probably the good indication where you can plan ulnar lengthening. But otherwise, if you are doing prophylactic when you are not suspecting radial dislocation or other conditions, it may not be of much use. They also go on to say that even severe deformity without dislocation can be managed conservatively. So, okay, so looking at all this, what I could realize, what we can realize, that critical event in the treatment algorithm is planning probably is the radial head dislocation, because that is the point when the whole prognosis can go wrong. So we need to intervene before radial head dislocation. So, but how to predict and how to find that radial head dislocation is going to happen. So there are a couple of parameters for that. This was a study by Drawer Pelle group, and few others are there. So 3 things probably are important. Number 1, involvement of distal ulna. If distal ulna is involved, there's a high chance of radial head dislocation. Third thing, total ulnar bow, all right, and percent ulnar length, which I told you in the beginning. If it is 81% or the percent ratio of the length is 0.9, more than 0.9, less than 0.9, then there's a chance that dislocation can occur and we should intervene early. Another thing, proportional ulnar length to height of the child. If it is more than 12%, that can also cause problem. Okay, so finally, I'll just wind up here. Again, the same questions. Depending upon all these studies which we could gather, that probably there's no indication for surgical intervention, because long-term studies have indicated that even if we do too many surgeries, long-term results do not help much. Even the last study which I quoted was patient-reported results were also there in that. Yes, if there is some pain, then early simple excision can help, but the only thing is it can recur and he may need another excision. Lengthening procedures or hemiophysis can be useful if we are anticipating the radial head dislocation. Okay, so I'll just wind up here. Thank you.
Thank you, Dr. Somesh. Now I would invite Dr. Manoj Panvan sir for his talk on radial ulnar synostosis.
Manoj, आपको सुन. Thanks, Prateek. Very nicely organized CME, and I thank Dr. Gautam and Anil for drawing up this nice program on not a topic which is often discussed, upper limb non-traumatic disorder. So I'm going to talk about another rare condition, much rarer than hereditary exostosis, on talking about congenital radial synostosis. It's a rare, as I mentioned, it's a rare disorder. Etiology is unknown. Fundamentally, the reason for it is that the growing limb, which the forearm develops as a single segment, does not separate out longitudinally. Normally, that happens around the 7th week of gestation, and that, for whatever reason, does not separate out. It's associated with various syndromes, but no single identified genetic cause. It's commoner in boys, 60 to 40, and bilateral involvement is the dominant presentation. The clinical presentation is usually neutral to pronation, so you don't really see synostosis with the forearm in supinated position. Milder deformities are well compensated by wrist and shoulder motion, so you may go through entire life without being aware of it. They usually present when the child becomes old enough to kind of understand or is able to convey the functional activities where he or she is restricted, which is usually washing, where you want full supination, when they have to kind of receive something with the palm of the hand, or when they have to carry something in their, holding a tray or a plate. And the usual age of presentation is around 5 to 6 years. So classifications, historical, it's Wilkie and Tagjian, which I don't think is used in current literature. They refer to the presence or absence of radial head and things like that. Most articles now quote the Cleary and Omer classification, wherein the type 1 is the fibrous synostosis, where you don't really see a bony synostosis. Type 2 is ossified, but the radial head is in its position. Type 3, where it's dislocated posteriorly with a hypoplastic radial head. And type 4, where it's dislocated anteriorly and the radial head is deformed and mushroom shaped. So that's what is usually used for people presenting their outcomes following treatment. So the indications for surgery, indications for if there are mild deformities and it's an incidental discovery with no functional limitation, nothing needs to be done because it's well compensated. And in today's day and age, most activities require your forearm to be in the pronated position. So you can compensate it very well. Okay. So historically, the cutoff value which has been told was a pronation deformity more than 60 degrees, one should consider surgical reconstruction. Now, there are lots of questions being raised about it. More important than an absolute value, because you may have a lesser pronation deformity, but if that child or the individual requires certain functional activity, and even if it is a lesser pronation deformity, you may consider surgical reconstruction. So functional impairment is more important than an absolute number or degree of deformity. There are certain relative indications where there is bilateral deformity and you want to kind of change the functionality of one limb versus the other. And the good time to reconstruct this, or with lesser number of complications, is usually 3 to 7 years, or certainly under 9 years before the child is adapted to his functional issues. But sometimes you have to kind of reconstruct older children, and I'll show you a couple of cases with regard to that. In terms of surgical options, so you have what is called as a mobilization procedure, which aims to restore the forearm rotation by excising the synostosis and interposing it with various tissues, including vascularized flaps, bone wax, silicone, and stuff like that. Traditionally, they have had bad outcomes, apart from the person's own series where the person who has discovered the procedure or is reporting the procedure. Apart from those individuals or those hospitals or those series having good results, by and large, most people have had no great results with this, and so I do not have any personal experience, so that's where things are. The overwhelming kind of surgical reconstruction which most people do is a corrective derotation osteotomy. Having said that, there are controversies in terms of what its indications are. I told you about the degree of deformity as well as the technique. And by technique, I mean some people do it staged, wherein they do the osteotomy, but they do not correct it, go back in 3 weeks later, and then derotate it to minimize the neurovascular complications. Should you do a single osteotomy or a double osteotomy? What is the level of osteotomy? There are controversies. Should it be proximal? Should it be distal? Proximal osteotomies carry higher risk of vascular complications. Fixation or not, if you're doing a stage procedure, you just put it in plaster. 3 weeks later, you correct it. So these are the areas which are controversial, where there is no clear guidelines. In addition to that, the other controversy is, what is the end point of correction? What is it that you're trying to kind of correct it to? Or so you have 60 degrees or 70 degrees of pronation. Should you be correcting all of them to a certain absolute figure? Should be the non-dominant hand be different from the dominant hand? These are the areas which are still not very clear. In terms of the level of osteotomy, at the synostosis which is originally described, we all now know that that's a small area of correction wherein tissues get corrected, the neurovascular structures get stretched out, and the incidence of complications, neurovascular complications, are much higher. Single osteotomies have been described to avoid that. Usually, it's been described for both ulna and radius. Usually, some people, it's done for the distal radius as well. But nowadays, most people do a 2-level osteotomy, which is a proximal ulna distal to the synostosis, and a distal radius. And that's what the majority of people would prefer for the degree of correction, maintenance of correction, and as well as ease of rehabilitation. In terms of stage, 2-stage procedures, like I mentioned, wherein you do the osteotomy, do not correct it, go back in about 3 weeks later, under anesthesia, derotate it. So you have soft callus by which you can derotate it, almost like a osteoclasis. So that's been again to kind of minimize neurovascular complications. Having said that, most people now again do single-stage procedures. With regard to fixation or not, again, especially with 2-stage procedures, plaster and simple KYs have been used technically for the argument for ease of surgical procedure, as well as, but they have problems with loss of reduction as well as loss of correction as well as union issues. So most of the time, these are now fixed. So in terms of the endpoint of correction, these are the factors which one considers, whether it's unilateral or bilateral, or whether it's dominant or non-dominant. But having said that, social and cultural factors play a huge role. And most people now try to correct it, irrespective of whether it's dominant or non-dominant, to about slight supination. So depending on the quantum of correction, and no difference actually between the dominant or non-dominant hand. Poorer outcomes are generally with older children, where you do mobilization procedures, where they recur, and osteotomy at the synostosis level, as I mentioned, and large quantum corrections. And the usual complications, I have again kind of touched upon that. So I'll just take you through a few cases. So here is an older child. This is a 14-and-a-half-year-old male who had severe pronation deformity. This is a type 2, where the radial head is in position. And there are ways to kind of actually quantify the objective functional deficits, rather than asking the child what are this thing. Jepson and Taylor hand function test is a useful way of quantifying what is preoperatively to quantify what is the level of functional deficit. So my preferred technique is a 2-level osteotomy, single stage with fixation. And as you can see that the proximal forearm, if you look at the outline of the proximal radius, you can see that's pronated. And you compare to the post-opposition, what you're familiar with the radial crossover sign, you can see that the proximal fragment is pronated and the distal is in neutral position. So you have so I fixed it in about 10 degrees of supination. Okay, and the opposite side was also done much later, ended up having a transient median nerve neuropraxia. So these are things which you need to be aware of, especially with large corrections. Here is another older child again, presented with one side much more severe deformity, the left hand, and she was having genuine problems in terms of carrying her books, and she could participate in the decision making as opposed to a younger child, and she really wanted it doing. And I don't have long-term follow-up, but about 3 months, her reported improvement is almost 80% improvement in her functionality. And it's very difficult sometimes in a clinic setting to kind of extract from them what their functional issues are. Again, here is a 2-level osteotomy. If you find the tissues very tight, do not be rigid about fixing the second bone. You don't need to, because you just need a stable construct. In this particular case, we actually shortened the ulna just so that it could sit better. So a single bone fixation would give you fairly kind of stable construct to mobilize earlier. A younger child, about 3-year-old, which is an ideal indication, probably 3 to 5 is a good kind of age to get. This is the same case, I'm just winding up on that. This is a younger child. Both forearms are fixed in hyperpronation, almost about 80-90 degrees, full function. This is a type 3, wherein you can see that the radial head is dislocated. Okay? sequential reconstruction. We've done only one side. And here again, small bone, sometimes it's very difficult to kind of fix it. All we could get was a plate on the ulna side. The radius was translated so much because of the rotational malalignment. You can leave it well alone. Nothing will happen. It will heal up in the new position. As you can see during this follow-up, you can see that the radius unites. So don't be rigid about fixing both, because you have a closed compartment, and stacking 2 implants can increase the risk of potential neurovascular complications. So in conclusion, I've touched upon the indications to intervene, which is a combination of functional deficit rather than an absolute value of the degree of deformity. Less important in terms of whether it's unilateral or bilateral, or dominant, non-dominant. But again, individual, social, cultural, and other factors contribute to the decision making. Ideal age is 3+, 3 to 7, 8, 9 years. That's a good time, because that's the age when you can put in a small semitubular plate for this. Single stage, double level osteotomy with fixation is the preferred option. Having said that, there are people who still do staged surgeries, use plasters, there are reported series of reasonably good results with them as well. And always be on the lookout for neurological and vascular complications, especially for large corrections. Thank you.
One way to reduce the neurological complication is to do a routine shortening of both the bones.
Absolutely. Yeah.
So when you do that, so the structures are very tight. It's not just the bones, the soft tissues are also very tight. So if you try to do a correction without doing shortening, you're very likely to get a neurological deficit. Also, you're likely to get a compartment syndrome. So anterior interosseous nerve palsy is because of compartment syndrome, deep compartment syndrome. So the way to avoid that is to do a routine shortening, and when I do it very limited, but I always do a shortening of both the bones. 2 different levels, but shorten both the bones to the same extent.
Good afternoon, sir. I am presenting a case of single bone forearm procedure for the management of a rare presentation of forearm deformity in a patient with Masada type 2B hereditary multiple exostosis. To start with introduction, hereditary multiple exostosis is a disorder of uncontrolled bone formation and is characterized by several osteochondroma in the long bone. About 30 to 60% of HME has a forearm deformity in one or both limb. A case of 11-year-old right-handed female student presented with abnormal protrusion from the posterolateral aspect of the proximal portion of the forearm, which was associated with pain and progressive deformity of the left elbow, and she had multiple osseous swelling over the distal aspect of both thigh and over the proximal and distal aspect of the both leg. On clinical examination, there was an abnormal bony protrusion in the elbow, rotated with forearm rotation, which was dislocated radial head, and elbow or range of motion was limited from 10 to 110 degree of flexion. On clinical forearm range of motion limited from 60 degree of supination to 0 degree of pronation, and patient also had a genu-valgum deformity in the left knee. On radiological examination, there was proximal migration of dislocated radial head, and which was dysplastic and convex, become dysplastic and convex, and bowing and shortening of the radius and ulna. Sessile osteochondroma at the distal end of the ulna, and also there was multiple osteochondroma over the long bone. On management, according to Masada et al., type 2 in type 2B, there is a osteochondroma of the distal ulna with shortening and dislocation of the radial head, which is managed with excision of osteochondroma, osteotomy of radius, and gradual ulnar lengthening. So traditionally, HME Masada type 2B have been treated with gradual lengthening using external fixator, but its efficacy in reducing the dislocated radial head has not been established. So single bone forearm has been chosen as the surgical option for our patient because of the severity and the chronicity of the symptomatic deformity at the presentation, which include loss of articular surface, degenerative arthritis, and osteomyelitis. Brief surgical, these pictures are showing brief surgical step of plant skin incision and exposure, and osteotomy site and excise segment of the radius and ulna. Finally, mobilization and fusion of proximal radius to the distal proximal ulna to the distal radius, and which was fixed with DCP plate. These are the immediate pokes of X-ray and 6-week follow-up, in which bony alignment was good, and bone graft also seen in the place. Radio-ulnar fusion using plate construct. Recent follow-up about 1 year, 1.8 year after the surgery, showing the radio-ulnar fusion, and the genu-valgum deformity was managed with medial distal femoral hemiepiphysiodesis using 8 plate. Recent follow-up after 1.8 year after the surgery, there was no recurrence of the deformity, and full pain-free range of motion of the elbow, about 0 to 130 degree of motion. The loss of forearm rotation compensated by elbow and shoulder range of motion. The genu-valgum deformity was also corrected, and recent follow-up after these are clinical pictures showing she had satisfactory function without any work limitation. Overall, the patient was extremely satisfied with the outcome. The take-home message is single bone forearm is an additional treatment option in the selected severe forearm deformity with dysplastic proximal radius for more rapid return of fraction. The major limitation of this procedure is restricted pronosupination. Thank you, sir.
Thank you, Dr. Dilip. Now I'll invite Dr. Ashish for his case.
Good afternoon, respected faculties. I am giving a case presentation directly over the case. My patient is 4-year-old female child with history of swelling in hand and discharging sinus since last 3 months, with history of intermittent low-grade fever and no history of trauma or discharge of colored granules. So the clinical presentation of the patient, she presented with a linear encircling scar mark with a discharging sinus over the volar aspect of the wrist with sprouting granulation tissue. The examination part, distal circulation and capillary filling in the thumb and fingers were normal, gross sensations were intact, and active finger movements were present. So further we decided how to approach the patient. We decided to do the basic investigations, which are mostly normal, except some raised ESR, and the radiographs, which initially shows no significant bony changes, but only some soft tissue swelling around the wrist joint. So we come, what will be the diagnosis? So mainly the diagnosis will be clinical. So we suspecting a foreign body inside with a dhaga or maybe a rubber band. The points in favor of the diagnosis is usually small children, usually chubby, restricted vocal abilities, clinical presentation of discharging sinus, linear soft tissue swelling around the wrist joint on radiographs. Retrospectively, we asked the parents, but they did not give any history of band or a thread being tied over the wrist. Other differentials of this presentation is can be chronic osteomyelitis, osteoarticular tuberculosis, or mycetoma. So this condition can be missed easily if clinician does not have a high index of suspicion and can be mistreated as TB or osteomyelitis. So how do we further corroborate our diagnosis? To confirm our suspicion, in our case, we went ahead with a MRI, which revealed a curvilinear thin foreign body with a synovitis of radiocarpal joint. We can additionally also do ultrasound, which can give similar findings, but it is heavily user dependent, and it can also be used as an alternative to MRI in detecting foreign body in case of infants and toddlers who require sedation for MRI. So these are the MRI findings which reveal the foreign body, but most of the structures are obscured because of granulation tissues. So these are coronal images, and these are sagittal images, which shows a rubber band below the neurovascular bundle and extensor tendon slips, but superficial to finger flexors. So next question arises, how do we plan for the surgery? Broadly, we have 3 important questions to be asked. First, how do we plan for the incision? Is it vertical or horizontal? how do we plan for removal of the foreign body? Will it be piecemeal or in toto? And what do you anticipate in the follow-up? So the first questions to be answered here. The foreign body trajectory is horizontal. So after excision of dense scar tissue, are we planning for vertical incision? So the answer will be no, because we are not planning for any biopsy. We are planning for excision. If we give the vertical incision, it will also lead to retraction of foreign body, or it may also cause the breakage of foreign body. So we went ahead with the horizontal incision along the circumferential band. Dissection revealed the foreign body rubber band within the tissues. The tendons and neurovascular structures were in continuity, although engulfed in a granulation tissue and adherent to each other. Rubber band found deep to the median nerve, as in the image. So next question will be how to remove the foreign body. So slow and meticulous dissection should be done to remove the foreign body in toto as much as possible, and make sure not to leave any fragments behind. Watchful of neurovascular structures, as rubber band may pass within the substance of tendons and may be missed during the removal. So this is the extracted specimen. It's approximately 4 centimeters long. So the discussion is a rare syndrome first described by Hochboom and Stephens in the literature as today commonly known as Dhaga syndrome or rubber band syndrome. Due to rapid growth and increase in the circumference of the wrist, the bands cut through the soft tissues around the wrist. As the skin epithelializes over the thread or band, it can become completely invisible. This slow process of penetration is mostly painless, and sometimes it cuts through the tendons, causing a constricting sign on the X-rays, results in distal edema, loss of function, and sometimes damage to neurovascular structures. Rubber band, in comparison to Dhaga, shows penetration into tissues at a more faster and deeper planes due to its more elastic and non-biodegradable nature. So the treatment of choice is removal of the foreign body along with the exploration and repair of the damaged structures. In our case, wound was completely healed in 4 weeks with the antibiotics after the removal. At follow-up, gross normal sensation and active use of hand was present with the child. So the take-home message is simple. Delay in diagnosis and treating due to lack of awareness, rarity, and resemblance to other diseases leads to the deterioration of symptoms. The common complication can be, it can also present with acute compartment syndrome, tissue necrosis, residual motor weakness in view of tendon injury, painful neuroma in view of nerve injury, persistent discharging sinus in view of retained foreign body, or permanent functional impairment. Thank you.
Thank you, Dr. Ashish. Now, with the permission of our chairpersons, we can invite any couple of questions for this session.
So, first of all, I must compliment Dr. Ashish. That was an eye-opener. It was very good. Now, the question is for Dr. Somesh. Dr. Somesh, see, I mean, I know the presentation was very good. I mean, what I mean to say is that on one hand, you said that we are interested in treating a symptomatic radial head dislocation. Yes, sir. And immediately after you show us Paley's paper in which we are predicting which patients are going to have a radial head dislocation. So why are we predicting?
Yes, I think you missed a slide. So I was telling that radial head dislocation is one critical event that can change the whole scenario and prognosis of the disease. So if we are able to catch them when the radial head is about to subluxate, then that is the time when you should intervene, or maybe little before that. But sometimes, actually there were 2 cases I couldn't show due to paucity of time. So sometimes there was a child, 3-year-old, he came with a distal ulnar osteochondroma. So at 3 years, if I am going to lengthen the ulna, it's not going to help. I just excise the ulna, cap them at follow-up. And now, I think a year back, they came when their ulna was, radial head was almost about to kind of dislocating. So at that stage, and moreover, those studies and those 3-4 parameters can help me predict when a radial head is, there's a chance of getting dislocated. So we need to intervene there, because long-term results of all these procedures are not very much defined. There's a need for a long-term study. But still, this is almost uniform in the literature. Once radial head dislocate, results go to deterioration. So that's the point we want to intervene. That's why the importance of those parameters.
So what are you going to do if you find that the radial head is going to dislocate? What is the intervention?
So ulnar lengthening, slow or acute
So
depending.
it's basically a prophylactic ulnar lengthening.
Yes, sir. At that stage only.
At that stage only.
Yeah. Means because there are studies which say that you should lengthen every case. So that is probably not advisable. Most of the long-term studies, there are a couple of them, don't advise that. And as a matter of fact, there are few cases in which even after radial head dislocation, there was another case in which radial head is dislocated, but still child has good range of motion. They are all controversial, but radial head, when it is about to dislocate, it's better to intervene at that stage before it dislocates and goes out of the socket. Yes, sir. Sure, sir.
So you said something about the results. As I guess, there are two issues. One is the cosmesis. Second is, of course, the pronation supination loss. So I've done a couple of lengthenings in this, again, multiple osteochondromatosis. And in a lot of these cases, I mean, the patients, they do lose pronation supination even after lengthening. Cosmesis becomes better. And I'm not too sure about the radial head, because radial head is something, once it dislocates, it dislocates. Then you don't have much choice, except perhaps to consider excision once the child is skeletally mature, if it is still symptomatic or if the patient is cosmetically concerned. So your comments about...
So that's why, because if it once dislocate, then it is very difficult. Although there are studies and procedures when they have done ulnar lengthening and tried to reduce. But as you said very clearly, that's why the importance of those parameters before it dislocates to intervene at that stage. That's why probably. No, sir. It's yeah, that's what. And so studies are saying that they regain after the length has been restored, but there are studies which say there was a case in which they have regained, but not much. I'll not say there's a significant range of motion, but yeah, cosmesis becomes better. And most important, what I feel, if you are able to prevent radial head dislocation, long-term results may be better. That arthritis and all those can be prevented.
Sir, I wanted to ask you a question about the multiple exostosis. Will it be prudent to do an MRI or USG in cases who have multiple exostosis, considering the risk of finding a hemangioma, which is known as a Maffucci's syndrome?
So Maffucci's, I don't think, I am not very sure about that, but I don't find anything in literature. But yes, one pertinent thing which I'll point out here, that forearm osteochondromas are more in X2 type of genetic mutation, and probably they are more linked with the conversion to malignant change, that is chondrosarcoma. So it is important, if we are suspecting that, and particularly so in forearm, when the forearm is involved, to do that MRI.
If you see an osteochondroma which is slightly in an older child, so is there any chance that by lengthening the ulna, you could reduce the radial head dislocation?
So just seeing an osteochondroma is not an indication for lengthening.
The radial head is just about to dislocate, radial head has just dislocated. So I'm asking, is there any chance that by lengthening the ulna, we could reduce the radial head dislocation?
So that's what, if it is yet not dislocated, probably it's a very good time to intervene at that stage. But if it has dislocated, there are studies which say that they put wires into the radius also and bring the radius down, over lengthen it, then remove it. But there are not many instances for that, and how much, that's what sir was telling, how much range of motion you can regain, that is also questionable.
One of the issues is that the so-called results in this situation is not clearly defined what is meant by results.
So that's why I said it's a very controversial.
So somebody needs to have some sort of objective criteria to define the results.
Masara was, they are good enough that they themselves told that their results deteriorated over time.
Over a period of time, yeah.
Thank you.
I think we should wind up this session now. We are getting pretty late. Should Should we move
Thank
on
you,
to
sir.
the next session?
We will come to the end of this session. Thank you, chairpersons, for this session. Now I'd like to invite Dr. Prateek to moderate the next.
Good afternoon, everyone. So, without wasting any time, we'll move on to the next session. I invite the chairpersons to the next session. Dr. Ramani Narasimhan, sir, Apollo Hospital, New Delhi. Dr. Albert D'Souza, sir, Associate Professor, Department of Orthopaedics, Sharda Hospital. And Dr. Ravi Chauhan, sir, Sir Gangaram City Hospital. And I invite Matthew, sir, to take his session on upper limb in cerebral palsy.
Good afternoon, everyone. Apologies, I'm having a very bad URI. My voice may not be as good. It's a fairly extensive topic. I'm not sure half an hour is sufficient. When you think of the hand in a normal person, there are three key functions that define all activities that you do with your hand. First, the hook function. You hook a book off a shelf. The second is the grasp function, where you grasp the book like this. And third is the pinch function. In a child with cerebral palsy, all three components are affected. There are subdivisions of each of these. You can have cylindrical grasp, spherical grasp, you can have chucky pinch, you can have side-to-side pinch, and all kinds of modifications are there. However, in a child with cerebral palsy, one of the key problems is independent individual muscle function is lost. So muscle power itself may be good, but when it comes to getting the child to do one finger function, that becomes poor. And therefore, assessment is a challenge. You can't get the child to do individual muscle power. If you're planning a tendon transfer, to define the final outcome, you need to have individual assessments. The classic presentation is a child with an elbow flexed, forearm pronated, wrist fingers flexed, thumb adducted and flexed. You also have to differentiate between what is a cosmetic hand versus a functional hand. You may cosmetically correct the hand, but functionally maybe not so good. You may have the other side also. You may have a reasonably functional hand, but when the child walks fast or runs, might adopt the posture, the same typical flex pronated and a thumb clutched hand. I had a mother, designer, fashion designer, moved in the higher circles. Her child had the problem. At rest, beautifully corrected, could grasp things nicely, but the moment the child walked fast with the mother, she would go like that. You have to warn the parents that whatever you do, that pattern, which is the reflex pattern of rapid walking, may not get corrected. I had explained to the mother, it won't be best, but be prepared, it will be like this. She was very unhappy. Despite all my explanation, she was not happy. So be prepared for that unhappy parent where, despite your explanation, may not be happy. So the thumb and the hand postures evolve as the child grows. At birth, it may be a thumb clutched hand. That may be one clue to the child being a spastic child. A thumb clutched hand. The child's thumb clutched hand may grow out of the hand as the child grows. That's the normal. However, may persist. Like in this child who is 7 years, it's a thumb clutched hand, just severely deformed hand. Even toileting and hygiene becomes a problem in such a hand. So you have to prevent this. So while you're waiting for the hand to get out of the thumb clutched posture, you will have to be sure that you don't end up with this. 6 to 9 years, the thumb opens up maximally, wrist flexion is predominant, forearm is pronated, elbow is flexed. Adolescence, elbow flexion and pronation slowly decrease, but they don't disappear. Some degree persists. So your job is to assess the evolution of the patterns in the history that you have taken. Find out in a given child what are the holding patterns, what are the transfer patterns from the right to left, left to right. Is there any tendency to ignore a hand? And that is a challenge, because you may not have realized it. Everything looks good, child does things, you do ask the child to do movements, but when everything is done, the child still does not use the hand. And that is an ignorance in terms of the neocortex of the child. The child's stereognosis of that particular hand may not be good, so whatever you do, it may not be able to use the hand properly. So do not forget to do assessment of the stereognosis. So I often have little candies in my hand. I ask the parents, and this is not possible in a smaller child. You have to have the child somewhere between 7 and 10 to be able to assess the stereognosis in a child. So assessment is difficult in these. And what is your goal? You have to be clear. You have to be clear, is it toileting? Is the child GMFCS 4-5, forget it. If you are looking at nursing care, donning and doffing of clothes, yes, then you can have severely flexed hand like that with this posturing is difficult for donning and doffing of clothes, particularly during winter times. So you'll have to find out from the parents. And what about the other functions? You may not have all the functions possible. Be very clear, what are you expecting by an intervention in this particular child? Do your assessment, both static, dynamic, passive, active, all have to be assessed clearly. Shoulder is not such a big issue except in donning and doffing and clothes. Elbow also is not such an issue unless it is a severe flexion. Yes, once in a while you may need to lengthen the biceps to encourage donning and doffing and clothes. Most of what you do will be in relation to the forearm, wrist and hand. In the hand, we need to look at the positioning. You look for contractures. Are there any contractures? Sometimes may be difficult to assess. A child who is severely spastic may appear to be having a contracture, whereas the moment you take under general anesthesia, you find everything just relaxes. So it was severe dynamic spasm and not a contracture at all. So be prepared for that. Differentiate between contractures and dynamic spasticity. Occasionally you may have a doubt, and when you have a doubt, those may be an indication to check out with a nerve block or a Botox injection. Early childhood, we like to do physiotherapy, occupational therapy. Please do not put too many bulky splints on these little children. Splints will inhibit development of the hand, inhibit the cortical image of the child's hand. So earlier in the 70s and 80s, there were prominent splinting recommendations being done, but the current recommendations: do not splint a hand too long and do not put large splints on these hands, because the child will fail to use the hand over a period of time. So your efforts to get the child to use the hand after correcting deformities by therapy and by splinting may not work. The child won't use that hand. Avoid large splints as far as possible. Again, look at the functional abilities of the child and see how they are and how the child is using the hand. Most of them are left hand dominant. They check for what are you going to do. So if it's a bilateral thing, the child may still have a left hand dominance or a right hand dominance depending on what it is. You assess that carefully. Before you start your intervention, assess the child's handedness very carefully. Always get an occupational therapist also to do an assessment and have it documented there and set the goals between them. As I said, occasionally you may need to use botulinum toxin. I use it very sparingly, and if you're using it for multiple muscle, you will need the help of an ultrasonologist. You won't be able to inject into the correct muscle in the right pattern without an ultrasonography. Do I use baclofen for severe spasticity? No, I do not use baclofen unless it is a GMFCS 4 or 5 where severe generalized spasticity is there. I may consider it to reduce it. Sometimes you have to be sure that some of these children who come with severe painful spasms may be severe vitamin D deficiency. Why would that happen? Many of these are on anticonvulsants. And anticonvulsants are enzyme inducers. And enzyme induction of vitamin D destruction happens quickly, and they have deficiency of vitamin D. And therefore, you have to be prepared. And on top of that, if their nutrition is not good, they will have painful spasms coming. It is not because the spasticity as such is high, but because there is a painful, any nociceptive stimulus in them may add to a spasticity being higher in these children. A UTI may cause a further spasticity. A vitamin D, calcium deficiency, stress fracture may cause spasticity. So be prepared of that. I have children who come to me as non-walkers, becoming walkers because their vitamin D and calcium deficiency have been corrected. When you look at the hand, there are certain patterns that are described. Pattern 1, pattern 2, and pattern 3. Pattern 1 is active finger extension is possible with the wrist in less than 20 degrees of flexion. Pattern 2 is to extend the fingers, you need to flex the wrist more than 20 degrees. And pattern, that is, you're able to straighten the fingers nicely. That will fit into a pattern 1, less than 20 degree, you're able to extend all the fingers. Pattern 2, further subdivided, wrist extension with full finger flexion, or no wrist extension with fingers flexed. So you look at the two types and that tells you the severity. So if you look at this child, the child has got palmar flexion of the wrist, and you ask the patient to dorsiflex the wrist, the fingers will go into the constant length phenomena, they will go into that flex posturing. So that's the constant length phenomena which you have because of spasticity of the forearm finger flexors. Again, if you see this, there's something else happening in the finger. Watch out for that. When they're trying to do that, there is swan neck of the finger which is happening. And that is because the severe spastic forearm long finger flexors are not allowing the extension of the finger, and the extension is causing a swan neck phenomena. You can't have that. So some of these children have an athetoid component overlapping. So whenever you ask them to do something with the hand, the whole forearm, elbow and the shoulders go into an abnormal posturing. This is a patient who is a poor candidate for surgical intervention because an athetoid component is a poor component for a surgical intervention. So this child, you can do it for donning and doffing closings, but don't expect too much of functional result in such a child. So again, just see the way the pattern of movement. It goes into pronation, sometimes into supination, the whole elbow goes into full flexion. That's a poor result. Pattern 3, active finger extension is not possible even with maximum wrist flexion. And that is how it is. It's a clutched hand like that. There is no extension possible of the fingers at all. This is an extension of the wrist. When you flex the wrist fully, even then the fingers are not extending up fully. So the fingers are not extending fully. That's a pattern 3 hand. That's a severely clutched hand like that. You try to open it. I'm trying to open it. I'm using all my strength. I can't open it fully still even then. Can you see that? I still can't open it. The long fingers go into further flexion. So you need to understand that. So pattern 1 and 2 can probably improve functionally provided there is no athetoid component. Pattern 3, there could be more cosmetic improvement but not too much of functional improvement. And by and large, Freeman Miller recommends that don't do upper limb surgeries of this kind where you're doing transfers for improving function before the children are 7 to 12. I certainly don't operate them before 6. May occasionally do very, very sparing Botox, otherwise I don't operate them early. Best results, as I mentioned, in spastic CP. But I have seen residents are not able to differentiate between dystonias. So beware of the dystonic child who is constantly in dystonic posture. You think that is dynamic spasm, but there will be, from the history you can make out, the parents will tell you, sir, kabhi kabhi bilkul theek kar deta hai. So that is a dystonic pattern. Beware of the dystonic pattern. That will need a medical management. Get to a neurologist, may prescribe pacitane and other relaxants that are required. Shoulder, by and large, you rarely have to do anything. But your best results would be if the IQ of the child is good enough to cooperate in physiotherapy, that needs more than 70 IQ. As I mentioned, your goal, is it for toileting? Is it for dressing? Is it for hygiene of the hand? Because a thumb clutch hand starts smelling, particularly in the summers. So we don't want that to happen. So we need to see that. Biceps, the indication would be a severely flexed hand where donning and doffing clothes becomes really difficult. So here you may do a Z-plasty of the bicipital aponeurosis, and it is a fairly straightforward procedure. Occasionally you may have radial head dislocation in some of these children with severe deformities, but that's a rarity. I wouldn't worry too much about it. Pronation can sometimes become worse with age as the child. Normally, it settles down as the child is growing up, but it may not. And therefore, you need to look at passive supination in these children as an assessment. Supinate and see. Is the child supinating? So this is a very mild restriction. Right hand is normal. Left hand can go only up to mid-prone position. It cannot be supinated fully. So here is a child who is otherwise good, can extend his fingers fully with the wrist in neutral position, is a good candidate. He can abduct his thumb actively, but there is a restriction of the full supination. It is in semi-prone position. The parents were very keen that we must correct it. And here is an isolated pronated teres release, which is called Tubby's release, which can be done, will make a difference in these children. You may, if there was associated palmar flexion, then you might combine it with the other surgery, but by and large, a Tubby's release in an isolated, mild case like this might work out. I do not give splints, but if there is a spastic hand with the flexor pronated hand like that, there you might take the pronated teres, the deforming force, to the extensor carpi radialis brevis. That will work beautifully. Otherwise, if there is an ulnar deviation, then you would combine with an extensor carpi radialis longus. So radialis longus is on the radial side. So if there's an ulnar deviation, it will help to correct the ulnar deviation. So your decision to transfer the pronator teres, it's just lying side by side. It's a very easy transfer, small incision, easy transfer. Just take the pronator teres. Make sure when you're transferring the pronator teres, you take a long strip of the periosteum along with it. Otherwise, the short tendon, particularly in a spastic child, if the anesthetist has not given a muscle relaxant, it will go back. So you won't be able to get it to the tendon correctly. So beware of that and take it correctly. Otherwise, by and large, a flexed pronated hand, you use a flexor carpi ulnaris transfer. Some people prefer the flexor carpi radialis. I prefer the flexor carpi ulnaris because usually the hand is like that, in this position, in ulnar deviation. And you can actually palpate the FCU being overactive. So I take the flexor carpi ulnaris and transfer it. Now, there may be a child with severe spasticity of the long and the superficialis flexor tendons of the forearm. These you may need to do assessment very carefully. Can you manage with Botox if it is there? Can you manage with stretching exercises? Occasionally, you may need to do a myofascial lengthening. But beware of myofascial lengthening. It's not a procedure to be taken lightly, because if you do a myofascial lengthening of the FDS and FDP, they may become weaker. So the grasp goes down. The strength of grasp goes down. These children can hang on to objects very nicely. So if that hanging on grasp posture goes down, you will be very unhappy, having very unhappy parents on you. पहले तो उठ के खड़ा हो जाता था पकड़ के, अब नहीं खड़ा होता ठीक से. So be careful with that. Thumb in palm, occasionally you may need to do a myotomy of the adductor muscle, and occasionally you may need to do an FPL lengthening. So isolated FPL contracture may need an isolated tendon lengthening. You don't do a myofascial lengthening. For the postgraduates here, flexor pollicis longus tendon is one tendon which has a vincula which permits lengthening of the tendon. Other flexor tendons do not permit lengthening like that without causing a vascular damage. So FPL is occasionally lengthened. The thumb itself can be further classified as Houses 1, Houses 2 or Houses 3. House is the name of a person. He defined the categorization into 1, 2 and 3. A spasm of the adductor pollicis along with first dorsal entry, thumb is like that, is adducted. It's adducted. There's no other deformity, no flexion, no extension. So it's a simple adduction that is there. When you dorsiflex, it goes into more adduction. When you palmaflex, it gets corrected. It's passively corrected. Simplest of the deformities of the thumb. House 1. House 2, the metacarpal gets adducted at the MP joint, metacarpophalangeal joint. The adductors are of course weak, but the adduction is there. Can you see this? The metacarpal is flexed there like that. MP joint, the metacarpal is flexed. Here it is flexed like that. House 3 on the other hand has hyperextension of the MP joint. In House 2, there is flexion of the MP joint. In House 3, there is hyperextension of the MP joint. The same patient, on the other hand, had this along with the swan neck deformity. Swan neck must be prevented. Swan neck must be prevented by early intervention to ensure that you have a good wrist extension possible. When you have long finger flexors, finger extensors being substituted for doing wrist extension, you will have a tendency for a swan neck phenomenon. Prevent that. Surgery of the hand, classically we used to do, when I was a postgraduate, we used to do Max Page operation. That was the standard operation. That is the only operation that I saw ever in a cerebral palsy child's upper limb. And fairly simple. You can assess the efficacy of this by checking the elbow inflection and is the constant length phenomena improving by holding the elbow in maximum flexion. If it is, then this patient may benefit from that. So this is a constant length phenomena. Palmar flex the wrist, all the fingers open up. Dorsiflex the wrist, all the fingers close up. And that's what it is. That's the max page operation where you release, do a flexor pronator release. Flexor pronator release, all the common flexor origins you release from the medial epicondyle, and there you have it reattached. Very nice cosmetic scar. That's it. I have a 20-year follow-up on this girl. She's very happy. She's in the enabling department of a college now, and she's doing very well with everything that she has. So, can be very satisfying procedure also. So, this patient, again, a flexor carpi, ulnaris transfer is being done. You take the tendon, it is muscular right up to its insertion, take it from there and you transfer it from the ulnar side onto the dorsum, identify the muscle. If only the extensor carpi radialis brevis, that's the middle tendon, if that is the one which needs to be supplemented, transfer it only to that. If you think the extensor digitorum communis is also weak, then you put it into the tendon of EDCs and also the ECRB. So both may be required. So here we are doing it both in the EDC as well as in the ECRB and transferring it like that. Give a cast. Again, you can see the muscle sticking up and as a small bulge on the ulnar side of the forearm. She could not do this before. Nicely she is able to extend the wrist. Wrist extension is good, finger extension is good, good procedure, deformity is corrected. She is able to do active extension also. So, very nice procedure. Myofascial release, beware. Such a patient in whom where there is severe contracture and it's a type 3, pattern 3 type of hand, there you need to do a myofascial release, combining it with an FCU transfer. That's an FCU that has been taken up. That's the palmaris longus, and identify, that's a flexor carpi radialis tendon, and identify the flexor superficialis. Even under anesthesia, the fingers are remaining flexed. You can't straighten them out. Okay, so there, one by one you identify and do a myofascial release of these tendons. That's how we do one by one. What do you do in this? At different levels, just cut the tight myofascial structures. When you stretch the finger out, these myofascial structures do not stretch initially. Once they are cut, the muscle stretches out nicely. So hold the limb in the neutral position after that, and you will have correction happening. So one by one, you will be able to correct it. For every finger you do. But if you notice, the thumb is in flexion, FPL is hyperactive. I need to identify the thumb in the end, and then only I'll be able to straighten out the finger. So I'm trying to identify the flexor pollicis longus and doing a myofascial release. Finally, I'm able to open up all the fingers with a myofascial release. But I should have explained to the patient. One thing that is left is to get the thumb in palm. How do I get it out? I need to get the extensor pollicis longus, release it from around the Lister's tubercle, bring it to the more radial side and transfer the palmaris longus. That's the extensor pollicis identified, and I'll transfer the palmaris longus onto that. So has a patient. This is a patient who could not do abduction. Now he is able to do that also. So overall can be very satisfying provided your assessment has been good, you define the goals well. Splints as far as possible try not to use or minimize the use. Cosmetic correction is more predictable than functional correction, and spastic muscles fare much better than athetoid muscles. And prefer to do surgery around 7, 8, 9, not earlier than that. Thank you so much.
Any questions?
Sorry?
Simply just the pronator muscle. What procedure will you do, sir?
In a severe case, in one case, I have released the pronator quadratus, but otherwise I have never ever had to touch the pronator quadratus, because pronator quadratus, it's not facial, it's totally muscular. It stretches out with therapy. So you don't need to do anything to the pronator quadratus. You manage very well. There's only one question, whether you would transfer the pronator teres right from the radial side, or would you pass it through the interosseous membrane? So that's the issue that we need to look at. If you think that you need to have less pronation coming up, then you can pass it through the interosseous membrane and transfer it to the ECRB. It's a direct transfer, but remember, it's not easy. You do not get sufficient length. So be prepared to take sufficient periosteal length if you're doing that.
So sometimes in India, these children come very late. As you said, ideal age to operate is around 7 or 8. If a child is coming to me at 12, 13 and has...
That's a little late.
So what would you do, sir?
That's a little late. But then if I'll assess the function of the child clinically, I'll assess the stereognosis. At that time you can assess the stereognosis very well. I'll assess that. If stereognosis is good, I'll still give a chance. Because if the child has a feeling of the hand, then they tend to use it. If the feeling of the hand is not there, they'll ignore their hand.
Okay. And sir, is the same plan or your plan will change in view of some bony deformities would have also developed by that time?
I am not so worried about bony deformities, no. Because here by then you're only looking at crude function, not fine function. You can't get fine function in these children because they do not have independent muscle function. Thank you.
Thank you, sir. Thank you for coming in this bad health and guiding us. So next we move on to the session on AMC. I would invite Dr. Abhishek Saha. He is a consultant at Institute of Child Health, Kolkata, and Secretary of the Paediatric Orthopaedic Society of West Bengal. Dr. Abhishek.
Good afternoon, everybody, respected seniors and all postgraduate students and colleagues who are present over here. It's an honor to be here. I'd especially like to thank my hosts who have invited me over here, especially Dr. Pratik, who made a very good arrangement for me and for my transport and stay. Thank you, Dr. Pratik. And well, a topic becomes a little bit challenging when a surgeon is trying not to sell a surgery, because a surgeon is supposed to do a surgery. If he's trying not to sell a surgery, the topic becomes a little bit challenging. So I'll try to stick to that goal while enumerating the various surgeries which are done for AMC in upper limb. So my personal experience in this is mainly conservative. Few surgical cases in which I did a little bit of triceps lengthening and transfer and a humeral derotation. My mentor, who has far more experience than me, I had a talk with him before I came over here. So I'll try to bring forward his experience, which I could garner by talking with him, and my short experience of 10 years with conservative and physiotherapy regimes. Now the scope of my talk will involve introduction, a brief classification of the AMC, and plan of management, brief review of literature, and a summary in the end. And we will also discuss the surgical management. So we'll try to go where most of us have not gone before. So the earlier practice, as I have been mentioning over here, the earlier practice is the upper limb or the hand, it had no place. The seniors used to tell that they have no place for any operation or surgery, because most of the time the muscles will be fibrotic They will not have the normal muscle tissue. It will be foolhardy to go for any surgical correction. And normally these childs used to adopt very well to the deformities. And the common deformities which we used to encounter, or we are still encountering, are the internally rotated shoulders, stiff extended elbows, flexed wrists, and ulnar deviation. So it's roughly the classic classification of AMC, which we all know. I'll be restricting myself to the first group, which is known as amyoplasia, or the most commonest form. Now, in amyoplasia, we have most of the, all the limbs which are involved, as well as the lower limbs, the involvement is more, and we perform more surgeries of lower limbs as compared to that of the upper limb. Present strategy and practice, which is gradually evolving, we are moving away from our age-old practice of not operating the upper limb in these cases. Early repositioning of the upper limb at a young age, passive elbow movements to gain some movement before going for any surgical correction, and try to bring the wrist into extension, which I normally try to do by putting it in a splint and then going for a little bit of physiotherapy. Now, accessing a desktop or laptop is very important in the present days. Feeding and personal hygiene have been the requirement for surgery for a long time. Goals of management: before you go for any surgical management or intervention, you should gain passive movement. Always remember, you are here to preserve the joint movement and not sacrifice the joint movement. Consider the upper limb as a single functional unit and try to achieve a bimanual function. Now, coming to the surgical goals, if you want to operate on these childs, major changes of hand position should be done by 4 years of age, best before 8 years. Broad guidelines, if you are going for surgery, 18 months to 3 years is the best time, because till 18 months, if you are able to gain some amount of passive movement, then your surgical results will be better. Skin crease is suggestive of certain muscle activity. When the child is born, it's in the worst possible shape which the parents will see. But gradually, over time, the hand and the other things, they start improving. The child starts using his hand more. So if you are seeing skin creases appearing over the arm, that means that some muscle in between the fibrotic tissue or some function is present. Look for associated muscle dystrophy. I had a case 2 or 3 months back in which we had corrected the we had technically corrected the foot, but by the time the child reached a certain stage, a genetic diagnosis of some muscle dystrophy was made, and that's where we had to abandon the cases. Most of these patients have spinal deformity as well, and remember the most important thing of surgical management, that the muscle tissue needs to be healthy for attempting any surgery. Stages of surgical management. First, achieve elbow flexion, which has to be passive. Start with passive exercises, then correct humeral rotation, and last is reposition the wrist and correct thumb in palm deformity. So roughly the sequence goes, first you try to get the elbow, then the shoulder or the humerus, and lastly reposition the wrist. Try to combine it with the lower limb procedures, because the lower limb deformities are far more common. This also reduces the need for more anesthesia. Elbow, you have to have some active triceps function before you can attempt for inflection. The goal is always to get a flexion more than 90 degrees. Easier said than done. Posterior release with tricepoplasty, I have some experience with this, a case which was done, but results are again very doubtful. Bipolar pectoralis major transfer, which I have shown in the image over here. You can see all fleshy red muscles over here, which is hardly the case in most of the cases. So you should be very skeptical before going for these transfers. You can also transfer the long head of triceps, though some of the recent research advises against it. Free gracilis transfer has failed. It is not a good idea to do a gracilis. It's still under evaluation. And Tajian specifically mentioned that stainless flexoplasty should not be done. Recent publications have taken a little bit of interest in the latissimus dorsi transfer. This is the present, the favorite of surgeons right now. A lot of latissimus dorsi transfers and a lot of publications are coming on this, and results are relatively better. Shoulder, we have, once we go for shoulder, it is normally the adduction and internal rotation. The humeral head might be deformed. That is the first thing which you need to know, and MRI will be a good thing to evaluate that. Look for soft tissue contractures. Little flexion is always available because the pectoralis major is not completely like we have some amount of muscle tissue in the pectoralis major. Internal rotation contracture is an impediment to the wrist and the elbow movements. So we should try to correct the internal rotation, and derotation osteotomy is normally done at the mid-shaft level. You can secure it with some external fixator or K-wires. So this can be supplanted with after you have regained a bit of elbow movement by passive exercises. Wrist deformed, the problem or the difference from other muscular deformities or CP is that carpal coalitions are very common. Most of the muscles, they are fibrotic, and extensor carpi ulnaris is the only muscle which might be spared. Now, wrist surgical techniques have also been described. Dorsal closing wedge osteotomy of midcarpus and tendon transfers, which is the favored child. Proximal row carpectomy, again, very poor results. Wrist fusion, it is always better to avoid. Now, as I mentioned, the only operation which has been showed, the surgery which has been showed to give a little bit of better results is the dorsal closing wedge osteotomy and some tendon transfers. Release of tight volar structures and FCU lengthening. Divide the flexors if they are fibrotic, because the hand is in a flexed attitude. Preserve the radiocarpal joint capsule. In case you have to get the wedge, approach the joint through the dorsal wedge, and you can transfer the ECU to the stump of radial wrist extensor so that the child can get a little bit of extension. As I mentioned already, it is an old modality of treatment, the proximal row carpectomy and the wrist fusions. They normally have poor results. Wrist fusions are an absolute contraindication now. No one does it. Now, recent articles which we are seeing and the results continue to be poor. But however, a new beacon of hope is the nerve transfer from median to the musculocutaneous nerve, which has been shown to, which has been described as being showing a little bit of good results, but the long-term results are awaited for this. To summarize, this disorder has been treated with conservative approach for ages. Recent studies are gradually advocating more and more of surgical management, supposedly because they're achieving better results. Muscle and tendon quality should be considered before surgery because most of the tendons are fibrotic. Passive exercises should always precede surgeries. Muscle tendon transfers to achieve elbow flexion have been documented to give good results. Wrist hand surgeries are advisable in very selective cases. Nerve transfer is the new kid in the block, the new treatment option. Thank you. And I'd like to request you all to support our candidate from West Bengal, Dr. Rajiv Raman, who is also a life member of our Paediatric Orthopaedic Society of West Bengal. In fact, LM number 1, he has been instrumental behind that. So I request you all to kindly support him during the IOA elections. Thank you so much.
Thank you, Dr. Abhishek. We have last talk for the session. I invite Dr. Sumit Gupta for his talk.
Thank you, Pratik, for inviting me for this talk. And thank you, Dr. Abhishek. Most of the things that I want to discuss has already been covered. So I will limit my talk very short. So I will be presenting the optimization of elbow and the wrist in AMC children. As Dr. Abhishek already told that the number of surgeries are very limited and they are hardly has successful result. So the involvement of upper and the lower limb is up to 56% in AMC child, and only the upper limb involvement has seen around 17% of the child. The characteristic presentation is internal rotation reduction at the shoulder joint, extension at elbow, flexion at wrist, and thumb and palm appearance. The goal of the treatment of upper limb has already been discussed. The basically is to augment the daily activities functions, which includes feeding, self-feeding, independent toilet activities, table activities, and the grasp. The initial treatment has already been discussed by Dr. Abhishek that it is always conservative. First, you have to go for exercises and splintage. So if the conservative treatment fails, then only we have to go for surgical treatment. And the surgical treatment, we have to do shoulder surgery might be required at the level of correction of the internal rotation deformity of the shoulder, elbow, and the wrist joint. So I will just limit my talk to the elbow and the wrist joint. So the principles of the surgeries is basically first aim is to gain the passive motion, because if you don't have any passive motion, no surgery will succeed. So once the passive motion is gained, then you can try some motor to add the active movement. Another aim is to aim is to preserve the unemotion that is already present, and bimanual function is necessary in most of the patients because neither hand is likely to have a strong unilateral grasp or dexterity. So you have to keep all these principles in mind before going for surgical intervention. So now come to the, I will not discuss the derotation osteotomy because it's a part of the shoulder surgeries. Now come to the elbow surgeries. In literature, the elbow surgery has been described to correct the elbow extension, which is common presentation, as well as for elbow flexion. So the elbow stiff in the extension, the first we have to go for in the exercise, in the stretching exercises in the early neonatal life. And in most of the patient, the good amount of passive movement can be achieved by the sprintage and the exercises only. Now suppose if the patient is not having the passive motion even after exercises, then we can go for surgical intervention. Okay, suppose if the exercises we can gain the good amount of range of motion, then we can try the tendon transfer procedure, which includes latissimus dorsi, pectoralis major, and the triceps transfers. Now commonly done is the long head triceps transfer to the biceps femoris. If the passive movement is not there, then first we have to release the triceps and posterior capsulotomy, then we have to go for the tendon transfer. So these are the pictures how to go for the soft tissue release. You can see the posterior elbow has been exposed, and you can see the lengthening. This is the Z-plasty of the triceps as well as capsulotomy of the posterior capsule joint. And these are the pictures showing the tendon transfer of the triceps. You can see this is the ulnar nerve, and this is the long head of triceps which has been transferred towards the anteriorly to the biceps tendon or to the periosteum of the radial tuberosity. Okay, now the question arises that if the patient is having the stiff elbow in extension in both the limbs. So literature says that you should go for correction on the bilateral side, but in our setups in India like country, we usually try to, in the bilateral involvement, the optimal solution is to have one arm in flexion for reaching the head in the mouth and passively or actively, and one arm in extension for the hygienic control. Though this procedure might jeopardize the bimanual grasp. Now look at this video. This child is having the flexion, good amount of flexion on the right side, and you can see there is also the flexion deformity of the wrist, which has not intentionally been corrected, because this flexion deformity is helping the child to keep the hand to the mouth. So this patient was operated by the long head of triceps transfers, and we were lucky that he was having the good function. This child was also having the problem on the right hand, and on the right side, you can see the extensor contracture is there. So it was not corrected because it helped in the hygienic control. Okay, so suppose if you are not doing tendon transfer, these patients are so adaptive that they can use household activities to flex the elbow joint. You can see this child is having the flexion of the elbow joint with the using of the table and by the other joint. And this is the another child who is having the flexion of the elbow joint by using the flexion at the knee joint. So if the tendon transfer even not work, they usually do it by using some other activities. Now elbow stiff in the flexion, they usually have surgical correction is very futile, and child usually functions better in this position only. So we don't do any surgery in these patients. Now come to the wrist surgeries. So in the wrist surgeries, these are the only things the surgery is slightly indicated. Usually the conservative treatment is good. If it fails, then the wrist extensions tends to improve. If you are going for dorsal varus carpectomy, it tends to improve the grip, pinch strength, as well as the appearance of the foot. But you should also keep in mind, if the elbow flexion is limited there, this wrist flexion helps in the reaching the mouth when the elbow flexion is limited. So these are the surgical procedures which are already covered. This dorsal varus carpectomy, already told by Dr. Abhishek, it is a biplanar osteotomy. The proximal cut is perpendicular to the long axis of the forearm, and the distal cut is to the long axis of the metacarpals. And the wedge is created, which is widest coronally plane in the radial side and dorsally in the sagittal plane, so that you can correct the ulnar deviation as well as the flexion deformity. These are the clinical pictures of the dorsal wedge carpectomy. You just need intraosseous sutures to close this gap. Nothing fancy implant is required. And this can also be supplemented by tendon transfers. So these are the surgical procedures for the wrist. Now the stiff wrist extensions, the surgeries are usually, the results are not very promising. And this was the child. His father was also AMC patient. He was having the wrist extension at the, and this child was having no problem even with the wrist extension. You can see he is in right with this deformity also. I would just like to show you two videos. This was around 8-year-old child who was not operated for any deformity, either elbow or the wrist joint, and he was able to do all his activity. He just came to our OPD to show some other complaint. He was able to do the more fine work like buttoning the button of his school. He was able to tie the belt, and he was able to tie his zip as well as to undo his zip. And he was able to unzip his shirt button also. So this patient usually functions best even if you don't treat them. If you don't do any surgical procedure, just they usually train you with this deformity. This child was also able to write. You can see he was writing properly with this deformed hand. No surgery was done in this child. And he was mentally absolutely normal. He was able to write counting also, whatever we told him. So the take-home message is you have to see the patient whole. There are few surgical procedures which has been described in literature. Never sacrifice one function for the another. Usual procedures that is described in literature are humeral osteotomy for the interlocution deformity, triceps plasty and the transfers, which has shown good results in literature. Dorsal wedge carpectomy for the wrist flexion deformity, and the thumb contracture release for the hand deformities. Thank you.
Thank you, boss. So, do we have any questions on AMC? Okay, so we are already late for lunch. So, I'll invite Dr. Gautam sir to felicitate the speakers and chairpersons of session 3. Dr. Nitish Arora. Dr. Syed Faisal. Dr. Swaroop Sinha. Dr. Manoj Padman sir. Dr. Rahul Kaul sir. Thank you, sir. I invite Dr. Rajni Ranjan sir to felicitate the speakers and chairpersons of session 4. Dr. Sudhanshu Bansal. Dr. Somesh Virmani. Dr. V.K. Gautam, sir. Dr. Matthew Varghese, sir. Dr. Rakesh Kumar, sir. Dr. Abhishek Saha. Dr. Sumit Gupta. And Dr. Albert D'Souza, sir. Thank you, sir. Before we move for the lunch, as many people have come from outside and they have trains, so I would like to thank all of you for coming to this CME. We have sessions in the post-lunch time also, but I would like to thank POF and Manoj sir for giving me this opportunity to conduct this CME, and other speakers who flew from Chandigarh, Ludhiana and Kolkata and Bhopal just to attend and guide us with their wisdom. We go for the lunch, and we have sessions after the lunch as well. Thank you.
completed by adducting the arm and trying to do passive external rotation. The supraspinous part of scapula is exposed subperiosteally with periosteal elevators. Being lifted by periosteal elevators, the supraspinous part of scapula is protected by spikes. A sharp bone cutter is used to cut the supraspinous part of scapula, and the small pieces of residual scapula is removed by nibbler. The completion of procedure is demonstrated by passively doing adduction and by seeing disappearance of the supraspinous part. One can do subscapulary slide through the same incision by passing the periosteal elevator between the periosteum and the subscapularis, which is exposed after resection of the supromedial angle of scapula. Periosteal elevator is passed after forward flexing an internal rotating arm and making the medial border of scapula prominent. Gently, the subscapularis septors are released by a periosteal elevator, and that's how subscapularis slide is performed. One can see the correction of passive external rotation to 90 degrees after subscapularis slide. Next, attention is driven to the conjoined latissimus dorsi teres major transfer through axillary approach. One should know the surface anatomy of axilla, wherein the posterior axillary fold is formed by triceps tendon. In front of triceps lies the conjoined tendon of lat dorsi and teres major. The axillary neurovascular bundle lies in front, and anterior axillary fold is made by the pectoralis major. About 5 cm incision along the axillary crease is given, ending just behind the posterior axillary fold. The dissection is carried out in subcutaneous plane, saving some sensory nerves. On deeper dissection, one would find the conjoined tendon, and just in front of it lies the axillary neurovascular pedicle. Axillary neurovascular pedicle should be retracted anteriorly to fully expose the conjoined tendon. The next step is to dissect the anterior and posterior margin of conjoined tendon. One should dissect it till it inserts on the shaft of humerus, and after clear dissection, to prevent injury to axillary and radial neurovascular bundle, one should put the mixture underneath, and the tendon is cut from the bone, keeping the edge of knife away from the neurovascular bundle. The mixture should be placed on the lower half, and similar procedure is repeated to avoid injury to radial neurovascular bundle. On lifting the conjoined tendon, one can easily see the axillary pedicle, which has to be carefully safeguarded. Myolysis of conjoint tendon is the next step, and this dissection is limited by the bundle of teres major, which lies closer compared to the neurovascular bundle of latissimus dorsi. After adequate myolysis of conjoint tendon, one can take stay sutures either with Vicryl or an ethibond. And the next step is to identify the interval between long head of triceps and posterior fibers of deltoid. After dissecting the posterior margin of triceps, deltoid is retracted and one can see the shiny infraspinatus inserting on the posterior-superior humeral head. One can also feel with the finger the humeral head, and the conjoint tendon should be transferred on the head and not the neck to avoid injury to the circumflex axillary vessels. One can use a pot needle for easy maneuver of suture in this narrow area. One can also use ethibond for robust fixation. 3 or 4 sutures is adequate to securely fix conjoint tendon with infraspinatus and posterior-superior capsule. The tension of the transferred tendon should be optimum to avoid any external rotation contracture. One can check with an artery forceps the tension of the transfer. At the same time, one should check the amount of passive internal rotation or ability of the hand to reach the midline intraoperatively before we close the wound. The subcutaneous tissue is closed with Vicryl 2O and skin with monocryl, and this gives an aesthetic scar. Various techniques have been described to treat shoulder internal rotation contracture. Subscapularis. A subset of patients affected from residual obstetric brachial plexus palsy shows good degrees of active external rotation, but they lack active shoulder abduction. Minimally invasive subscapularis release from the medial border of scapula. The patient is a 2-year-old girl with residual C5-6 lesion and coinciding with the MRI finding of Waters type 3, suggestive of a congruent glenohumeral joint. To do minimally invasive subscapularis release, patient is turned lateral, the arm is internally rotated and forward flexed to make the medial border of scapula prominent. A centimeter incision is placed at the junction of upper 1/3 and lower 2/3 of the medial border of scapula, and an artery forceps is introduced through the soft tissue and through the rhomboids to reach to the undersurface of scapula. A small periosteal elevator is now taken and it is introduced on the subperiosteal level, and gradual subscapular slide is performed in a clockwise fashion. One has to be careful not to penetrate on the lateral border of scapula to prevent injury to the subscapularis neurovascular pedicle. The septas at the top and bottom of subscapularis are rigid, and one may need a robust periosteal elevator to release them. A bigger periosseous elevator is now introduced through the same portal. In a similar way, the tighter septars are released in a clockwise fashion. The concave surface of periosteal elevator should remain facing undersurface to prevent inadvertent passage into the body of scapula. The next step is to do gentle stretching of subscapularis and anterior soft tissue structures over 5 minutes. To do this stretching, the elbow should be flexed at 90 degrees and forearm should be supinated fully, and counter pressure is given on the posterior shoulder joint to prevent any bony injury. Typically, this procedure takes 5 to 7 minutes to finish, and one should get about 70 to 80 degrees of free passive external rotation, and last 10 degrees can be a bit springy. One skin suture is taken to close this aesthetic scar. One can see there is substantial improvement of passive external rotation in this small procedure of about 5 to 7 minutes. And this is how it is termed as minimally invasive subscapularis release.
Now I invite Dr. Aditya KS for his case presentation.
There is no question. Yes, sir. Yes, sir. अभी आएगा.
Okay.
A very good afternoon to one and all present here. Myself, Dr. Aditya, resident at AIMS Rishikesh, and today I'm going to tell about arthroscopic subscapularis release with conjoint muscle transfer in a case of birth brachial plexus injury. So we had a 4-year-old male who presented with complaints of inability to grasp objects and difficulty in eating and combing hair using the right hand. So later on mainly he presented with flail limb at birth, and which gradually improved over time. So he gained flexion at around 6 months and shoulder movement at around 1 year of age. During his birth, the mother tells the history that there was a prolonged difficult labor, and also, although the cry was immediate at birth, there was 1 day NICU admission. So on inspection, there was wasting of deltoid muscle, and the right upper limb was adducted and internal rotated, with the elbow crease facing medially. On palpation, the internal rotation contracture was present, and there was 20 degree of flexion deformity which was present over the elbow joint. Active movements were less compared to the passive ones, and in shoulder joint, abduction, flexion, and internal rotation was abduction flexion was restricted, and mainly there was total restriction of the external rotation. And the flexion and extension at elbow was reduced compared to the normal side. So the left wrist was neutral, and the thumb activities again had showed abduction which was present, whereas there was extension at the metacarpophalangeal joint, and the sensory examination was within normal. Modified mallet score for this patient turned out to be of a total score of 9. So in the pre-op x-rays, we can see the shoulder joint, right now the dysplastic features have not yet appeared, and the shoulder appears to be near normal morphology. So a diagnosis of 4-year-old child with sequelae of birth brachial plexus injury, Narakas type 3, which was recovering, was made. The problems to be addressed currently were limitation in abduction and external rotation at the shoulder, internal rotation contracture, the limited extension at the elbow, and weakness of the grip strength. Mainly, we will be dealing with the limitation of abduction external rotation with internal rotation contracture, which were addressed. For that, the patient underwent arthroscopic subscapularis release with conjoint tendon transfer to the posterior margin of the humerus. So, patient was made to lie lateral, and arthroscopic view of the shoulder I have depicted in the picture here. As you can see, the posterior viewing portal was inserted and the anteroinferior working portal was inserted, and later resection at the subscapularis tendon. Mainly the upper half of the tendon was resected, and this was the final picture. And intraoperatively, we also could check that there was gain in the external rotation of the shoulder. These are the actual intraop images. Previous was a pictorial depiction. Here we can see the subscapularis tendon was identified and the upper half of the tendon was resected. I would like to take a moment to mention about a paper, a systematic review which was done in 2021, which says about the effect of arthroscopic subscapularis release. In this, in whole of literature, there have been only 13 records with 17 studies in which they have told that around in 288 children, there have been a large improvement in the mallet score and passive external rotation, and large reduction in the glenohumeral subluxation at 30 months of follow-up. And also there is low chance of recurrence as compared to the submuscular slide. Although these studies lack good quality evidence, and also further evaluation need to be done. Up to 2012, only 3 studies were published in literature. Following these were the subsequent studies. Later, for the conjoint muscle transfer, as previously discussed in the study, a standard L episcopo procedure was done, wherein an axillary incision was made and the conjoint tendon was identified, and it was passed percutaneously towards the posterior margin of the humerus. Here is the article quoting the same of modified L episcopo procedure. The normal insertion of the latissimus dorsi and the teres major was redirected towards the posterior margin, and it was inserted. We mainly used a suture anchor to get a better hold, and prefabricated shoulder spica was placed for 6 weeks, and active physiotherapy was encouraged following this. This is the final follow-up at 12 months for the same patient. So I would like to summarize the above case by saying that the decision should be mainly based on the age and severity of the internal contracture with shoulder dysfunction. And arthroscopic release, the advantage I would like to quote here are: 1, it is a less invasive procedure. Secondly, it gives a superior visualization of the shoulder joint. Third, it gives a comprehensive evaluation of the shoulder joint per se, direct visualization. And fourthly, there is lower risk of neurovascular damage compared to the slide procedure. So this gives an upper hand for the arthroscopic release. Thank you. I would thank the organizing team for giving me this opportunity. Yes, sir.
You operated upon a 4-year-old child.
Yes, sir.
Okay. To put a scope in a 4-year-old child, what type of scope did you use?
So we used a 2.7 mm scope, sir. Small.
And was the release of the tendon intra-joint or extra-articular?
Sir, it was intra-articular, just before its insertion towards the LT, lesser tuberosity.
Okay, and 2.7 probe?
Yes, sir, 2.7.
Okay.
subscap release also before
Yes.
this?
Yes, sir.
So in comparison to minimally invasive subscap and this arthroscopic subscap release, I mean, what difference do you feel in
So-
terms of time and ease and results?
So minimally invasive subscap release, we have a longer follow-up for the same. Patients have recovered they have a good functional outcome. And but the problem there was they required a longer physiotherapy. Like as sir had previously said, one thing is during the intra-op period itself, 5 to 7 minutes of passive stretching was required. Whereas this procedure, just the immediate release of the subscap intra-articularly, we could obtain the external rotation gain. Also, these right now I have a shorter follow-up, so of 12 months, and series also short. So, but these patients are showing a promising result, sir.
And you release the entire subscap?
No, sir, just the upper half, because further release would hamper the.
Okay.
I want to know about the prefabricated spica you told.
Yes, sir. Sir, the aeroplane splint that we get in the market. Thank you. Thank you, sir.
Next we have Dr. Rujuta ma'am from Wadia Hospital, Mumbai. She will be joining us on Zoom. Please connect.
Can all of you all hear me?
Yes, ma'am, we can hear you.
Thank you. So I've been listening to a lot of the lectures and all that with a lot of interest. I think this is a subject completely close to my heart, pediatric upper limb, and lots of points that I would like to make if permitted after my lecture. But first let's go on with what my brief for today is. And that is really you all wanted a surgical video of radial club hand, but I've chosen to really come across with some slides instead because sometimes it's a very small hand, so it's difficult to shoot a really good video when you do that. So we already know the clinical features of radial club hands, but what I want to point out with these slides is that there is a lot of variation and variety even in the types of radial club hand that we see, and no two grades of radial club hand are really the same. Sometimes in children you may have a different grade in each hand, as you can see in the lower bottom x-rays here. So irrespective of what kind of thing we are kind of faced with, what we have to focus on is to correct the radial deviation, correct the volar subluxation, because that's a very important component of the deformity, and the ulnar bow as well. A lot of attention is shifting to that nowadays because it does have a significant role to play for your recurrence, and for a long term you need to also have to be able to address the limb length discrepancy and then treat the associated anomalies. So it's a multi kind of segment deformity. Ideal protocol, we all know this, and I don't think we should harp much on this. But if we can really start the serial OPDs stretchings like we do for a Ponseti, why can't we do it for radial club hand? So I'll show you some parts of that technique of mine. And then the radialization. These are the ideal times when you should really do all that. Gupta ji, the only place I would want to differ with you on this is policization by 1 year. Best learnt by pediatric orthopedic surgeons, so that we don't have to leave it to our plastic surgery colleagues. It is not that tough a procedure, and we should be able to learn it and pass it on to our next generation as well. So what are the issues when you start with plastering with a small radial club hand? You have a very, very small working space. Sometimes the thumb is entirely missing, hence the first web itself, there is no hold. The forearm is bent like a hemimelia. Unlike in a club foot, it's bent like a hemimelia, remember that? And the child can easily throw off the plaster. The 2-inch POP rolls, if you really try to cut the 4-inch POP into two, are very, very small, and they actually form a constricting band. Hence it is, even the 3-inch POP rolls sometimes are too bulky. So we thought, let's modify, since we have a little less working space, we use Vaseline gauze, multiple layers so that the skin is really well protected. And then we wrap dry cotton gauze over it. And these interlacing fibers cover the skin very well. And then we cut the plaster into small, easy to mold strips. and we retain it up to 21 days. So this was the first case which we did under GA so that, the child wouldn't really bother us. But this is the Vaseline gauzes. And if you really put 2-3 layers over each other, it forms a very nice interface and the skin doesn't get affected. And these are the dry gauzes which we then wrap over the Vaseline mold. And these are the small POP strips that we just cut in different sizes, thin enough to form a finger and easy for you to mold. And some are cut into squares, which you can just place over this and keep on putting small rolls over the same thing and mold it well. That's the first crisscross construct which I lay a lot of emphasis on after reducing the volar subluxation. This is what is going to hold it and preventing it from going back. And then with a simple cotton bandage, just a few layers of plaster, you can easily form a nice thin plaster there. And this is easy to change we are doing it on OPD basis now. In fact, I presented it in the last POSICON and we are shortly writing it up and it's due for submission to one of the journals. So this is a very important technique, particularly of value in syndromic children who have anesthesia issues, who have small birth weight and many other visceral anomalies to battle. And this you do before you move on to your final procedure. This will give you a lot of soft tissue and skin stretching on table. It will make your reduction easy and it really stands in good stead. So let's look now at some of the smaller grades of radial club hand, where basically what you really need to do is just reverse the deforming force so that you have a biomechanical advantage at the wrist. And some grades it may not always be possible because it's a hemimalia, remember, so the ray with all its tendons, nerves, vasculature, everything may be missing. But for lesser grades it is definitely very useful. So we take a very simple, so you can see the thumb is completely absent there, but it's a mild radial club hand. So you take a Z-shaped incision both on the radial as well as ulna aspects. That's your FCR identified, and then transferred over a subcutaneous tunnel to the FCU, that's your recipient muscle, and that itself corrects the deforming force and corrects the deformity. Similarly, you take the ECRL this time because you want to reduce the deviation and transfer it to a subcutaneous tunnel to the ECU. And that's the kind of beautiful result you can get on table. You have actually got a ulnar deviation there. You excise the os flotant, and then by 1 year you can policize this and give them a very good looking hand. Another technique that I pretty much like is distraction when plasters are, the child hasn't come early enough or it's come late in life. Sometimes it's of great value. Of course, there are various apparatuses but for our scenario, I think the Joshi's external stabilization system works very, very well. And how do we do it? What we basically rely on the reduction of carpus by ligamentotaxis, which is suitable both in primary and late presentations. And most importantly, we like it because it preserves the ulnocarpal epiphysis. So as it is, growth is less by 50% in these radial club hands. So whatever little growth you can preserve, it really helps. So what are we using here? Fixator frame is very simple to make. You have a double hole distractor there. These are 1.5 mm K wires. These are 2 mm K wires. These 2 wires are just threaded through the ulna across right to the other side. These 2 wires can be half. The metacarpal wires can be half pins. And you can use something like a reverse couple. So you basically distract along the radial border and either keep this in hold or compress along the ulnar border at the rhythm of 1 mm per day, generally within 4 weeks. This is a frame which is nicely showing you at the end of 4 weeks how well it stretches out and it corrects, and that's still the volar subluxation which you need, you can reduce on table. Later on I'll show you a frame to tackle that as well. Then we proceed with the biloflap radialization as we have done. This is another child, but the thumb is present. But what do you do in that? You basically fashion the radial defect just above the wrist crease. And then you draw the biloflap described by Evans. Flap A and flap B need to be absolutely equal in length and breadth. Flap B consists of the extra redundant skin over the ulna, and flap A is on the dorsum. When this opens up, as you will see shortly in the next pictures, flap A will come and fit into it, and flap B will go into the place of ulna, and this will close by primary intention. So have a look at that there. Fashioned radial defect. Make sure that the median and the FCR, they are lying very close to each other, and the median is often tented. So take that and keep it out of harm's way. After that, you go on to the dorsal aspect, that's your flap A moving into the other side. Expose the ECU, locate the capsule, and open the capsule. There you can see the ulna head as well the carpus very well. The ECU is generally tented over it. This gives you an advantage to refit down and full like as you do a hip close reduction, open reduction. Same way you can really shift the entire carpus onto the ulna there. And that's the kind of beautiful closure that you get. This closes by primary intention. Flap B comes here, flap A goes down. If you have the tendons present, then you transfer them, the FCR to the FCU and ECR to ECU. But grade 4 and 5, which is what this is used for, usually you will not have those tendons there. And that's the kind of beautiful closure that you get. And that's your fixator in some late cases where you even had a bifid thumb. You can use it for a good readjustment. After every 15 days you can do that, but you can still get equally good results. And then this was treated by a bilobe flap. So what are the advantages? It's a very small, light apparatus. It's customizable. Some cases you can just use it unilaterally. It allows you wound inspection, maintain stability, and you can even do the dressing of the bilobe flap successfully. Of course, depending on how you want it, like sometimes some people have used just with a carbon rod there. What are the outcomes? Over a period of time, you see the radial club, angle of radial deviation is really very well corrected. You don't have a unsightly scar like this. It behaves actually much better. It's very aesthetic. And the most beautiful part is since you're retaining the carpus and the ulna growing cartilage, you see how well this hypertrophy is almost as much as the breadth of the radius out there. So that is the best kind of osseous support that you can give to the wrist, and probably that's why it is really, what we have been favoring. Of course, depends on your training and where you've trained. Other procedures are equally valid. You have sometimes a recurrence of the volar subluxation because you're not stabilizing the wrist and creating that arthrodesis, which is what the shaving off of the cartilage does. And then tissues has to be sorted later. But that again, in some cases, I have very happily used with the Jess fixator. Nowadays, I use this kind of a frame for the radial club hand where I treat it like a triangle. So this is the apex of the deformity. This is the base of the deformity. And I drop 2 L rods from either side and kind of first distract along the volar border to pull it out into neutral, and then I go ahead with my fixator. I have Elizaro surgeons fortunately with me, and therefore with them we even do some lengthenings now. I've tried a couple of lengthenings on the Jess, but that's before 8 or 9 years of age. Beyond that, it's always better to use Elizaro, and that's a relatively simple construct and you can get good deformities. Just a quick word about the role of the ulnar osteotomy. There was a lot of debate about it. People have been talking about doing it after 5 years, but then realize it's a nice big bow, so there are multiple apices. So you'll have to treat it like we treat OI and do sheikh kebab or I prefer multiple osteotomies and then thread it with either a K-wire or a small thin rush rod. Nowadays, I've tried to move to the primary osteotomy with the percutaneous technique, and with doing a lot of the plasters, I find that my reductions are easier and I'm getting away with the primary osteotomy along with easy radialization, and I hope to publish that in the coming years. The reason I'm stressing on an early osteotomy is that the bowstring effect of the long tendons, where you have the wrist corrected but the forearm is still a deformity, tends to pull the whole thing back into a recurrence. And unless we know the effect of this primary osteotomies, I think Premal also, one of our colleagues, he also does a primary osteotomy. We hope that we'll reduce the number of surgeries for these children. So this was one of my early osteotomies which I did after 5 years of age, and that's the kind of results. This by no means is an easy deformity. Complications are a rule. You can get scar fibrosis, the flap itself, there's a learning curve, so sometimes it necroses badly. And the fixator also, if you have had multiple attempts at wires or if it gets infected, it can loosen out. And I've actually had some residents even fracturing the radial club hand and, causing a physiolysis. So by no means is this an easy technique, but if with a little practice and a little dedication, I think you can really master it. In some cases where we've had a bad recurrence, nowadays we've also started using a fascia lata graft to retain the deviation. and correction with that. Of course, you have to hitch it to one of the extensors there. But this was a multiply recurred case where there was a loss of the ulnar cartilage here as well. So therefore, we elected to do that. But final message that I'd like to give all of you all is, come what may, I think one should not give up. And we pediatric orthopedic surgeons are pretty much capable of treating any deformity in the body. So why not this? Just a quick word about the regenerate is not always great in radial club hand or congenital hands, basically as much as you would do in the lower limb. So at times it's advisable to go slow or bone graft when you come across these non-unions. And the future, God alone knows what people will come out with. I think right from the 17th century to now, there is still an attempt and it's an unsolved problem. But well, hopefully some of our youngsters, if they take a lot of interest in the pediatric upper limb surgery, they may come up with some good answers in future. And I'm open to questions now.
Ma'am, Dr. Anil Agarwal here.
Anji.
Namaste. Ma'am, I have a query regarding the stiff fingers. Okay.
Yes.
So this entity is frequently accompanied by stiff fingers, and the most common query which is asked to us is the original capability to hold the something between the wrist and the stiff finger. When we correct the deformity, that capacity is lost because now nothing is there to hold. Then it becomes just a cosmetic correction. How do you go about it?
So I counsel the parents right in the beginning, and this is a very important associated anomaly that you've pointed out, that is a camptodactyly. And I tell them with the wrist, within 3 to 4 months, we will correct your fingers as well. So you have to do advancement flaps, or you do multiple Z-plasties, you go down, release the volar plate, at times do a fractional of the FDS also, and try to even open out that stiff finger. Because the commonest bowstring effect will come and the worst recurrences will come in cases where you have camptodactyly along with radial club hand. So if they are counseled well and they accept both the surgeries, then once we have done this, you can actually even use a mini jess for the fingers at times. But if you correct everything, then you can give them a much better outcome rather than just stopping at the wrist. But if parents don't consent, then it is better not to do. If they consent, then I think even if you all find it of value, it may be like a good idea to rotate our residents to a 3 months plastic surgery post so that they can learn those basic flaps. And we can easily do them ourselves, means, we don't really have to wait for them.
Okay. My second query is, ma'am, how frequently do you go for, once the wrist is corrected, how frequently do you go for lengthening? Because the desires never end. Once the wrist is corrected, then they say that the hand length is not equal. And does this lengthening create a effect at the treated wrist? I haven't got any experience with lengthening, so I'm asking you this question.
So I've managed to lengthen about 5 of my original radial club hands after trying my best to demotivate them. It's like unilateral, especially I would counsel them, but I would still try my best to demotivate them for the simple reason that I want the patient to buy the surgery rather than me trying to sell it to them. Because this lengthening does not behave as well as we do for the femur or the tibia. Like I showed in the last case, sometimes the regenerate is really poor. But of the 5, 4 of them have done reasonably well, only that one which I showed that needed a bone grafting. So I tell them that we will need minimum 3 settings of the lengthening, one at 5 years of age if the osteotomy is done and the limb is straight. So ulnar osteotomy is a must before any lengthening. You have to have a well-aligned forearm and wrist. So first sitting will be then, second sitting usually will be at 7 to 9 or between 9 and 11. I try to push it towards 9 and then at 14. So the ones which at 9 years and 14 years, those I take the help of a Elizarov surgeon with the construct that I showed. But the first one is still possible on Jess.
Okay. Ma'am, another question is that there is a description of various wrist stabilization procedure. Some say the centralization is best, some say the ulnarization is best, some say radialization is best. What in your opinion works well for our patients?
For our patients, I think if they come early enough, radialization is good. Ulnarization is it's a very complex procedure. Of course, the thinking is the same. Like we have stopped doing that notchplasty and excising the growing epiphysis and carpus. Same way, I think Pele went into the other side where he completely translocated the ulna to the opposite side. But it's not easy to execute on table. I mean, I have never had success with that. But yeah, the big advantage is since the carpus is intact, you still get some movement. And then Pele is an expert at lengthening those club hands. So they still look a little weird, but they're straighter than before for sure. So, I don't know. I wouldn't indulge in a guess on ulnarization till I've seen very good long-term results from all authors who practice it. So by and large, I think God of radial club hand, Bugramko, he always said, try to do good radialization if you can with tendon transfers. Of course, there's only one surgeon from Finland, Simo Vilki, who does an entire second toe transfer with his metatarsophalangeal joint, and he hitches that to the radius.
They are also doing in Japan, ma'am. They are also doing in Japan.
That's they are also doing, but he was the one who started first, and he had the longest series with great length issues. I mean, without length issues, great long-term follow-up. But that is a microvascular procedure, and if those small vessels, if they get thrombosed, then it's a catastrophe because you've already mutilated the foot as well. So by and large, I think in average hands like mine, radialization has worked so far, and Jess has really aided me to make it easy for me on table. So the whole struggle of really trying to get the carpus, because the problem is not just deviation, it's a subluxation, it's an override, the entire carpus is shifted down. Plus there is a deformity in the ulna physis as well. So this is actually a very, very complex deformity. And
agreed, ma'am. Over to Gaurav.
Yeah.
Yes. Thank you, ma'am. I also have one question. It's great to connect with you today, and thank you for giving us so much clarity on radial club hand. So my question is, many a times we see that the thumb is absent and the index finger is in camptodactyly, as sir said. In those cases, how you take your decision regarding policization? I mean, do you transfer that index finger or?
So policization again is the investment on the surgeon's part has to be in the counseling. A camptodactylus finger is not going to give you an ideal tip-to-tip pinch. But the good part is it's already there. Some of the bend is already there. So even if you get tip to side, that is also good enough for them. But policization has its own kind of worries in terms of the size of the vessel and all that. So what we do nowadays is that we take help of another similarly trained orthopedic surgeon, and we use loops on table. And we start with the dissection of the neurovascular bundle first. If it is found to be kinking, or if it's found too thin and it's likely to be overstretched or thrombosed, then I have always counseled each and every patient and actually taken a special consent that I will abandon the procedure rather than go ahead and jeopardize the vasculature. But if all that is fine and things go well, even some semblance of a thumb which comes in early is better for the mental cortical adaptation rather than having to, kind of them persist with the chopstick action, because they just can't get over it. Beyond the age of, there are people who do it at 4 and 5 and all also, but I think beyond 3, very, very difficult for a child to unlearn what he has already learnt. If he starts doing this, then he's never going to really oppose and come this way. But if that works well, if the camptodactylus finger works well and it has got policized, then in future you can add an ADM transfer to give him an additional apposition.
Thank you, ma'am. Thank you.
Good evening, ma'am. Thank you for the wonderful lecture. I just have a small, simple question. We all know that the path of the median nerve is very aberrant in this radial club hand. So there are no safe zones as per se. What do we have in normal hands? So how do you take care of that while putting the fixator? So
the fixator goes into the bone, okay?
Yes.
Really, you are going much below.
So
you're going pretty much proximal on the forearm.
Okay.
And here you're going in the metacarpals.
So
your median nerve is going to be tented over this aspect. It's going to be more radial in lie rather than more ulnar in lie.
So we are putting a through and through pin through the ulna in the proximal.
So here, that's you're going right there. So that if you're going by a strict bony field, you're unlikely to injure it.
Okay.
Here you have all nice thick musculature protecting it. If you're going to go here, which is not indicated here, then yes, I can understand your worry.
Okay, so you are taking it out dorsally by entering it through the ulna. From the ulnar aspect, we are entering it.
Yeah, so entering percutaneous, and then you're going very much proximal on the forearm. Na?
Okay.
Another query, ma'am. How long, till what age will you try the plasters?
I've done them almost up to 3 to 5 years now in some of them. It's not at all, the claim is not that it works like a Ponseti and you won't need anything, just a percutaneous stenotomy. That doesn't happen. It's more like a Matthew Dobbs technique where you're using it as an aid to give you a easier reduction on table. And then you stop when the fifth metacarpal aligns with the ulna. So as long as you get a collinear axis, you stop then and then take it immediately on table for your radialization. So maneuvering your carpus intra becomes much esier.
How frequently do you change the plasters? Weekly?
21 days.
Okay.
So not 21 days, so that's good enough for them, to, and almost 3 to 4 plasters, not more than 5 plasters.
And
because the goal is very clear that it is only a prequel. It's not the final destination.
Okay. Do you do them under GA or now only
on?
No,
now I've stopped under GA. Now doing totally OPD basis. Only some children, if they are really cranky, then you give pedicloral. So that is what, again, it is helping. Such a lot of them have cardiac issues, they have renal issues. So much better to have an OPD based technique.
Good afternoon, madam. Abhishek here, ma'am.
Yeah, hi, Abhishek.
Ma'am, technically I am also using the same technique which you are using the external fixator and the JES for my radial club hand. Any, ma'am, superiority of our older techniques like putting a trans K wire or something, or why we haven't abandoned them, or we can go to Elizarov's also. Any difference, like any papers?
No. See, I think that is like a saying that will you drive a Maruti or will you drive a Skoda or will you drive a Mercedes? We don't want to compare and rate each of the fixators. Each of them has a value. India has a unique advantage that we have the JES available with us, which is lightweight, which is customizable. JES again is a method of distracting to aid your radialization or ulnarization, whatever you want to do as the main definitive surgical procedure on table. Once you get that, once you get your reduction, you will use your K-wire anyway to hold the reduction. It is only in the very supple sort of radial club hands where there are no camptodactylous fingers, where the deformity is not rigid, that you can think of just using JES and then passing a K-wire. But I am yet to have a good result or any other person's paper also where I have seen that just with doing JES and K-wire, you get good long-term results. Unless you open the joint, it's like DDH. You can use scopes, you can use, many ways of doing this. But eventually, finally, you have to open that joint and reduce
and then.
So if we are reducing hips, why are we not reducing the radiocarpal joint properly? Why are we not, reducing the shoulder joint properly? So in fact, I had a few things to point out in the arthroscopic release, but anyhow, I think we'll stick to this discussion for now. I hope
Elizarov, ma'am, any experience with Elizarov, use of Elizarov or like small?
So not me. I told you I use them for lengthening with my Elizarov colleagues. But a forearm which is barely 3 or 4 centimeters in length,
it's
in a
difficult
baby, I doubt even the Elizarov surgeons would put apparatus on that.
That's exactly what I thought.
It has a place. In India, you still get such a lot of late, presenting radial club hands, and if somebody's trained like Gupta ji and all in Eliza Rao, then why not? That is their fixator, this is mine.
Sure, ma'am. Thank you.
Any more questions? So we are very lucky to have you with us, ma'am, today, and thank you so much for joining us. And thank you.
I enjoyed listening to a lot of the talks in the morning session also.
That is why I had sent you the YouTube link, not for connecting. Okay. Thank you, ma'am. Yeah. Thank you so much.
Thank you.
So we'll osteotomy के लिए I don't think. So we'll move on to the next session, which is the distal humerus osteotomies workshop, and please give us a couple of minutes to make the arrangement.
Hello, check. Hello.
हाँ, ठीक है. Yeah, now it's working. So now we are fine with the recon plate and everything. That's okay. Students need to come down. We'll just get them to work. Yes. I think everybody can come down here. We can have a discussion also, because there are multiple techniques for correction of the deformity. So join with Sudhanshu, yeah, and Pratik is here. Okay, so first question, what is this deformity? Why it is cubitus varus? Because?
So it's a plain deformity and...
Take the mic. So we'll go for a revision of the lecture also. We had you have already been taught this in the morning session. We'll see how much you have picked up. Yeah. So what will you do first? You get a patient like this, what is the first thing you will do in this case? What's the first thing, or what is the first investigation, or what is the first thing you will ask the patient for? Both limb alignment, very important thing. I'll come to that, I'll tell you my thing. Okay, any other thing which you would ask? First, let's start with the history. What are you going to do? So, which fracture are we suspecting in this? Why not lateral condyle? What is the deformity in lateral condyle? Valgus deformity. Okay, that's fine. What else will you look for?
Plane of deformities.
Plane of deformity?
What the patient wants, like why is the patient presenting to you, whether the patient has a cosmetic deformity or whether there is any functional limitation that the patient
What
has.
functional limitation are we looking at?
Like
And there is some other. Okay. Do you get laxity in this? Hyperlaxity? You do get hyperlaxity in this. Okay, so you have to take that into account also. Okay. Second thing is regarding the age. Anything specific about the age when you should correct this? Suppose you had this child tells that I have had a supracondylar fracture 6 months back. Will you operate that case? Why not?
Wait for remodeling.
Wait for remodeling. Till what time? What's the present timeline for this?
We usually wait for 1.5 years.
1 to 1.5 years. We normally, it's safer to be on 1.5 years side, but it can be done after 1 year according to the publications, like the recent these things. Any other precaution you need to take care of, or anything else which you would like to know?
Neurological involvement.
Exactly. Which nerve gets affected in this? Which nerve?
Ulnar.
Tardy ulnar nerve happens in which one? It happens in the valgus. Okay. And what about this one? Any nerve gets involved over here, or you need to? AIN might get involved in that. So it's very rare. Okay. Second thing, any other detail which you need to ask the patient, or you need to see in the X-ray. Very rare thing, but still you need to know this.
History of massage, myositis, any like.
Myositis is one point, definitely. But by 1 year, when you are, you're going correcting it, mostly will get resolved by that time. Okay. Any other thing? Yes, that is another important thing. And one more thing, we have been talking so much about syndromes and everything, just because there is a history of trauma. And as you know, these children who have varus, they will end up, I have had patients of mine who have ended up with a lateral condyle, with a proper supracondylar after fall. So check for any fresh injury or any lateral condyle component is there. A lot of the time they will just snap their lateral condyle and it will be there. Okay, so you need to be careful about that. Okay. So you have seen the patient, you know the history, you have seen there is no neurological deficit. Okay, next what do? You immediately start planning for the surgery, or you take any other detail on that? Anything else which you need to know? One very small point, okay. I normally do it during my surgeries. I always take care of that. Less important, neglected by a lot of people, because most of the time it's not that much important. You have to check the ROM for the opposite limb and take a note of the carrying angle of that side. Okay, because in this case you have rotational deformity as well, and that, so you have to have a proper idea about the opposite side, that how the deformity, like how much is the movement and everything. Okay, fine. So now I think it's high time. We as surgeons, we should start planning something to give this child a proper, most of the thing cosmetic, but definitely a proper functional limb and that. So how will you proceed? Anyone? Gentlemen?
Bilateral full limb X-rays.
Yeah, that's the thing before. That's the most important thing in your armamentarium. I prefer to keep the other hand also exposed during the surgery. That's the way in which I go for it. It's highly variable, but normally we expect that when you have the other limb in front of you, you're always having a visual thing that, no, I need to correct. And obviously there's a huge carrying angle difference between a male and a female. So a lot of the time you end up over-correcting it, as well as sometimes the laxity and everything. In that case, the correction should be a little bit more, because with the laxity, it will again come back to the little bit lesser correction than what you have already achieved on the operating table. ठीक है? Okay. Someone please come over here. Okay. Pratik, we can keep it there. Okay. So you have the patient on the table now. Okay. Position of the patient. Supine, lateral, flexed, lateral. Why not lateral? Why not lateral like this? Exactly. That's the correct answer. Best possible is the you know, like what my boss used to do is keep it in the prone position. He used to tell that we get to see the alignment, and most of the time we try to put the plate in the posterior direction. We try not to putting it along the lateral side. I have done it a few times, but the prominence makes it look like a little bit of pseudo, you know, correction looks not that good, and that disappears with this. Okay, so you want the patient in the supine position, right? Okay, okay. Now next, what do you do? Lateral approach or posterior approach? Or posterolateral approach? Posterolateral. Why posterolateral?
Does your approach vary with
Get a mic and that.
Your approach vary with the type of osteotomy you want to do?
Yes.
So for what kind of osteotomy you would want to do approaches? What approach to do?
Lateral closing wedge oblique osteotomy, lateral approach.
Yeah. Dome is the most like the advice thing nowadays. There's nothing called absolute, like, you know, a foolproof technique is not there. It, you know, like changes with time, horses for courses. But what we have the closing wedge osteotomy, which used to be the workhorse few years back. Then you have seen that wedge technique which was there. We have seen that. That's what I normally use nowadays. And you have the dome also, and that. One more thing I'd like to point out, because you people belong to the YouTube generation and everything, and I think there were a lot of like pictures of complication which were present in the lecture. You have seen how devastating the use of K-wires in this deformity can be. I think that is what we could make out in this. So remember one thing, it's always preferable to fix it with a plate. That is one thing which I would like to stress repeatedly. I think it was very evident from the complications which went to cubitus varus that you should be using a plate for this, like for the correction of this surgery. Okay. Okay. So how do you measure the angle of the wedge? And that over there, take it. You can just use this to just draw, like, you know, tell us how you will draw the lines, and then.
So along the long axis of the
Yeah.
Then along the long axis of the ulnar.
Yeah.
The angle which is made
between these two, and you have to draw another, draw a line across the joint over here, and from there measure. Then where will you use the angle for that? To the wedge, the wedge and that over there. Okay. And what about the other triangular wedge which you learnt? How do you measure that? Closing wedge has been there for, like, has been the main thing. The only problem is if there is not a proper shifting of the joint, it will create a pseudo, like, varus, or even though you have corrected the deformity, still you will end up with a appearance that it has not been corrected, or it is technically in cubitus rectus, which is in a straight alignment. Okay, so it has happened to all of us in our surgeries, and that. If it's a male, you are forgiven, but a female who have larger carrying angle, you are in deep trouble, because it's a cosmetic thing and the parents won't accept that. Child will not accept that for that. Okay. So what we should do? We'll doing the wedge thing, or we'll go for this? Which one do you want? Wedge, closing wedge. You want to start with closing wedge. Okay. So since we don't have, yeah, this one and that, yeah, that's good. So be careful when you, we've got a thicker thing over here. Okay. So there was a mention about the where the K-wire is. Come. You people are supposed to handle this. We have been using it for 15 years. Come this side. You're from this is the lateral side, right? Okay. Be careful. Okay. It's thicker K-wire. So where will you put the first this thing, K-wire? It was mentioned in the lecture. Anyone? Anyone who knows how to, anyone knows who can,
Parallel to the joint line.
Okay. Come here. Come here. Not so this thing, it will be in the metaphyseal area. Okay. Yeah, it should be, how much was the distance which was mentioned? 1 centimeter or 2 centimeter? Huh? Around 2 is the safer thing, and that. You should not go to the medial cortex. Why? Why you should not go to the medial side? Take the wire out. Allah. That's fine. Good. Next, what do you do after putting the wire?
Correcting wedge.
Have you put it in the right direction? How will you confirm that? You have to take a CM shot for that, right? Okay, you have to see it in CM. There's no other way of, doing it. This is a perfect thing. You have to see it on the CM. Okay, once you have introduced it, rather the best thing is when you are introducing it, that time you need to be sure that it is going in the right direction. You cannot go for a repeated radiation exposure to a adolescent child or with deformity. Lesser the better. Okay. Now, next, which direction will this wedge be? The K-wire will be.
This is coming distal to your osteotomy site, right?
Okay.
And this is parallel to more or less parallel to the joint line. Second wire. So
we'll measure it with a
goniometer, and then you can end that over there. Yeah. You introduce it. We don't have a reference other side cubitus varus, so you can, we just need to know the technique over here. There's nothing like.
I would do is, if there is no reference, then I would put a wire perpendicular to the shaft of humerus.
Go a little bit more distal. Yeah.
So that you have working space in between those wires.
Because your saw will cut from this direction. You will not be cutting from this direction. Okay.
You're doing more. You won't be able to take this much of a wedge, right? You have to try to be perpendicular to the shaft.
It's good to keep the medial, that periosteal hinge little bit intact, because the healing and that should not be possible. Little bit on the higher side, but it's okay. Yeah. Okay.
So now you have made 2 of your reference wires, right? And now suppose at this stage you want to correct the rotational component
That over there. So at this stage, what will you do for correcting the rotational this thing? How will you assess that?
With the K-wire, if I want to increase the internal rotation, put the...
Anything with the direction of the K-wire which you introduced?
So
there was a technique called the French osteotomy. Do you remember? Anyone remembers that? Yes. What is the French osteotomy? It's an outdated technique. We don't use it anymore, but... And we use K-wires for the fixation, or we use something else for French osteotomy? K-wires and that. And screws? 2 screws and then, wire, and that corrects the rotational component. Same over here. We have to introduce the, the wire like that, and then correct the rotation accordingly. Okay. So in this case, if both the K-wires are in the same plane, you will not get any rotational correction. Okay. Okay. Next, what are you going to do? If we have that wedge over there, the template that we say, you're supposed to place the template and then go with the K-wire over there. That's the thing that you need to do, first of all. Okay.
Template is made
Template is made from the X-ray. and that true size X-ray. You have to see the true.
Do you mark it like with a pen or something on the
Yeah,
leg,
we have a stencil and that. We normally in the X-ray we normally make a marking and then we take the measurement from there, and then it's a lot of people have a habit of making it into a plastic thing, then sterilizing it, and then on the table. One of my colleagues has that habit of putting it over there and then cutting it. But it's very cumbersome and it does not work like that. You have to, you know, gradually over time, like what has happened to us, we don't even measure all the angles and everything now. We can just, you know, with our practice and everything, we can directly go for introduction, rotation, everything gets auto-corrected by itself. And if there is a mild difference in that over there, you can always, you know, toggle your hand and while fixation.
Even in the template, there's no rotational component that you're seeing. It's a 2D thing.
No,
So
exactly. That's the reason why I never trained on the template. There are other people who have trained on that. Rotational component is always more about, you know, the other side, the rotation and that. And what was mentioned over here was once you cut the wedge, you stabilize it with wires and then you check the movement.
I have another question. How do you assess how much rotation is to be given? Because everything that we are doing from the patient has come, the X-rays, everything is 2D. There's no 3D, we never do a CT for a cubitus varus, nothing. How do you make that decision? How much rotation? Like is it just clinically that
clinically
you see
we have to, clinically we should be able to see that, as well as I think something like, I normally prefer not doing a CT in a younger child for obvious reasons, because a CT is equal to how many X-rays? 625. You are exposing a child to 625 X-rays means you are doing some damage to that. And okay, so the issue is CT gives you a very good 3D reconstruction, CT guided that, or if you have a good MRI center like what I have at my place.
Like you very experienced, but we are going to start our practice. So should we go into the rotational correction, or should we leave it and only correct it in 2 planes and leave it?
We are teaching you the closing wedge technique because of that only, because the dome and the other things are a little bit higher level than that over there. Okay. Okay. So should we start? Anything else now? We have to cut or we will do something else? And that. Any nerve we need to protect, or we need to, any other step we need to go for this? No, nothing. Okay, take the saw. So where will you cut? From here or from this side?
This side.
Yeah. Okay, hold. Okay. Cut from this. So what Dr. Pratik was also saying, it was very, whatever angle you have to place the guide wires at a more further distance, because the saw will take some part of that, a few mm from your guide. Okay, that's fine. So the angle has to be perfect. Okay, what we have over here is in which what we do, if suppose if our cuts go like this, so backup plan, right? Okay, if you like, you people are young, these things will happen all the time. Okay, so what you need to do over here now, not a good technique, nothing mentioned over there. If you are seeing that there is something over here which is not exactly up to the mark and that over there, one thing is definitely you can again go for a remarking and you could saw that thing. Other way around is you can always start nibbling or taking some part of the bone from here. Okay, be careful not to break it, and that most of the time a little bit of 5 or 10 degrees of difference does not make much of this thing, and always adjust it with the amount of compression and that. This is working knowledge, this is not mentioned in the textbook. Okay, so what do you want to do? You want to progress to the cutting, or you want to do and that? Okay, you can nibble and that over there. You can introduce the saw over here and just close it up and that. Okay. Regarding the saw direction, any precaution you need to take? You're very close to the medial side. So the thing is that the saw should not, you should not use your saw over there. Okay, okay. That complete with an osteotome. Preferably, what I do, not mention the textbook, we nibble out. We have a look at a, a small time if the bone is there, that is intact, means the medial is intact, you are not anywhere near to the ulnar nerve and that, okay? Like a hinge and that. And if the medial hinge, this is anyhow a metaphyseal osteotomy which you are doing, it is going to unite whether you keep a medial hinge or you don't keep a medial hinge. Only thing is, you need to fix it with a plate, not fix it with a K-wire. Okay? So, anything is there for holding and that? You can apply the saw over here. We don't have any nerve over here. We can, right? Okay. Only thing is you need to remember. Okay. Okay. Yeah. Yeah. Okay. Now coming to the problems. Do you see the incongruity of the surfaces over here? Large and small. So what do you need to do now for this? How will you, compensate for this?
Usually there's a problem of a lateral bump.
Yeah. So you need to, yeah, distal part and that over there. So that is the problem why the wedge technique has fallen out of favor, because the lateral bump or the lateral thing always gives a, you have corrected your angle, everything is fine in X-ray, but it looks like that there is still a little bit of residual varus over there. Okay, and this is a cosmetic surgery most of the time. We do have functional thing, but you have to get the carrying angle as simple, like as same as the other side. That's the main target of this operation. Okay. So which side will you shift? You will be lateralized. Okay. Yeah. Thoda this side. Yeah, that's it. Okay. Okay. You can take this out. We don't have much K-wires. You can just take it out from there, and then we can introduce it to hold the fracture. If you are doing it in an adolescent or adult patient, which is the other deformity, secondary deformity which happens after this type of correction, which is also a cause of concern because that's a cosmetic deformity. It does not cause any functional problem. It happens mainly in a little bit like older people, adolescent and that over there, which you need to know about this. Something starting from here to here. Huh? Shorting is not an issue most of the time. There is an S-shaped deformity which happens a lot of the time. It's cause of concern. Okay. We have had it also. So that happens a little bit in the adult age group or the older age group. So that also is something which you need to counsel the patients about. Okay, this might happen, or there may be residual thing. They are happy with the angle coming outside. This is anytime better than a little bit of curve over here. And this is mostly hidden by the shirt or the garments and everything. So they are not worried about that. Okay, you can take this out as well. You can fix the osteotomy. How many have performed this surgery before? We are giving you a very basic actually, and that. Anyone who has performed this surgery with cubitus varus, you have performed before? Which one did you do? The same lateral wedge closing and that over there. Anyone experienced in French? I think French must have fallen out of fashion after when I was a student, it was still in vogue. Sure, someone can hold this thing, and anyone holding it has to hold it in the right position. Okay. So we have a dome technique. We have a French osteotomy, a wedge which is gradually, falling out of fashion, and we have the other wedge technique and that. Okay. Will it be possible? No. Difficult. No. Get me the K-wire and that. Let's see if we can fix it.
That's the problem and that over there. ठीक है, we'll go a little bit cross कर देंगे and that. Actually, this is the right position, okay, because that will not interfere. It will not interfere with your plate placement, okay. Come out? Yeah. Is that the right direction of the K-wire? Why no? It's come out a little bit posterior, right? No, it's relatively, it should be a little bit more anterior there. You can load the other wire over there. Take it, that's fine. Where will you place this thing? Cross? Okay, put it from that direction. Someone hold the humerus? Yeah. Yeah, to that side. Just hold it like this. Yeah. Go a little bit anterior. First go straight, yeah, and then go. So in supracondylar fixation, what is your preferred fracture I'm talking about? What is your preferred wire configuration? You are using 3 divergent pins or some other technique? Two lateral and 1 medial. You all people are using medial pins now? Should it be routine? If you dissect it properly, okay. So that's one fear which you people need to overcome. That's what I will tell you. Because most of the time, cubitus varus post-fixation or everything, it happens because someone has not put a medial pin. There are certain things in which the medial, this part gets compressed, and that is not diagnosed. So we have this thing, okay. हाँ ठीक है, that's fine, and that over. This is anyhow a bone saw model, okay. Fine. So now what will you do? We have kind of a correction. So at this point, hold it with a clamp, check the movement, check the rotation, okay. And I think sir was mentioning something about a 3-point, it's cubitus varus and that. If the deformity has happened, what will happen? Disturbed, then what you need to, yeah, then what you need to counsel the parents about. If it's an old, say, patient is coming after 5 or 6 years, 7 years after near to skeletal maturity, what are you going to do? In those patients, the arc of rotation is already altered in a bad way. So you have to counsel the patients that even after correction of like the deformity and everything, there might be a residual range of motion impairment, which might get corrected or may not get corrected. As well as you might have certain conditions in which a little bit of FFD and all those things will be like there. And other than that, what you need to know is even after implant removal, you can tell them that during implant removal, we can think about getting a little bit of movement and that. But it happens. If that permanent deformity, because that is a deformity which has already happened at the olecranon and the ulna and that, and there's nothing much you can do provided you don't do another corrective osteotomy along with that. Okay, the next and the most important thing, which you need good trained assistants also, is the contouring of the plate. Okay, so we have a lot of plates over here. I think those, straight plate. No, those are not the plate used here. What plates are those? Anyone? Achha. They are acetabulum plates. Okay, yeah. So how will you contour? So we have something called a plate template over here, which is, we have something called something like, I don't know whether you know this thin thing which you can always contour. That's what I use. Okay, we put a contour over here. Okay, exactly same thing. Okay,
and then you can just bend it over there. So anyone wants to attempt that, or we will? Benders are there, or if it's not there? Okay. So anyone strong enough to bend a recon plate with their hand? You all are orthopedic surgeon, right? Okay. Yeah, it will be more of a contour like this, posterior. Should I help? Can someone hold the model? I'll just help Dr. Pratik. Oh, he has already bent it. He's already, But that's a little bit larger plate. Okay. So same principle, we need to have 3 cortexes this side as well as, 2 or 3 purchases on that side. That's the same thing that we need to do. Preferably, which side? I told you something in the beginning. It should be a little bit in this direction, the posterior way, little bit like this. The bend has to be reduced a bit. Things there, less than that over there. So bone model, no? So we have. I think a little bit lesser will help. Yeah, that should be good. Okay. So we roughly have this thing. Rotational things can also need to be taken into consideration for that. Most of the time, it's an internal rotation. So we have to, when we do it from this direction, it's mostly in this direction that you have to correct. This is I'm telling with your experience and that little bit of angulation in this direction. Okay. Okay. So. I have had cases in which I have seeing the seniors and whatever is more available in the YouTube and that. Okay, I know the reason for the disasters happening. The issue is that most of the time we have put K wires and it has not united also. That has also happened and must have happened to a lot of people also. Okay, so then you're already creating trouble for the patient, and then if you're operating again, you're putting in a plate and that, so you're basically inducing more trauma, more stiffness, all those issues. Okay, ठीक है. Drill and that, I think we can just finish off with putting 2 screws and then. Another important thing is when you are, this part needs to be kept exposed. Okay. Ideal thing is to put a spike over here and to keep it retracted. My advice would be not to do it. Why? Give me 2 reasons. There are 3 reasons actually. I'll tell you the third one is. One is very simple. One is the ulnar nerve. You are putting the ulnar nerve at risk. Second one. When you push it, it will come in this direction and that over there. So wedge osteotomy, preferably not to put spike. Make your assistant work. Okay, ask him to hold the Langen back and that over there. But you have to technically try, resist the temptation of putting a lateral spike, which makes your work easier. But at the end of the day, you might fix the plate and see that correction has reduced to a certain extent. And wedge is very notorious for that. That's why we, the closing wedge. The other wedge we have shifted to that because of that. Okay. Okay, you want to fix it? Someone hold him, something is there for holding. Another question, locking screw or normal screw? Which one? Cortical or locking screw? Why cortical screw? Why locking screw? Which holds better, locking or cortical? which keeps the plate flush. You have treated fractures, no? Cortical should be also, it's very common, this thing. Cortical should be put first, okay? Take measurement and everything. Something in the range of 24, 26, something like that. So you realize the importance of assistant in this, okay? The plate moved a little bit and he had problem in this thing. So you need to have properly trained, at least 2 people should be with you during this surgery. And 1 person should be dedicatedly given the task of maintaining the rotation. He should not be told to, hold the plate, get the instrument and that over there. So this is what we tell you from experience, okay? And when you introduce the K-wires, your direction, the way in which the K-wires were introduced should not interfere with the plate placement. That comes with experience. That is something which will not stress. It comes with experience that most of the time, initial days also, our K-wires also used to come in way of the plate, then we have to again remove it, then we have to, it happens. Let me see. Take it, it's fine. It's a bone saw models always have issue. Okay. Now coming to the screw over here. Now tell me, cortical screw here or some other pattern of screw? Cancellous screw. What will happen if you put a cortical screw there? Yeah, that is so there is not the ideal screw for the metaphyseal region. Anything else? What did the cortical screw do here? The plate was, you remember the plate was a little bit off? It goes flush. So if you put a cortical screw over there, whatever rotation you are holding it, it will rotate and it will come, it will pull itself towards it and that over there. Okay. So see if we have a cancellous screw there. That's a partially threaded one. Locking cancellous. Okay, we'll make do with a locking cancellous. You can take the locking screw and okay. Ideally you should, use just a normal cancellous screw, not the locking one. Okay. Okay. Another important thing over here, very common mistake, is you should see how far you are away from the olecranon fossa. A lot of the time the screws, because the direction and everything, it might go to the olecranon fossa, and then after the surgery you will see that the movement is either restricted. So even if you have a hint of doubt after the surgery that something, how do you understand the screw is is in the olecranon fossa and that? X-ray is okay. X-ray your screw is fine. Any idea? Someone must have had some in learning days some screw in the joint or something like that. Happens all the time with distal radius. It goes into the DRUJ. Huh? First of all, if it is just penetrating out, you will get a full range of motion on table. That's the most confusing part of it. You will get a little bit of crepitus or a little bit of jump at that point. So you have to be very careful in that. Okay. Okay. Drill. So our K-wire placement, though not in the ideal position, has been so good that we need not take it out. Okay. And in these cases, you need not worry about a very stable kind of fixation in that, because you are mostly operating on a child. If you give, not absolute, if you give stability strong enough, because people were treating it with K-wires, which was relative stability, right? Okay. Happens with bones all the time. So that's okay. If only we had this type of bones, right? Huh? Rotation. Yeah, it was through here. Yeah, now it's okay. Wait. You have gone to the olecranon fossa itself. So to drill somewhere over here. Try to drill it. We'll just put one screw and we'll finish it off. So I was mentioning that don't go through the olecranon fossa, and he has drilled through the olecranon fossa. Here you can come out anteriorly, lateral side. Which nerve is in risk if you come out too much anterior? Most of the time it's not damaged. We have never damaged it, but which is anterior here on the radial side? Radial nerve. 20. So we got the right thing, not exactly the right thing. It should not have been a locking, this thing. In pediatric bones, what screw should you prefer? The locking screws, the locking plates, or this thing? Which is the better, the idea? Cortical or locking? General, I'm not talking about the osteotomy, I'm talking about the general thing. Should you use more of locking screw, or should you prefer using cortical screws? Also that, and they become so rigid because the bone is growing, it will break. It breaks. Okay. That's fine. Okay. Fine. So this is roughly the fixation. So you have to put some screws over here. This part should be contoured to the condyle. Okay. So this is again, we know from the mistake, this should be bent in the downward direction. Don't worry about this thing remaining a little bit proud or that. It should be totally flush. That's the correct way to do it. But triceps being a huge muscle, even if you put a little bit of something protruding.
In pediatric patients, we say that we are crossing the physis with the wire is okay, but if we are doing it with a screw, it will damage it. The plate will come somewhere near the physis. So how are we going to prevent?
That is exactly what I'm telling you. No? The plate has to be bent and then bent, and then you have to avoid the physis. Pre-contoured plates are not used in corrective osteotomies. They are for adults. They're only for adults. Never use a contoured plate for the children. First of all, they will not fit, and second, they're not designed for this operation. Okay, you have to work hard. You have to contour it. Okay, so what we see over here is technically a decent kind of fixation. Little bit more of a lateral shift would have been okay. The wedge should have been closed over here. Okay, and the only difference with the wedge is that we have to put, if it's a huge deformity, the wedge that we create over here, in case of wedge osteotomy, this has to go inside the wedge over there.
If our wedge is somewhat asymmetrical and something like this happens, should we use that graft that we took out and put it, or should we avoid it for any bump or something that might?
With the other apex-like thing and that over the wedge, no, the bump does not happen most of the time. We're putting it in the right direction, and that preferable not to put any graft and that over there.
We had 2 or 3 patients in which we had put that part, and then in the post-op we saw that lateral bump was more evident.
Exactly, because the child's bone is programmed to produce more bone than what is needed. So invariably, when we are putting extra, bone grafting is rarely needed in children, except for few conditions. Some other thing, some unsolved mystery of pediatric orthopedics, lower limb, where we pack it with graft. CPT. Okay, good. Okay, and Any nerve transposition with this? Which one do you do a nerve transposition? Valgus you have to do. Valgus you have to do a nerve. Preferably, it's preferable if a lot of the time the ulnar nerve is already in a safe place, so not to disturb that. Okay, any more questions?
Sir, what do you do routinely for this?
I do sometimes if the deformity is not that pronounced, this is good enough. But a lot of the time the deformity is quite severe, adolescent patients where the remodeling potential is not that good. We go for the wedge kind of.
Sir, for dome, how we cut that
Dome, I don't use it, first of all, because I've not been trained and I've not been in. Dome has had a little bit of like share of its complications, nerve injury, like this. You can see the recent papers and that. So that's another reason why I did not shift over to Dome, and I'm comfortable doing this. So, and it has given me good results. But
during dome, the problem that we were having is the contouring of that thing.
exactly,
So in
it's a
3D you cannot
3D. You cannot
nothing that cuts in 3D.
3D and that over there. So it comes with, you know, when you have trained, like we can do a dome over here also. Like you have to have a good nibbler. You need to have a little bit of curate or something like that. You can always get it done and that. But main problem with dome is that you are here already. We have a sharp edge. We have done a lateral shift, so the ulnar nerve is relatively protected. But in dome, you will always have some sharp edge over there, which will be fitting over there and that. So that's a cause of concern. But you should learn dome. That's what I feel like, the dome osteotomy and that is a preferable way and that. So the other thing, I think the workshop was there, cubitus valgus also, we have a similar kind of thing only.
Sir, when to choose between reverse step cut or step cut?
Like how to make a decision which osteotomy, or should it be like surgeon's preference?
It's just such, yeah, that's what we all, at least you people are young, you should, you know, learn first one technique and then over years you should gradually shift over to the other things which you might want to try. Achha, cubitus the valgus thing, the only thing you need to know is here at least the X-ray is looking a little bit pretty. This will be a little bit better X-ray. But in cubitus valgus, the X-rays, you should not go after the X-ray. They are not good. They don't look good. Okay, you have to totally rotate the thing. Okay, so more of this thing. And if you have a lateral condyle non-union, I think it was mentioned in the lecture also that you can leave it alone. Or if you have a younger child, then you can attempt again putting a wedge over there and then putting a screw over there and try to correct it over there. Okay. Okay. Rest of the complex things like rotational multiple axial associated with shaft, associated with a missed Montagia. Okay. These things are, I think, beyond your level. So once you graduate on this, then you should try cubitus varus with a missed Montagia, or cubitus varus or cubitus valgus with a non-union of lateral condyle. That's the way to go forward. Okay? Okay. Thank you. Thank you. Thank you.
Just a radial head fracture. Yeah, 5 years old. That close reduction. Just close reduction.